Hello, 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 hello.
Bismillahirrahmanirrahim.
Assalamu alaikum, everybody. We'll be shortly starting in a few minutes. We're waiting for a few speakers at the moment. So please bear with us for a few more moments. Inshallah, we'll be starting soon. Thank you. Bismillahirrahmanirrahim. Honorable Chief Guests, distinguished speakers and participants, ladies and gentlemen, Assalamu alaikum. I, Dr. Hajra Rana, and my fellow host, Dr. Munawwardeen Larik, working with the Department of Oral and Maxillofacial Surgery at the Shaheed Mohatarma Benazir Bhutto Institute of Trauma, welcome you all to the first Pak Traumacon 2020 organized by the Shaheed Mohatarma Benazir Bhutto Institute of Trauma. We would like to start the session with the recitation of the Holy Quran. I'd like to call Dr. Shahid Jamil Awan for tilawat. Please, Dr. Shahid.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والتين والزيتون وطور سينين وهذا البلد الأمين لقد خلقنا الإنسان في أحسن تقويم ثم رددناه أسفل سافلين إلا الذين آمنوا وعملوا الصالحات فلهم أجر غير ممنون فما يكذبك بعد بالدين أليس الله بأحكم الحاكمين صدق الله العظيم.
Thank you, Dr. Shahid. I would like to take the opportunity to thank our guest of honor, Dr. Mansoor Ahmed, consultant oral surgeon at Aga Khan University Hospital, to grace us with his presence. Thank you so much, sir, for coming.
This is the first traumatology conference to be held ever in the history of Pakistan, and the theme is Trauma Care Challenges, the Way Forward in a Digital Era. Our session today is on the facial and neck trauma, and we have invited speakers to talk on the various aspects of the facial and neck trauma. Before we proceed further on, I would like to invite Professor Shahjan Katpar, the head of Department of Oral and Maxillofacial Surgery at Dow University of Health Sciences and Shaheed Mohatarma Benazir Bhutto Institute of Trauma, and former Dean of the Faculty of Dentistry and Chairman Board, Dow University of Health Sciences, to please come up on the stage and say a few words, sir.
Thank you so much. It's a proud moment for me and for my team, and for the specialty at the same time. We are coming after a very long journey, and I'm heartened to see Dr. Mansoor Ahmed, known as the greatest wonderful Tony Bhai to all of us. जब मैंने ग्रेजुएशन की तो मुझे मौका मिला इनके साथ कुछ अर्सा काम करने का at his private clinic. And he's a great source of inspiration for the young ones, including myself. बहुत कुछ सीखा इनसे, जनरल डेंटिस्ट्री सीखी, थोड़ी बहुत ओरल सर्जरी सीखी, and then I wanted to pursue my post-graduation at different levels. I used to go and visit him at his house. गाइड करते थे, समझाते थे, बहुत कुछ इन्होंने किया. A wonderful person, a great खिलाड़ी, शिकार के शौकीन, and he's a founding person of Pakistan Association of Oral and Maxillofacial Surgeons. Sir, it's an honor for me to invite you, and we will be happy if you can share the past history of the association, कब बनी, कैसे बनी, किन लोगों ने क्या contribute किया, and also perhaps a few glimpses about the past. In '87, the first conference in Karachi, where we had a meeting where we wanted to sit down and gather all the leading people from Pakistan to form this organization. Prof. Taqir was also there with me, and at that time I can remember हम residency कर रहे थे. So over to you, sir.
Assalamu alaikum, everyone. My name is Dr. Mansoor, and I've been associated with the Maxillofacial Surgery Association for decades. I'd written all this huge thing to talk about the thing, but I'm not one of the speech guys. I just talk fil badi. As you all know, trauma to the human body is a very complex, very challenging task. No two traumas are the same, and we're not taught in the books on how to handle them. How we handle them is by experience and by association with other colleagues of ours who are plastics and ophthalmologists and oculoplastics, orthopeds, and all the surgeons that are involved with dealing human trauma. It's a long time since the association was formed. I had just returned from England in 1986, and Prof. M.M. Shakir and myself, we were known to each other from England, and we used to sit together and talk about our issues and share our experiences, and we used to have a little get-together on a monthly basis at Shakir's clinic. And then we thought, we'll get our seniors involved, and Professor Mervyn Hussain, Professor Rehana Mir, who's not with us anymore, in Alillahi wa inna ilaihi raji'un, Professor Ijaz Akil. 5 of us used to sit and just talk about things and think about the future and see how maxillofacial surgery we could bring it to the public, because I had a great difficulty in being recognized at the AKU as a maxillofacial surgeon. They used to call me a dentist. And I remember doing my first TM joint surgery, and they were very surprised that a dentist could go into the TM joint. And it took me ages to get recognized. But now we have a whole team of us working in cohesion with the plastics, and we have a trauma team where the trauma is admitted under one specialty, and then all other specialties are brought together. It was a journey where in 1986, when we sat and talked about forming an association, it was not easy to register the association. Prof. Mervyn was the backbone really behind all this, and this logo of the maxillofacial surgery that you see on our association was designed by me. And there were no computers in those days, so we had to hand draw this. And it was passed by all of us, and then slowly it developed into an association, and our first president was Prof. Mervyn, under which in 1987, as he says, it was, I think, the Taj Hotel, where we had the meeting, and we all presented our papers with enthusiasm there. Prof. Mervyn was the president for a while, and then Dr. Mahmood Haider took over, and we all know about Dr. Mahmood Haider and his flamboyance and his energy and his commitment to educating and increasing our clinical skills of our youngsters. And I find so many sitting over here who, even Dr. Taqir was an R1 in those days. I have seen this association grow into what it is today, and I feel really proud of all of the achievements that that you all youngsters have shown. I just wanted to share how we developed and how difficult it was in the beginning for us to establish ourselves within the surgical fraternity of this city and in the country. Now there are hundreds of MaxFacs all over, and I just feel so proud to see them. It's just, you can't even imagine how somebody who is a minuscule part of the formation of the association, how one feels when he sees so many sitting here. I thank you very much for inviting me, and I hope that you flourish and you all fly and spread your wings and bring this association to heights that are unimaginable, like we tried many, many years ago. And thank you very much for inviting me here. Thank you.
Thank you, Dr. Mansoor. Continuing with the session forward, I would like to invite the chairperson and the co-chairperson for the session. The chairperson, Professor Dr. Huma Ali Sehgal, is the head of Department of Ophthalmology at Fatima Jinnah Medical University, Sir Gangaram Hospital, Lahore. The co-chairperson, Dr. Said Muhammad Asad Shabir Bukhari, is a classified consultant ENT surgeon at CMH Rawalpindi. Sir, madam, please, could you join us on the stage and have a seat?
Thank you, sir. Thank you, ma'am. The moderator for the session today is Professor Dr. Noorul Wahab, the head of Department of Oral and Maxillofacial Surgery at Ziauddin Medical University Hospital, Karachi, and Secretary of the Oral and Maxillofacial Surgery Department at CPSP. Dr. Noor, can you please join us on the stage and move the further session on?
There will be a change in the order of speakers for today. So we'll be changing this sequence a little bit. So please.
Our first speaker, who will be joining us via live Zoom meeting from the Canada, is Professor Dr. Adnan Shah, the head of Oral and Maxillofacial Surgery Department at University of Manitoba. He will be talking on the management of the zygomatico-maxillary complex fractures.
Welcome, Professor Adnan.
To extend my gratitude to the organizing committee, Pak Traumacon Conference 2023, and special gratitude to Professor Shahjahan Kakar and his team for inviting me to present my humble experience in the management of intricacies of zygomatico-maxillary fractures. But while I'm here, I would also like to pay my respects and salam to Dr. Mansoor Ahmed, that I've known since the 80s, and as some of you who don't know, I followed his footsteps to UK in 1986 and went on to work in his unit where he used to work at Whittington Hospital, Manchester. Assalamu alaikum, sir. I've been in business for the last 32 years, and I've dealt with facial fractures ever since, and still learning the tricks of the trade. But to me, zygomatico-maxillary fractures poses the biggest challenge in terms of treatment and its orientation in a 3D fashion. So this is my province of Manitoba. We have almost 100,000 lakes there. This is the city I come from, the city of Winnipeg, and you'll be surprised that in summer we can reach the temperatures of around 40 degrees centigrade. Facial trauma comprises of frontal bone fractures, nasal-ethmoid-orbital fractures, zygomatical complex fractures, and mandibular fractures. But zygomatico-maxillary complex fractures are the second most common of all facial fractures after mandibular fractures. And the etiology remains varied, leading by assault, followed by motor vehicle accidents, sports, and gunshot injuries. And it's further subdivided into low-energy injuries and high-energy injuries. And it does determine the treatment protocol depending on what type of injury we are getting and what severity of comminution and displacement that we see in zygomatic bone fractures. ZMC occupies the most prominent and key position in the anterior lateral aspect of the face contributing to the mid-face width, cheek prominence, most important, and defining the lateral and inferior contours of the orbit. ZMC fractures can cause both functional and cosmetic consequences. But it is also important to note that ZMC fractures not always require a treatment. If they are minimally or non-displaced, with no functional cosmetic consequences, no treatment is provided. But at the same time, we have to pay attention to the alignment of sphenozygomatic suture, which is often missed and ignored, and the anatomical reduction of zygomatic arch, and it remains the most reliable indicator for proper reduction of three-dimensional orientation of the ZMC fractures. And my talk is going to revolve around these two areas of interest as we move forward. ZMC fractures also act as major vertical and horizontal buttresses of the face, and therefore it's important for us to reconstruct them in the proper three-dimensional way. It is the only bone on the face which has got 5 articulations, articulates with the frontal bone, with the temporal bone, and the sphenoidal bone. It has margins at the infraorbital rim and also has zygomatic buttress orientations. And therefore, you can all assume that how difficult it will be to put this bone in the proper three-dimensional anatomical spectrum. The treatment goals obviously are to restore the face and pre-injury form and shape. It has to reestablish the AP projection, also has to establish the vertical facial heights along with the transversal facial widths, and come to some sort of symmetry and facial harmony, and finally having functional occlusion. And therefore we try and achieve a facial harmony like that in all 3 dimensions. There are various classifications of ZMC fractures, but this is probably one of the most common that I use in my treatment planning. You could have zygomatic arch fractures, you could have lateral orbital wall fractures, you could have fractures at the infraorbital rim, or you could have a monofractal fractures, both disjointed at the frontozygomatic, buttress, and zygomatic or temporal region, or you could have a multi-fragment comminuted fracture. Clinical signs again varies from periorbital ecchymosis, swelling, subconjunctival hemorrhage, depressed malar bone, Gurian sign, raccoon signs when you have bilateral ZMC fractures, hooding of the eye, and so on and so forth. It's important that we have good diagnostic imaging, and the standard at the time when I was being trained, certainly Professor Mansoor Ahmad in the UK, occipital mental was the gold standard, where we used to take 30, 15, and 30 degrees views, and we would treat mid-face fractures using that because CT scans were hard to find in those days. Submental vertex, in my opinion, still remains a very good X-ray to assess the zygomatic arch fractures. But certainly CT scans have revolutionized in the diagnosis and treatment planning of any fractures involved on the facial skeleton. And it's been revolutionized further by having 3D reformative scans for us. We nowadays use virtual computer-assisted reconstruction, whereby we crop a mirror image of the normal side, and it helps us in pre-bending of blades based on the reformatted stereolithographic models that we generate after our virtual computer-assisted planning. The indications of treatment are both aesthetics and functional impairment. It could have ocular movements which have interfered, you could have infraorbital nerve entrapment, and you could have restricted mandibular movement. And more so, we need to have this bone projected back to its normal position because it also acts as protection to some of the vital structures there. Treatment options revolve around conservative management, as mentioned before. If they are minimally displaced or non-displaced, you don't need to treat these patients. You could go for surgical close reduction without fixation, but most often you require an open reduction and internal fixation for these fractures. A small comparison, and we need to know if we have to go for open reduction, most preferred site would be zygomatic or maxillary buttress, followed by a frontal zygomatic suture line. but should not be just limited to these two sites. If there's a need for extra fixation for unstable and grossly comminuted fractures, you could go up to 4-point fixation, and we'll talk about that later in our talk. Closed reduction, as I said, would be adequate in a very small percentage of patients because it's difficult for us to ascertain whether adequate reduction has been achieved or not. So therefore, we would need open reduction so that we can gain access to areas of zygomatic complex to ensure correct anatomical reduction at these points. Surgical access for closed reductions, we all know, is the Gillies temporal approach, very common. I still use it for my access before, just to disinfect the fractured zygomatic bone. We could go for percutaneous cheek access, Mailer hooks, carrel-Gerald screws, and you can have transoral Kunz approach access too. And this is just to show that the carrel-Gerald screw is probably one of the best tools to reduce the fracture, put it in the right angulation before you can put plate. And you can actually see in this picture, it has been through, the fracture has been reduced at the lateral orbital wall through transconch and a lateral conthotomy incision here. Although I must say that I am not a great fan of lateral conthotomy incisions because it's always difficult to put them in place, put them back in the right situation afterwards. Surgical access for open reduction of zygomatic or maxillobuttrus through intraoral approaches. The infraorbital frontozygomatic and sphenozygomatic sutures could be explored through subciliary, subtarsal, lateral eyebrow, upper bleph, and choroid fracture, and the choroid approaches. Zygomatic arch is usually choroidal, hemichromal, or preauricular, and if it's a complex comminuted multi-fragment fractures, and obviously you would certainly need a coronal approach for these fractures. I would always recommend to have adequate exposure because these fractures, complex ZMC fractures, would need good exposure so you can visualize the anatomical relationships of this particular bone with its 5 articulations. You could have 1-point fixation, and people have done from 1 to 4-point fixations. Sometimes it's the preference of the surgeon, and most often it has been guided by the severity of displacement and comminution of the fractures. But if I were to have a fixation point for a minimally displaced zygomatic or maxillobuttrus would be the one that I would be using most of the times, and hardly will try not to invade the infraorbital rim or the floor if I don't have to. But don't forget that we have an important articulation, which is the sphenozygomatic, and it is often missed in articulation, but mind you, this is the most appropriate 3D guide to ensure proper reduction. And this is just in case to present that this has been reduced adequately to have a proper 3-dimensional projection of the ZMC fracture. And sometimes you probably would need to put a fixation at that point too. And I often do that in mostly displaced fractures that I have to treat through my chromal incisions. This is just again to highlight, as I said, it's essential that we reduced adequately the zygomatic arch, because it ensures the AP projection of the malar bone, which is extremely important in terms of aesthetics and function. You see. When do we need to explore the orbital floor? That's $1 million question. Most, as we all know, most of the orbital floor is formed by the ZMC, zygomatic bone. And routine exploration of orbital rims and floor should be avoided to reduce risks, and we all know the risks involved in that. However, non-resolving oculocaudal reflexes, primary diplopia, and ophthalmos, mechanical entrapment of extraocular muscles, and evidence of large defects on the floor may necessitate that we should go in and do a surgical exploration of the infraorbital rim and the floor itself.
So we have just less than 1 minute. Can you summarize in 1 minute? Time.
Sorry?
Time.
Yeah. Soft tissue suspension is important, and we follow up with these cases. This is just to show an intraocular view of that. This is the view of the orbital plate post-surgery. pre and post surgery reconstruction, pre and post surgery reconstruction again. And this is a case that I'm going to show very quickly. A fracture from ATV. We had Leaford 1, a zygomatic bone fracture there, severely compromised. This was the treatment before and after, through a prone incision, before and after again. And this is the orbital reconstruction that was carried out. These are the post-operative views of this patient before and after there again. And that's the projection of the malar and the eye as well. Occlusion, importance of anatomical reduction. If you don't explore it properly, this is what happens. You still don't have the AP projection and the width that's possible. There are various complications that can happen. I won't go into the details of that. In conclusion, ladies and gentlemen, the three-dimensional orientation of the ZMC with multiple articulations and its prominent protective and aesthetic position on the face makes it a very challenging fracture to treat. However, accurate assessment employing appropriate diagnostic tools, treatment planning, knowledge, and regional anatomical interface and understanding of the adequate reduction with surgical exposure remains the cornerstone of satisfactory outcomes and standard of care. I must stress all ZMC fractures do not need treatment if they're minimally and non-displaced with no functional cosmetic consequences, no treatment is required. However, alignment of saphenous-zygomatic suture, anatomic reduction, and zygomatic arch remains the most reliable indicator for proper reduction and three-dimensional orientation of the ZMC fractures. Thank you very much for being patient today. This is Winnipeg in winter, and sometimes we can be below the Mars temperature as well. Thank you for your time.
Thank you, Professor Adnan, for sharing with us your experiences. If anybody would like to ask any questions, since he won't be with us later at the question and answer session. Okay. Okay. Professor Shahjahan sending his regards to you, sir.
Thank you very much.
I think we're up. So moving on further, our next speaker is Dr. Fiza Farooqi, Assistant Professor Ophthalmology at Civil Hospital, Karachi, the University of Health Sciences. She will be talking on orbital injuries. Please, Dr. Fiza. Thank you.
Assalamu alaikum. I'm Dr. Fiza, and today I will be giving a brief lecture on orbital injuries. So next. My pointer. Fine. Okay. So objective of my lecture is that I will be discussing few cases regarding different orbital injuries, starting from optic nerve and then ending up to be a simple hematoma. I will also be discussing orbital compartment syndrome, orbital foreign bodies, different types, and fractures of the orbit. So, starting with a brief discussion of the anatomy of the orbit, these are the four walls that need to be identified, and there are three important foramen and fissures through which the important nerves and vessels passes, so they need to be acknowledged. So, this one is the superior orbital fissure, inferior orbital fissure, and next comes the optic canal ending up into the optic foramen. So in any kind of orbital injury, the history which is important, we need to identify the nature of the object with respect. There are two things that are basically important in that: size with respect to the diameter of the eyeball, and also the energy and the force with which it has hit the orbit. Mechanism of injury: blunt or penetrating, direction, exact direction of the impact, and then prior treatment if the patient has received any before the patient presents to us. Specific questions that we need to ask regarding the decrease of vision is that whether it is associated with any diplopia and there is any watering from the eye or the nose or not. So these are the important signs that need to be inspected first on crude examination, then palpation, followed by slit lamp and torch examination. So we need to look for any obvious bony deformity, flattening of the malar prominence, displacement of the canthi, proptosis and ptosis, if there is any, should be measured and documented, and points of penetration. So investigation. Till now, CT is the investigation of choice. Both coronal and axial view need to be ordered, and thin slices of CT scan ends up giving us 90% of the trauma or fractures that are also usually missed in examination. So both thin slices should be ordered, and apart from that, MRI is also the investigation of choice for vegetative trauma. But before that, we need to rule out any magnetic foreign body injuries if it has occurred. MRI is also important to evaluate subtle intracranial hemorrhage and sections of intracranial optic nerves. So this is my first case. This patient, 16-year-old boy, presented to us with the history of instant decrease in vision following a blunt trauma. So this is basically optic nerve avulsion, which is a blinding complication, and this is also associated with a hemorrhage around the disc and central artery occlusion. So little we can do in this patient. Here's another case. This patient presented to us on the first day. There was no significant problem except that a decrease in vision. Anterior to posterior, all of the things showed up to be normal. A week later, this patient presented, and then on fundus, we did fundus examination on the first day, everything was normal. And a week or 10 days later, when this patient showed up, there was optic neuropathy. As you can see, pallar disc. So traumatic optic neuropathy is basically an acute injury of the optic nerve. It can occur as a result of both direct and indirect trauma. And what is the management? Usually it resolves spontaneously, therefore we keep the patient under observation. However, high-dose steroids and optic canal surgical decompression are also other surgical options. So moving on, coming anteriorly, retina. This patient presented with flashes and floaters and a slight decrease in vision. We did a fundus examination on an undilated pupil, and we were able to see that the posterior pole is roughly same, is normal. So the point in this fundus picture is that we need to identify and do a full, complete fundus examination to look for any peripheral tears, since as you can see there is a retinal tears which were identified on scleral indentation and peripheral fundus examination. Next, we have a subhyaloid hemorrhage, which again patient presents to us with a decrease in vision, and this subhyaloid hemorrhage is a boat shape in the retrohyaloid space, and this needs to be removed, or first we go for observation, but if the patient is having this in a chronic manner, then we go for anterior hyaloidectomy. Now this is a patient who presented, this is a very common finding in a trauma center. Patient presents to us, we get a call, following RTA, patient is unable to open the eye, and also the globe is so tender that even on forceful opening we can't open it. So this is a case of hematoma where the IOP has increased because of the accumulation of blood behind the globe. Sorry. So urgent canthotomy and cantholysis are advised if the condition is not resolving and if the IOP is so high that the patient is in pain and tenderness has occurred. So we can do it by transconjunctival or transcutaneous approach. Now this is a case, it appears similar to the one in the case 5, except that the patient is able to open the eye. The difference is that on examination we felt crepitus below the lower lid. So now our picture goes to the orbital emphysema. Air entrapment has basically occurred. As you can see on the radiological imaging, there is a black shadow just inferior to the orbit and also laterally. So this is where the air has been entrapped, and this can also cause an increase in IOP. So in this case, we advise the patient against blowing nose or Valsalva maneuver. Treatment is similar to the cases of increase intraorbital pressure, and also we can remove the air in a saline-filled syringe, so the air bubble could be easily noticed in the saline-filled syringe. So now there are a few cases of orbital foreign body. This patient presented to us, I guess it was more than 2 to 3 weeks, and this is a foreign body which has gotten necrotic and incarcerated along with the tissue that it has encroached. So foreign bodies are a vital thing that need to be assessed, evaluated, and if required, removed in ocular trauma. Here is another picture of the foreign body. As you can see in both radiological imaging, this foreign body has gotten to be encapsulated. So this also shows us the chronicity of the foreign body. Anyone from the audience can guess what's happening around here? So this is basically a heel trauma, probably a poor husband hit by the wife. So this is how the patient presented to us. Heel was intact in the orbit. And this is not a case that happened in our OPD. I got it from the internet, but it was a very classical case report that was actually published. So patient can also present to us like this. So small and high velocity objects, we need to identify penetrating injuries and intraorbital foreign body. Larger and denser objects have a high kinetic energy, so they can cause bony fractures. Then composition of foreign bodies are also important because it depends on the infection that can invade. Therefore, prophylactically broad spectrum antibiotic tetanus toxide is recommended in all cases, and inert foreign bodies that are smooth, for example lead, if left behind the orbit won't cause any problem. But if the body is vegetative, wooden, then we need to remove it since they are a cause of fungal or bacterial infections. So moving on to this case, this is a granuloma from the foreign body which was not depicted on examination. It was too small and near the canthal and the inner fornix. So this ended up showing up to be a granuloma after a few days. So this patient presented to us with a mild chemosis and hemorrhage, and when hemorrhage and chemosis resolved and patient was able to open the eye, on extraocular movement examination we noticed that patient is unable to supraduct his eye. So here comes radiological imaging which comes into play, since we need to identify if there are any fractures. So blow in and blow out fractures are the two important entities that need to be evaluated on the first day with the X-ray, and then later on, if we required, we can proceed to other radiological XCT. In blow-in fracture, basically, a part of the roof, a part of the bony fragment gets into the orbit, while in a blow-out fracture, for example, a floor fracture, the orbital contents invades into the maxillary sinus. Rule is rule out globe rupture. Initial treatment is observation, avoid nose blowing, cold compression, proper head, prophylactic antibiotics should be given, painkillers and ophthalmic ointment or tarsorrhaphy if required for exposure. However, there are some indications which need surgical intervention there and then. So what are those indications? Anophthalmos greater than 2 mm, persistent diplopia in primary gaze or the reading gaze need surgical intervention. We are not supposed to wait for that. Now, CT findings of ocular muscle impingement or orbital contents entrapment, which can in turn also lead to bradycardia, is an acute emergency. If over 50% of the floor is involved, then also we need to surgically intervene the patient. In all these cases, repair within 2 weeks is advised. So, in the end, I would like to share a study which was conducted in our trauma center, and it was a dissertation-based study conducted last year and published in Pakistan Journal of Ophthalmology. In this, we identified frequency and pattern of ocular trauma following road traffic accidents, and this classification that was used was according to Birmingham eye trauma terminologies, and different type of injuries were recorded, their frequency and percentage. This was a cross-sectional study basically. Apart from that, we also recorded open globe and closed globe trauma, and we ended up recording that open globe trauma is less compared to globe, as you can see, from 79% to 21%. Well, thank you.
Thank you, Dr. Feza. for giving us an insight on orbital injuries. Now I'd like to invite Professor Dr. Nurul Wahab, Head of Department of Oral Maxillofacial Surgery at Ziauddin Medical University, to kindly present on challenges while treating post-traumatic deformity. Thank you, sir.
AG मैं भी कर दे Bismillah ar-Rahman ar-Rahim, starting with the great name of Allah who knows the secret of night, moving in the dark night. First of all, I congratulate the organizing committee who organized this event. It's a great event and collect all these delegates for the conference. And I'm special thankful to Professor Shahjahan Khat for giving me, he invites me to talk on my topic. So we have 10 minutes. I will try my level best to finish the topic within 10 minutes, This is the institution where I belong. This is Ziauddin University. We have almost 900 bedded hospital in the different area of the city. One of the largest private sectors, the university where I've been trained, King Edward Medical University, and the first fellowship program I did at the Karachi College of Physicians and Surgeons in Pakistan. So the objective of today's talk is three. Just try to identify the etiology and types, diagnose the post-traumatic deformities, and treatment modality for the post-traumatic deformity. Deformity to treat a trauma is very easy when the patient comes earlier, but when the patient comes in the old with the post-traumatic defect, they are very challenging. So we'll discuss the etiological factors, inaccurate process of the reduction, and inaccurate choice of the, I think this point is not working, it's okay. So inaccurate choice of the reduction and fixation, and inappropriate reduction earlier, or choice of the device you have placed, like the fixation. So this is another example. Even though mini plate doesn't work in the edentulous space, and this is the errors we will find. We'll discuss them in the case. If inappropriate dealing with the patient earlier, it will lead to the infections, and one of the most common etiological factor is the ankylosing in the temporomandibular joint ankylosing. So let's divide the facial region in three parts. Number one is the frontal part, where we find the defect. Second is the nasoethmoidal region, and the third is the orbitozygomatic region. Okay. And the fourth one is the maxillary region, and the last is the mandibular region. So divide the face in the 5 zones, and you can encounter the different defects. So we are concerned with the two problems. Number one, the function and the static, or it could be the combination of both. Dono problem ke saath aapke paas patient aa sakta hai. So we just diagnose the history, examination, intra and extraoral examination. Being a maxillofacial surgeon, don't forget the intraoral examination. That is the key, is the occlusion, which will help in the function of the patient. So then you do the investigation. Plain radiograph work only for the dental, but the 3D CT scan is the gold standard to diagnose post-traumatic deformities. So we treat function, aesthetic, and the combination of both. The function first would be, number one, with the functional therapy. Like we have patients who have been treated with the fracture, occlusion inappropriate, our first kya kare, usko just arch bar elastic work for the minimum errors. Uske baad, 1 or 2 millimeter defect, you can just do the trimming of the occlusion. Just a simple work, you can work. And then if it's not resolved, then you can have to think about the orthognathic surgery and treatment of the stereolithic radiograph. And then you have your approaches. It could be intraoral, extraoral, it could be the combination of both. So one is the first case. You can see here, this patient was treated with the fibula, which is failed. Radial forearm with the bone is failed. And third option, which we tried, that is simple 3 implant with the prosthetic, it works. So it achieves the function in the static both. This patient is being treated maltreated. If you are thinking the patient will be treated just with the transosseous wire, it's a whole era, still the people are doing it. It's inappropriate treatment. Transosseous wire not exist, it is 1800 and old patient. So still the mini plate will placed second time, but it's again an inappropriate treatment for the edentulous space. So the inappropriate treatment in the edentulous space, it lead to the screw loosening and the fracture of the plates. So the ideal treatment for the edentulous space is when the bone is 1 centimeter or less, then you have to place the reconstructive plate. It's a follow-up for the 6 months of the same patient. So the choice should be started for the edentulous space would be ideally for the reconstructive plate. And this is the follow-up, still the patient is okay. So another patient with the inappropriate is the infection. So if you have these patients, first you have to control the infection. And you have to cover the soft tissue, either with the free flap or the local flaps. I just tried the supraclavicular flap first, put the bone graft, division, and then I place the dental implant. Of course, you have to rehabilitate the function, that is the occlusion. So started from here and ending with there. So soft tissue, bone, and the lips recontouring is very, very important. This patient, you can see the patient will come with inappropriate occlusion. Facial, aap dekhen iska to, there is a lot of problem with the face. So patient cannot bite. If you see from the side, aapko nazar aaga chin is slowly backward. You have to examination the patient all the way. The reason was there. Aap isme dekhiye kya hua. The garbad is that just IMF and the transosseous wiring. It's inappropriate treatment. So what I have to plan, do the 3V CT scan, you can do the model surgery, and then open reduction internal fixation, remove all these wirings which have been placed, and of course, if you needed the bone graft, you have to place the recon plate and the mini plate. If it is dentulous space, you can place the 2 mini plates. But if it's edentulous space, think about the reconstructive plate. So this is a follow-up for 2 weeks. It's a pre-op picture and the post-op picture of the same patient. The occlusion facial nerve is intact. Of course, you are treating this patient, you have to not give another morbidity to the patient. That is the facial nerve. To intact facial nerve, intact occlusion. So pre-op and the post-op picture of the same patient, pre and post-op the patient, same patient. And the facial nerve is 100% intact. And you have to be trained enough, you should preserve the facial nerve. From the side, pre-op and the post-op picture of the same patient. This patient, it came with the bone loss of the maxilla. Now, aapke paas option kya hai? Option number 1 is the free fibula. But this patient having the peroneus magnus. Peroneus magnus mein aapke paas kya option hai? You have the option of DCI flap. In Pakistan, only few people are doing this flap. The another option is zygomatic implant. The first ever FDA-approved zygomatic implant which we placed, we planned for this patient is a FDA-approved zygomatic implant based on the CBCT. And of course, you have to do this procedure under the general anesthesia. You cannot do it under the local anesthesia. Placing the 2 zygomatic implant, one in the terminal part, it resolves your problem. So even though if you cannot place the fibula, there is an option of the zygomatic implant, not the implant which is you turn it out. That is not the FDA-approved implant. FDA-approved implant should be having the multi-angle abutment. This is another patient with the loss of the soft tissue, the lip, chin, and the bone. So if you see the CT scan, from angle to angle, the bone is lost. So first, infection control and supraclavicular flap, then the free fibula. And of course, once everything has been settled down, then you have to think about the dental rehabilitation, the dental implant. All in 5, all in 6, there's a lot of debate. So at least you have to place 5 to 6 implants. It's my experience, and you can achieve. So starting from here and to there, the lip, chin, and the dental rehabilitation has been placed over there. This patient having the tracheostomy. Now we have again, patient cannot breathe. The floor of mouth is gone, the chin is gone, the bone is gone, everything is gone. The bone is lost from angle to angle. Now, aapke paas option kya hai? Fibula, This is the fibula. You cannot take the fibula in this patient. This peroneus magnus, we do all the patient with the CT angiography before doing any kind of the fibula. So you cannot do. Now which we have the option which we, that is the distraction. So starting the distraction from one angle to another, a double distraction, and it will have soft tissue and the bone will come with the distraction. You can see after 6 months, the complete bone is been formed with the distraction osteogenesis. So we have the solution for everything. So bone, from here to here, we can achieve just by the distraction. You should have the concept of AOCM. If I'll let you, what is the concept of that? This is the patient with the temporomandibular joint ankylosis, unilateral temporomandibular joint ankylosis. पुराने ज़माने में हमारे सीनियर क्या करते joint खोल दो. No, this is the wrong concept. Now the recent concept is start with the distraction first. So I would like to do the distraction first. Distraction पहले की, face को ठीक करें उसके बाद. Then you have to think about the gap arthroplasty. So distraction, I just complete the distraction first. This will happen. Now how to resolve, I will let you know. Then you have to do the bicoronal, the Bramley Al-Khayat and the Blair incision combination, remove that distractor, gap arthroplasty, genoplasty, and the combination of these. Now we did everything. Face is okay, but still is a dimple over there. So you put the iliac bone graft over there. So 3 week post-op, pre-op picture of the same patient and post-op picture of the same patient. Chin, bone, everything is there. Now you can see chin is there, it's been improved, aesthetic line is improved. And you can see here, and this is improvement in the occlusion mouth. Again, another patient with the bilateral temporomandibular joint ankylosis. Don't go for the old concept. Distraction first. So I did the distraction first. Bilateral distraction first, and now with this happen, what you have to do? You have the concept of AOCM. This interior bone bite will develop. Callus mollis modification, the recent articles by publishing my friend. So this is the callus modification concept. You should know how to mold that concept. And then this is a pre-op picture, the same patient, and the post-op picture. 6 months back, you can see here the complete bone is formed over there. So the pre-op airway you can see here, there's no airway, almost 2 to 3 millimeter, 15 millimeter airway you can achieve with the diffraction and the gap arthroplasty you have to do later on. So bilateral gap arthroplasty in the same patient. And then you can see the mouth opening is improved. Face is improved. Occlusion is perfect. So you have to do the orthodontic treatment as well, of course. So another patient with a condylar fracture, treated facial asymmetry, BSSO with the correction of this patient. You can do one of the options is asymmetry. Do we have to do hybrid fixation or the orthognathic surgery? So face improve immediately. Okay, this is the second last patient. Frontal bone fracture with the nasal bone. So what is the approach? Aesthetic approach is bicoronal flap, reduction of that bone, and fracture of the nasal bone and put to the only bone graft from the calvarian or rib, whatever you have. So the pre-op picture and the post-op picture of the same patient. Take-home message is identify an early treatment of post-traumatic deformities. Bony loss should be replaced with the bone. Load-bearing plate should be placed. Osteotomy, orthognathic destruction. Choice is yours, whatever option you have. Long-term follow-up. Thank you very much for the kind attention. Pakistan Zindabad. Any question you can write me on email, on my Facebook, or on Instagram. Thank you very much again.
Thank you, Professor Noor. It was really very, very wonderful presentation. And actually, post-traumatic deformities are very difficult to manage. And our next speaker is Professor Huma Kiani Saigal. She is Head of Department of Ophthalmology at the Fatima Jinnah Medical University, Lahore. She will present the talk on the ophthalmology-related trauma. Please, ma'am.
Assalamu alaikum. जब तक ये शुरू हो रहा है, just wanted to thank the council, Pak Traumacon की शाहजहान साहब, this is for you because we came, he invited और हम कुछ लोगों को ना नहीं करते. So ये होती है दोस्ती भी. So thank you so much for inviting, and it's a multidisciplinary field. जो trauma है, it is not just related to one, it is related to almost all the structures. और जहाँ तक ophthalmology का concern है या eye का concern है, तो एक छोटी सी बात, in the eye lies the magic. तो हम नहीं चाहेंगे कि कभी भी magic जाए इन आँखों से. So we will be talking about the ocular injuries. Dr. Fiza ने काफ़ी हद तक ocular injuries को, orbital injuries को cover किया है. So I will try to make it simple, something that can be picked up by everybody, and they should know when to treat it by themselves as observation and when not to. So हम हमेशा कहते हैं we want to create safe clinicians. So let's have a safe session today. So what I'm going to talk about today is ophthalmology trauma, how it affects the visibility and vision. So this is where I work. This is Fatima Jinnah Medical University, affiliated with Sir Gangaram Hospital, Lahore. I was born, bred here. जहाँ से आपका college शुरू होता है और have the opportunity of not just studying from there but being trained and now heading the department. तो इसका मतलब है उम्र बीत गई इस जगह पे. So ocular trauma circumstances, it can be accidental, we all know that, but it can be intentional also. So let's just move it to the, okay. So accidental and intentional, we all know that. So लेकिन कौन से types के होते हैं? In eye we have blunt traumas, we have penetrating, we have perforating, we have chemical traumas, we have something that everybody is very, very familiar with, the roadside accidents, and then we have one very, very important for that we somehow miss out. Please look into, especially the mothers and the parents have to look into the physical baby abuse. This is also trauma. So blunt ocular trauma mein, this is one way of showing it, which is known as the panda eyes. Then there is subconjunctival hemorrhage, and then followed by blood in the interior chamber, which is known as hyphema. Chot lagi aankh pe, it could be a fist fight. It could be like you're walking and you bang yourself into a mirror in a wall. Darwaza khul gaya. Anything that is blunt without any entry wound can cause these. So followed by this, then we have other issues like the retina can be involved, which is the back of the eye. There can be bleed over this. And along with that, there can be something which is known as a hole formation. This is usually seen in people who are cricket players, या squash players. तो तेजी से ball आती है, hits the eye, there is anteroposterior compression followed by expansion of the eye, and the center of the retina, which is known as macula, loses its vision. There's a hole. अगर मैं आपको देख रही हूँ, let's say I'm looking at a lady, फिजा को अगर मैं देख रही हूँ, तो I will not be able to look at फिजा. वो बिल्कुल एक black image होगा और आगे पीछे के लोग उनकी पे temporal या peripheral image आ रही होगी, but the central vision is gone for good. So apart from that, we have what is known as penetrating ocular traumas. These are ocular traumas which have an entry wound. Now this is a picture of a person. पता नहीं क्या हुआ था उनको कि रात के 12 बजे उन्होंने सोचा कि he will mend or repair his cupboard. So 12:30, 1 baje he was landed in the eye emergency with the nail just hitting it. This is our pictures, the original pictures we took with the consent of the patient. Or ye penetrating hair which has an entry wound without an exit. So what do we do? Now there are other forms of penetrating injuries. Ye ek badi nail hai which eye mein lagi. Then there are intraocular foreign bodies. हमने कसम खाई है कि हमने काम करना और हमने अपनी protection नहीं करनी. So working places, industrial zones and all that, sunglasses की बात नहीं हो रही. The working glasses, protective glasses भी नहीं हमने लगानी. So protective glasses will protect you from small chisel portion of a foreign body which is high, has a high projectile force, will enter your eye and there will be no entry or exit wound. The entry wound occurred, but because of elastic recoil, it closed on its own. So the patient will come after a few months with these small portions and which is known as sidrosis. So sidrosis के साथ then you go and get a complete examination. उसे याद भी नहीं होता कि उसको trauma हुआ था. So by the time you get it and you get a CT scan, you get the rest of the structures, you find, okay, there is an intraocular foreign body somewhere lying in the eye which you have to now take it out because it's going to damage the eye for good. So then we have the penetrating ocular trauma, cornea perforate ho gaya, iris pyre aa gaya. And then we have something which is caused complete disinsertion of the iris, which is known as iridodialysis, and the lens, which has to be absolutely transparent, now becomes opaque. ये age के साथ भी होता है, लेकिन trauma की वजह से तो एकदम होता है. If you have an iridodialysis, you can't leave it as such because the patient is going to have double vision. You have created, the trauma has created another hole here, and this hole is going to make this patient miserable for the rest of for his life because वहाँ पे उसको दो नजर आ रहे होंगे, which is known as diplopia. So entry, when you're perforating, entry and exit wound. This is what the roadside accidents and the bullets and the blast does. Eye को salvage करना अब मुश्किल हो जाता है, मुश्किल ही नहीं नामुमकिन हो जाता है. So for that, then we look for the cosmetic, because eye is not just about vision, it's also cosmetic. It is something that is visible on your face, और face is that part जिसको आप छुपाते नहीं हो, बड़े proudly show करते हो, because that is your identity. So apart from that, we have chemical burns, which can be acidic and alkali. Every household has chemicals. pH किसी का ज़्यादा है, किसी का कम है, but these can also cause damage to the eye in form of crusting, loss of eyelashes, adhesions, remove corneal की epithelium उत्तज होती है, and if you don't, if there's a high pH value or a very low pH value, depending it's alkali or acidic, the cornea becomes blind, and then you might be needing a corneal transplant. So roadside accidents की already बहुत बात हो चुकी है. This, it causes trapping. There's a floor fracture, which is the commonest, causing trapping of the inferior rectus or inferior oblique muscle. और फिर आपके बाद upward and downward movement नहीं होती eye की, and then you have to take care of it. Bullet injuries, blasts, terrorism, we all are familiar with it. And these small pellets or these sharpnels get fixed on the cornea, and then you have to sit down, do it under GA, or you need a lot of time to remove them one by one. So what do we do? The management is according to severity of trauma, visual status, and reassure. Where will the medical management play out? In which cases there is hyphema or blood in the anterior chamber, it is going to cause a rise in intraocular pressure, or pressure eye ka high on is just like the blood pressure. The blood vessels can burst, it can occlude, and it can cause optic atrophy. So patient might have temporary or permanent glaucoma also. As such, the patient is going to lose vision. You've got to just reduce the intraocular pressure by anti-glaucoma medications, and it's going to work. Then, if there is corneal abrasions, just please remove the epithelium, put a bandage contact lens. This will heal on its own. Then, we're going to look at the surgical management. Isko to nikalna padega. Isko hum chhod nahi sakte, because it looks very funny, and nail hitting the eye like that. And then, corneal repair necessary, because the patient is going to have everything from inside the eye is going to exit. दरवाज़ा खोल देंगे तो हम सारे बाहर चले जाएंगे. बहुत ही कम लोग हैं जो अंदर बैठे रहेंगे. So if there is an opening of the cornea, the inner structure is going to come out. And this also, if somebody has an iridiolysis, you have to repair it, and you have to remove the cataract. So I'm just going to show you a video of a patient that we did a month ago. So this video has been taken with the consent of the patient. We have no financial disclosure. And this is the iridodialysis. This is a small child who had a small trauma. Or uske baad he had, this is a cataract also. So first, a little bit of scleral tunnel is made, because we're going to attach the iris back. And for that, we need proline sutures. So when they're going to go in the eye, if they're going to come out and secure on the outside part, it's going to cause a lot of itching and foreign body sensation, so they have to be buried. So first, the cataract surgery has to be done. You clear this out. This is followed. So the lens is clear. Sorry. ये आगे नहीं हो सकता यहाँ से? ये आगे नहीं होता? जी? वो पूरा होगा, फॉरवर्ड नहीं हो सकता, फास्ट फॉरवर्ड नहीं हो सकता? ओके, माय अपॉलॉजी जी. ये तो चला दे मुझे. सॉरी? ओके, नहीं चल तो रही है. Just wanted you to fast forward. चले. So I'm just going to show you one video, because we have shortage of time. So this has started all over again. So scleral आपको करनी है. Scleral के बाद basically I will just show you till the point that we're going to reattach the iris, and then we're going to move ahead. So जब भी surgery करनी है, because the lens has been compromised because of the trauma, this traumatic lens has to be taken out, because the patient is not going to be able to see. You take the lens out, then after doing that, you are going to, the next thing is you take a straight needle, proline. Now this proline is 80 or 90, sometimes even 10-0. This is like 1:10 millimeter of diameter, its thickness hoti hai. So isko, when we pass through, we attach the iris now to the sclera. And because these are non-absorbable sutures, so it's always better to have a scleral tunnel, so that the patient will not have a foreign body sensation later on. So this is one way of putting it, and once this is done, then the second side will also be done and followed by placement of an intraocular lens within the eye. So ab isko main bas time kitna hai. So I'm just going to forward this, move to the next one. This one, if anybody would like to see, we can do it later on because we don't have time. So ocular trauma, then comes the cosmetic management. In the cosmetic management, you can have cosmetic contact lenses. This is an eye which cannot be salvaged anymore. This is a thicycle eye, and for that, what you need to, in order for it to look like this, you can actually have a prosthetic eyeball, and this is easily managed by the patient themselves. They can put it in, they can put it out because it's need to be cleaned. It's just like the dentures, where the dentures have to be cleaned, the ocular aesthetics also have to be cleaned. So finally, this is one thing that is very important. I'd like to thank the parents of a 6-month-old baby who allowed me to take this picture. This is baby abuse. This is also trauma. This is something every mother and a parent should know. A maid tried to kill this baby, a 6-month-old baby. And I had to take this just for this trauma session so that we need to see. Please protect your babies from trauma. This is also a very important and a serious trauma. And I'd like to thank the parents who allowed me to show this picture to you. Thank you so much. If there are any questions, please, you're free to ask, or you can even ask me later in the session. Thank you.
Thank you, Professor Homa. It was lovely. It was a lovely presentation. Now I'd like to invite our next speaker, Dr. Syed Mohammad Asad Shabir Bukhari, who will be talking about his experiences on surgical airway management in trauma patients. Sir, please.
बिस्मिल्लाहिर्रहमानिर्रहीम। कुरान जिसने एक इंसान की जान बचाई उसने गोया तमाम इंसानों की जान बचाई। I am now serving in Combined Military Hospital Bannu, an experience of a decade in surgical airways management of trauma. A patient presented by bullet injury for a mouth in a very remote place of Punjab, Shakargarh, and this was his condition. And there was a general surgeon who, what did he? He put the tracheostomy tube and saved the patient and sent to the CMH Sialkot for further treatment by plastic surgeon and ENT. A decade, I must mention, for last 10 years, first I was in CMH Sialkot where I started taking interest in trauma. I performed ATLS 9th edition, and Professor Minhas from JPMC came there and gave us the primary trauma course, and then I started working with the Rescue 112 and then thinking about the cricothyroidotomy. In CMH Peshawar, I conducted first workshop on this cricothyroidotomies, let them breathe in November 2017. In PNS Shifa, I bought my own mannequin, which is now is with me, and I trained more than 700 at that time and wrote an article which was published in Pakistan PFMJ. And then I am serving in Bannu and giving the presentations and also giving the training to the human resource in all over the world, in Lahore, Rawalpindi, and Bannu and Karachi every day. Sequence of my presentation will be the trauma training, surgical airway management, my research paper which I showed you, and periodic trauma, a bit one aspect and some recommendations. Trauma training, it's a responsibility of all, and I will show you, and I will, in trauma training, I will further talk about these pre-hospital, hospital, advanced, and Pakistan courses, such for suggestions. It's a responsibility of all the doctors. whether it's a general surgeon, maxillofacial surgeon, eye specialist, ENT specialist, thoracic surgeon, hospital administration, and it is very important. Rescue 112 pre-hospital, very good this in our mother language Urdu, which was published. I received 50 books from Rescue 112 Dr. Mr. Abed Kamal, which is co-authored with Dr. Rizwan Nasir. And I trained our staff first, doctors, nurses, and paramedics on this. And then I start teaching it even to sweepers and laymen and soldiers. I made it in two parts. First 17 was basic, which have some medical and surgical emergencies as a first responder course. And second part was, which was the advanced. But I focused on the basic part. Basic should be given to the more than 30% of Pakistan population above the age of 12. And it must be trained by, on this booklet. These have few sets of skills. Along with BLS, there is control of breathing, log roll, and these all are in Urdu and very easily taught. Particularly when you are hand-free and you are traveling, you have to be a first responder. This is the some award given to me by the Mrs. Corps Commander 11 Corps in Peshawar by training them 2 hours, 140 ladies, and then I presented the Surgeon International Conference paper on this pre-hospital and trained more than 700 of. Then is the primary trauma courses, which are flexible. There is organization doing this. I also made in PNA Shifa basic, paramedic, advanced courses of this, which is basically taken from the ATLS of American course. We add up some things, and I also emphasize on the airway management mannequins, on mannequins with surgical and other neurochemotherotomies. I was also the co-founder of an association which was formed by the Dr. Nazir Khan in Rawalpindi in April 2016, Pakistan Academy of Emergency Medicine and Trauma. Now the president is our orthopedic surgeon in Fauji Foundation, Brigadier Retired Salim. And we are doing with Rescue 112 and so many medical specialists, emergency medical specialists, and general surgeons, DG medicine surgeons of Army, and these are all working for the traumas. But I must say that we should develop our PTCs, and it should be in Urdu, and it should be basic and advanced. We should Urdu for our paramedics and nurses, and for English in our doctors. And airway management should be included in these courses, along with emergency tape for children. Airway management started with the workshops. There should be first there may be 3 to 5 stations. Training of critical adjustment skill is not satisfactory globally. लपे आती है दुआ बन के तमन्ना मेरी जिंदगी शम्मा की सूरत हो खुदाया मेरी. The aim of this workshop is that we should save the life and get the blessing of Allah. A motivated skilled doctor in airway management is an asset for the nation, teacher for paramedics. And when there is increased level of doctor in stressful conditions, he will perform well, and he will also make available essential equipment. Definitive airway ATLS guidelines are this, but unfortunately these are not followed. What is definitive airway? Any cuff tube below the vocal cord should be done in case, and it should be undertaken tube in more than 90% of cases, and then surgical kecotherapy. These are the assessment. Everybody has to take action, anybody, but there are so problems, and pulse oximetry is not so good, but you have to use your own examination, respiratory rate, work of breathing, and some gadgets like ABGs and continuous capnography. And physical examination is more, and any intervention should be carried out. Unfortunately, so many patients die due to no action by any doctor. And rapid intubation is very important. With anesthesia people, we should make our local protocols and should be done. And in 80% of cases, then is the inability to intubate. Then we have to, it's a latest edition, 10th edition, 9th also. We perform first needle, followed by surgical and cricothyroidotomy. Now a bit of cricothyroidotomy. There is 2 types, needle and surgical. This is performed here. and insertion of tube, very important, 15 liters, and in adults, 12 to 14 gauge intermittent insufflation. Oxygenation should be given for 1 second and 4 seconds should not be given. All ages, and it will give 5 minutes of brain death ho jati hai, and you can perform it and give 30 to 45 seconds. These are the needle cricotherectomy. Why I'm speaking here? Because so many people don't take action within 5 minutes in their setups in ICUs and emergency. Acquired skill, I have master trainer, I have mannequin tubing, and I'm traveled from Banu. I have this with me, and I can teach in next 2 days if anybody wants. This is my video on the YouTube, and time is short, so I am not showing. You can just Google YouTube pe jaye and write little kikothad.in Urdu by Asad, you will find it. Then surgical, this is also in these are 2 links. You can write this on YouTube, you will take it. And I must say you should, in lunch break, you should take it. See it. Now, a bit small, 1 minute left, experience with, it's a quasi-experimenter. I trained so many people in Mayo Hospital, Sheikh Zayed, Fauji Foundation, small, large groups, 994 participants, including 55, 12 males and 482 females. These are the gender distribution. This is the groups like the residents, medical officers, house officers, paramedic, nurse. These are conclusions. It's very important life-saving skills in airway management in situation of do not intubate and do not ventilate. Very important. Proper training of doctors and paramedics need of time and great service to humanity. I must say that we should do it. Pediatric trauma is very important. Unfortunately, I did ATLS in 2015. I saw a very good tape, Brassos tape, but which are used in trauma centers by law in America for 2009, but we are not using it. I distributed its color photocopies. This is the tape, and this is pink, red. The doses are written, even used in arm periodic trauma. This is the wave you can do. These are the drawers in which you keep the things. These 9 basic skills should be by every doctor every time, but particularly our house officer should be. Government recommendation is education must be approached to teach rescue 1-1 7th 8th class में हम compulsory कर दें, law बनाएं motorcyclists के लिए और 9th के doctors को दें और doctors को ATLS के लिए grant मिले. These are for doctors कि हमें very important है बार-बार इसको conduct करनी चाहिए अच्छी quality mannequin के साथ needle की is very important and life saving. And 9 basic skills should be taught, assessed in first 3 months of whole job. Trauma centers must be equipped with pediatric emergency tape and life-saving equipment. And last is we should give the leadership. Inshallah, we are multidisciplinary, but there should be leaders which having emergency and trauma, and should be developed at CPSP level. And we will all will be the beginners to make this specialty in coming years. This is the. Thank you all for patient listening. Any questions? I'm here to.
So we'll take questions at the end of the session. We'll take questions at the end of the session.
Thank you, sir, for sharing your experience with us. Now, I would like to invite the person who has played a key role in organizing this committee. His tireless efforts has given us an opportunity to be gathered here today. He is a co-chair of the scientific committee of this conference. He is the head of Department of Oral and Maxillofacial Surgery at Dow University Health Sciences and SMBBIT. Professor Shadan Katpar, please come up on the stage and say a few words about your presentation.
Can I have the first slide? Bismillahirrahmanirrahim. I'm heartened and honored to be a part of this whole academic event. And it's so heartening to see my colleagues, my dear friends, my mentor, my students, invited guests. Assalamu alaikum. Next, please. My workplace, Dow Institute of Health Sciences and Shaheed Mohtamra Benazir Bhutto Institute of Trauma, where we have this surgical unit. It's a second surgical unit tagged the Dow Institute of Health Sciences. Professor Homa and Professor Noor, I'll take the liberty of perhaps exceeding the time, few minutes more, so please bear with me. Thank you, sir. To some of you, mostly perhaps who do not have the dental background, let me tell you, the dentistry, which is normally tagged as a profession associated with extractions, root canal fillings, and scaling, has moved on. And we deal with cervicofacial necrotizing fasciitis cases. And this pandemic era, we proudly say that perhaps it is one of the largest referral centers in Pakistan. We have unpublished data, and soon that will be published to see exactly what we have been dealing with. The COVID pandemic has brought us so many things. Next, please. 5 major achievements which we did at this particular organization and department. We established the maxillofacial surgical unit in 2018. In 2022, it was approved for fellowship training programs, and we have so many graduates who are tagged with us. It's the only functional active unit in the whole province which was working, providing services throughout the COVID pandemic. 24/7 we were actively involved. My whole team was involved there. It's the only public sector institute in Sindh province which caters to provide free maxillofacial surgical implants in terms of oncology, traumatology, and reconstructive surgery. At this particular unit, we also conceived a totally new procedure to treat pediatric population fracture mandible cases. This is the first and the innovative technique in the world. It is available on Google. Next. A simple case we manage very well. This patient is a case of polytrauma neurosurgery, kept it under observation for a long time because of the poor GCS and so many things. This is how we faced it, and to the different stages, we were able to give her a decent face, so she's very happy. And something big, which is very close to my heart, is bismuth iodoform paraffin pack paste. I call myself the BIP man because I use it as much as probably anyone is using in Pakistan. The biggest advocate for this particular wonderful medicine. Next. Another case of cervicofacial necrotizing fasciitis from Peshawar. This lady was perhaps hit by a bull. She presented to us because somehow she heard that there is some kind of a remedy. Different stages from admission to surgical procedure, and we have our own strategy. Must operate aggressively as soon as you can, as soon as it is possible. Next, please. She's happy. We did split skin grafting. She has a face. The mouth opening is great, and she's functional, and she's alive. And because of her prayers and people like her who are praying for us, we are able to do more and more. Next. We started in 2018. We had only 80 patients which we operated, and progressively, as you can see, the number keeps on increasing. As Prof. Swenson was talking about yesterday and some other colleagues, yes, now the system is collapsing because we are unable to cope up with the disease burden and the traumatology patients. I have a very small team, a devoted team, my PGs, my junior consultants, and they are all committed, and we are doing whatever we can. From 80 patients till 436. In total 4 years, we have managed 1,355 operated cases. Next. Males form the predominant proportion of this particular traumatology, and yes, this needs to be explored. Why? Next. This is unpublished, genuine, raw data, which will soon be published, hopefully. Different age groups who have suffered traumatology, from infants to from children to elders and geriatric population. Next. Fracture mandible is more common as compared to the maxilla and the mid-facial fractures. Total, we have, these are the number of the patients which we have treated. The common causes being road traffic accidents, physical trauma, assault, sports injuries, industrial assaults, and so on and so forth. Next. The ER and the OPD cases which we have been treating, and I was surprised to see this data. Trust me, this is all genuine. More than 40,000 patients we have been able to see in the span of 4 years. This is perhaps the largest data from the Institute of Shaheed Mohtar Benazir Bhutto Institute of Traumatology. Each year, we see these patients, they are referred to emergency department and also at the OPD. At the OPD, we manage patients with minor trauma, fractured tooth, small laceration, to so on many things, which can be managed only under local anesthesia. Next. The patients who have been admitted, again, the number seems to be increasing yearly from 219 till 2022. Total 1,800 patients have been admitted. And those patients who required conservative treatment were not admitted. They were seen at the OPD and then sent home with regular follow-ups. Next. The year 2022 has been very important for us. We were able to start and establish the minor oral surgical unit where all procedures under local anesthesia are performed, ranging from fracture mandible treatment, fracture maxilla, biopsy procedures, cyst enucleations, soft tissue repair, removal of the arch bars, the craniomandibular suspension wires, and so on and so forth. And again, mashallah, mashallah, more than 5,000. Next, please. That's my mission, my vision, to establish Pakistan's first and pioneer institute of maxillofacial and oral oncology. We do not have any institute for this particular expertise, and this is my ambition, my dream, because we want to attain international standards, collaborations, bridges, recognition for the training, for the undergraduate and the postgraduate. At the same time, it's the biggest service which we can contribute to the humanity of this particular country. We have an oncology cancer hospital in Lahore and also in Karachi, but surprisingly, the oral cancer seems to be increasing, very alarming in our society. And each day we see oral cancers. My unit is doing at least 1 to 2 cases of oral cancer every week. And the disease burden keeps on increasing. And we don't know what to do because we are unable to cope up with the disease burden. Next. One case of bomb blast. We again have the honor to start making maxillofacial prostheses in Sindh province from the public sector for the first time in this country. This patient is a case of blast. He was fixing a tire. The tire got burst. He came from Balochistan, a poor chap. These are the stages, to different stages of debridement. We were able to save his mid-face, as you can see on the left-hand side of the screen. And then we thought either to do some plastic surgery procedures, whatever we could, and then the option of maxillofacial removable reconstructive prosthesis was available. My team from the Department of Prosthodontics, Dow International Dental College, was involved, and this is the face which we have. So it is better to have some kind of a face, and as Prof. Huma said, yes, face is your passport, so we must protect it and carry it. It's very important. That's the identity which we all have. Next. My small team, here I am, and it's so heartening to see, to be a part of this particular academic traumatology conference for the first time in Pakistan, where we are trying to bridge the gaps so that collaborative learning, collaborative procedures can be performed. Thank you for your time and attention.
You'd like to say something, sir? Mike? Session. We're taking the questions at the end of the session, Dr. Swenan. Thank you, Professor Katpur, for sharing with us the spectrum of trauma in our society. Our last speaker for this regional session is a vascular surgeon consultant at Aga Khan University Hospital. He is also the chair of Education Surgery Department at Aga Khan University Hospital. Please welcome Dr. Nadeem Ahmed Siddiqui. He will be talking about what's new in the management of vascular injuries in the neck area. Dr. Nadeem.
Assalamu alaikum, everyone. First of all, I would like to thank the organizing committee for inviting me here. And it's such a privilege to be among such a diverse group of people. I can see maxillofacial surgeons, I can see ophthalmologists, I can see general surgeons, plastic surgeons, I mean, you just name it. And obviously, many vascular colleagues and friends. So what I will be discussing today is the vascular trauma in the region of neck, and Dr. Asad has made my life easier by giving his lucid talk on the airway management in trauma. So my major focus will be on the vascular trauma rather than. I'm Nadeem Ahmed Siddiqui. I'm a vascular surgeon, and I'm from Aachen, but here I'm representing very recently formed Pakistan Society of Vascular Surgery, which is just registered now, and I can see many colleagues and senior leaders from vascular surgery, and so I'm also presenting on their behalf as well. So we will start with incidence of vascular injuries in the neck, followed by how they present, imaging, whether it is required or not, followed by treatment strategies and what is new in the vascular trauma management. So we know that vascular trauma is a serious injuries, and out of all the serious injuries, 5 to 10% of the injuries are comprises of vascular trauma in a neck area. And obviously, understandably, civilian injuries differ from the military injuries, and the incidence in civilian population is a bit less as compared to the military population. And mortalities cannot be ignored. It's 2 to 6%, approximately 3,500 deaths per year. It is data from US, not from Pakistan. And men are affected more than females. When we talk about the neck trauma management, the most important thing is the anatomical considerations, which I think is important because as we understand that the neck is a closed structure, and it's surrounded by the bone, thick fascia, as well as the muscles. So there is very little space to expand, in fact. And the problem further complicates because we have within this closed space very important structures. We have airway tract, we have esophagus, we have vessels, we have nerves. And so that is why this, the realization, the management, the suspicion, and the promptness to treatment is very, very important. And it has been, so it is very important to know the anatomy and how you are going to deal the different type of injuries. And there's a very well-known system of zonal classification as a zone 1, 2, and 3. And the cricoid cartilage is one of the things which anything below the cricoid cartilage is zone 1. Between angle of the mandible and cricoid cartilage is zone 2. And from the angle of mandible to the base of the skull is zone 3. And why it is important to know is just not about just from the sake of knowledge, because the different structures present in different zones, they sort of tend you to guide which organs are involved. Also, the management is different, the proximal distal control and the surgical accessibility is very different. So if we talk about the zone 1 injuries, as you can see in the picture, so these are the major vessels which are involved, including subclavian veins, brachiocephalic, common carotid arteries, aortic arch, and jugular veins. Obviously, we cannot just forget the other important structures like lung apices, spinal cord, cranial nerves, and esophagus. Similarly, for zone 2 injuries, we have carotid arteries, vertebral arteries, and jugular veins, followed by the rest of the structures, which include aerodigestive tract. And zone 3 injuries generally include carotid arteries and jugular veins. Obviously, you can see in the picture that trachea, esophagus can always be involved. So if we talk about the neck vascular injuries, initially and how we manage that, we just cannot forget the airway breathing circulation approach of ATLS. And it is all the more important because aerodigestive tract is right in front of us, and as well as the major vessels. So you just, we have to stick to the trauma ATLS protocol. And from the neck injury point of view, we have some hard signs. If there's active pulsatile bleeding, expanding hematoma, absence of carotid pulse, vascular murmur or thrill, or cerebral ischemia, that constitute hard signs, which means the patient needs to be taken to the exploration or the surgery right away without any further imaging, especially if the patient is hemodynamically unstable. We also have soft signs like history and the mechanism of injury, dysphonia, dysphagia, non-expanding hematoma. This sort of should raise the suspicion of vascular injuries, and that can give us time to further investigate these patients. So one has to be aware of these hearts. And the important thing about is local pressure only. We cannot apply tourniquets here. We cannot do very pressure dressing because this is a closed space. It can eventually compromise airway. And the intrinsic temptation of putting a clamp or something in the emergency room is not advisable at all. You can even do more harm than a good. And everything is not as it seems, and the reason being, If you see this type of trivial trauma, which is probably in the zone 2, which is surgically accessible, but we do not know the injury which it has caused. But it means it may be a long object, a screwdriver, or the knife, which may have gone into the aortic arch or the subclavian origin. And obviously, the management will change a lot on that. So that is why the mechanism of injury should be known before you take this patient to OR. Imaging is an important concept. It is necessary or not. Unstable patients, no imaging is required. If there are hard signs of vascular injury, just take them to the operating room. CT angiogram of the neck is important in a stable patient, or if there is a blunt trauma in a lucid patient, or if you want to confirm digestive tract injuries. Chest X-ray is indicated for apical injuries in the lung, for hemothorax and pneumothorax. Conventional angiography, not used for diagnosis, but obviously has its role in the management. For zone 1 injury, the thing is that it's a proximal distal control, and you have to be prepared for doing a sternotomy or thoracotomy depending on the right or the left side of the injury of the site neck is injured. For zone 2, it's a good area for surgeon because the proximal and distal controls can be obtained surgically. So this is the area in which you advise the patient for a surgical exploration. Zone 3, the distal control is very difficult because of the base of the skull sort of hinders the for getting the distal control. So this is why zonal division is very important. If we talk about certain injuries like carotid artery injuries, so in any patient who is lucid, who is not comatose, who is not unstable, penetrating internal and carotid artery injury should always be repaired. Ligation is not advisable at all. We do ligations only when the patient is unstable, and now with the advent of the shunt or the temporary shunts, you can always put a shunt in the proximal and distal part of the arteries, take the patient to the ICU, resuscitate, and you can always bring him to the operating room for the definitive repair. So ligation is not an answer anymore. External carotid artery can be safely ligated if it is causing significant hemorrhage. For carotid artery, proximal and distal control is a must. Primary repair and patch repair can be done, especially if the injury is a dialysis access catheter induced or a small injury involving less than 30% or the 20% of the diameter. You can just put a stitch or two and you can get away with that, or put a patch repair. But if the segment loss is there, then you can always use a saphenous vein graft. Because of the trauma, there's chances of infection. You can see the two ends here which are repaired with the vein. You can always use PTFE graft, and also the external carotid artery can also be transposed to the internal carotid artery for the sake of revascularization. Ligation is not ideal. For venous injuries, if you are thinking about isolated venous injuries, most of them can be managed conservatively in a stable patient. And if there is active bleeding going on, there is a new concept of putting a Foley catheter from the bleeding wound, and you can inflate 1, 2, 3, 4 Foley catheter, inflate them so that the bleeding can be stopped. But if the bleeding is not controllable or there are suspicion of arterial or aerodigestive tract injuries, obviously surgery is indicated. Here you can see 1 Foley catheter has stopped the bleeding. It can also give you the time for resuscitation and managing this patient. And usually these lesions heal well if we are talking about isolated venous injuries only. There is also certain unusual presentations, like a patient can present with neurological deficits, Horner syndrome, and carotid murmur, or the neurological deficit with normal CT scan. In such situation, you should always think of a blunt injuries, especially in carotid artery dissection. Or post-surgery, if there is a hematoma in the carotid wall, it can present with Horner syndrome. So one has to be aware of these. And you can see such a picture in the Horner syndrome, and you can see the carotid artery dissection in the CT images and the conventional images. High index of suspicion, ultrasound CT can be misleading, so MRI or the conventional angiography is the answer. Blunt trauma is now been educated as a separate entity for vascular injuries, and there's a BIF classification. You can see class 1 injury indicates if there's labinal irregularity less than 25% of narrowing, class 2 more than 25%, class 3 is pseudoaneurysm, 4 is occlusion, and 5 is transection. So based on this, grade 1 injuries can be managed conservatively, grade 2 injuries, surgery is recommended. Grade 2 and 3, 4 injuries, anticoagulation is important, as well as now the endovascular treatment is advised for the management of grade 2 and 3 injuries with the advent of stents. Same goes for the vertebral injuries. Low-grade injuries can be managed with conservative treatment. High-grade injuries should be managed surgically, or even now you can do angioembolization of the vertebral artery for bleeding arteries. So what's new? CT scan is now very, very much available. It's used everywhere, and it has sort of also used in the blunt injuries. Endovascular interventions are now very much common. They are both accessible as well as, because expertise has been developed, people have developed their skills, and also the advancement in the technology has helped us a lot. The stents and the balloons and the coils, they have been advancing day by day. Carotid artery shunting is mostly required, not only during the operation, but if it's a damage control surgery, you can always put a temporary shunt. And we have now a better evidence to treat and diagnose the blunt vascular injuries, which were sort of missed in previously. These are some guidelines which have showed the use of blunt trauma management as well as selective operative management for such patients. To summarize, so initial management according to ATLS protocol, urgent surgical management on unstable patient. If instability is caused by hemorrhage, you can use Foley catheter for hemostasis. CT angiogram in all patients, they can reduce the risk of surgical examination as well as the complications. Also, in asymptomatic patient, if the mechanism is not good. Observation is same in asymptomatic patient, and angiography and interventional radiology are now a diagnostic as well as therapeutic tool, avoid unnecessary surgical interventions. With this, I would like to thank you, and if there are any questions, I think we can take it after the panel discussion. Thank you.
Thank you, Dr. Nadeem, for expanding our knowledge on such an important area of trauma.
Ladies and gentlemen, we now have a paper presentation by 3 participants. First paper will be presented by Dr. Rabia Anwar. She is a registrar in plastic surgery department at SMBBIT, and she will present the talk on the retrospective study on early scalp coverage versus scalp rotational flap and graft. Please, Dr. Madhi.
Dr. Rabia.
Dr. Rabia, sorry.
इससे खुद पढ़ेंगे ऐसे ही ठीक है चेंजर ये आपका ले लो जब इधर नेक्स्ट करें तो उधर भी नेक्स्ट करें अच्छा दोनों से करना पड़ेगा Assalamu alaikum everyone. I am Dr. Rabia. I am a fellow plastic surgeon and currently I am working as a registrar in the Department of Plastic Surgery at Shaheed Mohtarma Benazir Bhutto Trauma Center under the esteemed guidance of our head of department, Dr. Hassan Kashif. Today I'll be presenting the paper that was conducted in our department on early scalp coverage with scalp rotation flap and graft, our experience at a tertiary care center in Karachi. Okay. Scalp defect, they present a distinct challenge for reconstructive plastic surgeon, as they must not only address the need for bony coverage in cases where the periosteum is absent and there is a defect in the bone requiring cranioplasty, but also ensure timely intervention. Exposed bone is prone to desiccation and necrosis, so making early intervention crucial in order to prevent further complication. While providing coverage is important, aesthetics should also be taken into consideration when reconstructing a scalp defect. In this regard, flaps offer a distinct advantage over graft. Flap have the ability to incorporate hair transplantation, allowing them to effectively conceal the defect and achieve a more natural and aesthetic appearance. By utilizing flap, plastic surgeons can not only address the functional aspect of the reconstruction, but also enhance the future cosmetic outcome of the patient. Okay. Scalp rotation flap, when combined with skin grafting at the donor area, can serve as a viable option for covering extensive scalp defect without restoring to free flaps. The combination provides the ability to address large defect covering approximately 40% of the scalp surface. By employing this technique, surgeons can effectively reconstruct a huge scalp defects while minimizing the need for more complex procedures. While free flaps such as LD flap and or ALTF flap are well suited for large defects, they may not be preferred choice in the trauma setting where the risk of wound infection is significantly high. In such cases, other reconstructive techniques such as local flap or graft are often favored due to their low risk of infection and simpler surgical approach. The decision on the choice of the flap or technique depends upon various factors like the nature of the defect, the patient condition, and the surgeon's expertise, with the ultimate goal of achieving optimal functional and aesthetic outcome while minimizing the potential complications. In order to establish a scientific basis for our general practice of performing early scalp flap, we conducted a study to evaluate the outcome of patients who underwent scalp rotation flap and grafting within 5 days of injury. Additionally, we aim to assess the impact of contamination level on flap and graft failure. It was a single-centered retrospective study that was conducted in our Department of Plastic Surgery at Shaheed Mohtarma Benazir Bhutto Trauma Center. All the consecutive patients, they underwent scalp rotation flap or grafting between the month of April 2022 till March 2023. For the purpose of this study, we specifically included patients who experienced scalp trauma and subsequently underwent scalp rotation flap and grafting procedure. However, all the patients with scalp defect resulting from other causes were excluded from this study. During the study period, total of 16 patients met the criteria, and these patients spanned a wide range of age, as young as 1.5 years to as old as 60 years, with the mean age was calculated to be 21.9 years. Most of our patients in the study were male. Out of the 16 patients that were included in our study, only one patient experienced a fall from the building as a cause of their scalp trauma, while the remaining patients had a head injury resulting from road traffic accident. In this study, mild contamination was defined as the wound that were previously debrided with no foreign body or devitalized tissue. Moderate contaminated wounds were characterized by the presence of devitalized tissue but no gross pus. And severely contamination was referred to as wound with the evidence of pus. Duration since the injury till referral to plastic surgery, we receive almost all of our head injury patients from neurosurgery department, and the mean time of referral since the injury was 31 hours. Time from injury to the coverage, we covered all the patients included in the study within mean time of 58.25 hours and with a maximum delay of 93 hours. The total size of the defect after debridement was calculated, and the maximum size of the defect was 216 centimeters square. Surgical procedure was performed. We did scalp rotation flap in all of our patients, and donor area of just one patient was closed primarily and didn't needed a skin grafting. Flap and graft survival. Almost a total of 16 scalp rotation flap was done, and merely 3 experienced partial loss, and out of those only 1 required regrafting. Similarly, out of the total 15 grafting patients, 9 encountered partial loss with only 3 necessitating regrafting. Showing few of the results as due to the time issues. Due to the, this is a patient that was referred to us, and he sustained a scalp injury, and craniotomy was done. And we did a scalp rotation flap with donor side grafting, and his post-operative outcome was unremarkable. There was no flap or graft failure. Likewise, we had another patient who underwent cranioplasty and experienced complete success in both graft and flap integrity. This patient was debrided and scalp rotation flap with skin grafting was done. There is partial loss of both graft and flap, which we managed. The graft and flap was managed conservatively, and the outcome was a success. This patient had partial loss of the graft, which was conservatively managed, and he recovered completely. So concluding, based on this study, we can draw the conclusion that scalp rotation is a safe and effective procedure. Even for moderate contaminated wound, it provides to be beneficial for even neurosurgeon in achieving adequate and healthy coverage for early cranioplasties. Additionally, it is worth noting that in the majority of the cases involving partial flap and graft loss, resurgery was not necessary. Thank you.
Thank you, Dr. Rabia. Our next paper is by Dr. Maria Shabir, fellow working at the Department of Oral and Maxillofacial Surgery, SMBBIT. And her topic is a 2-year retrospective study on frequency of orbital fractures in maxillofacial trauma we see at Shaheed Mohtarma Benazir Bhutto Institute of Trauma. Dr. Maria, please.
Assalamu alaikum everyone. I'm Dr. Maria Shabir, fellow at Oral and Maxillofacial Surgery at Shaheed Mohtarma Benazir Bhutto Institute of Trauma. First of all, I would like to thank all seniors and respectable guests who joined us, and would also like to thank my HOD Professor Shahjahan Katpar, who gave me opportunity to present this this paper with you. So this is a retrospective study showing frequency of orbital fractures in facial trauma patients. Facial trauma currently constitutes a major social and public health problem because of its high frequency and magnitude, as well as its association with the road traffic incidents, violence and insecurities. Orbital fractures are a part of middle third facial fractures. They are associated with damage to the surrounding structures, as well as damage to the orbital contents, and it communicates orbital cavity with the cranial cavity, sinuses and the nasal cavity. In US, about 3% of the ER visits are because of the eye or orbital injuries, whereas a large European study shows that 16% of the maxillofacial fractures are orbital fractures. In our region, we are having limited data with scanty details, so we choose the topic of orbital fractures in maxillofacial patients, trauma patients, from January 2021 till December 2022. About clinical records of the facial trauma patients were reviewed, and those having orbital fractures were selected. Patients who already have orbital traumas and ophthalmic complications or vision loss were excluded from the study. Total 211 patients were selected, and in age, gender, etiology, type of fracture, ophthalmic complication and treatment provided were noted. As per our departmental policy, informed consent was taken from every patient for research and photography undergoing surgery. Fortunately, at our institute, when a patient arrived with the symptoms of orbital fractures, patient is reviewed by both ophthalmologist as well as by the maxillofacial surgeon, and a joint decision is made whether to treat the patient surgically, conservatively, or need a consequent follow-up in OPD. 94.8% of our patients were males and only 5.2% were female. The most common cause that we encountered was road traffic accident, that is 96.7%, followed by fall, gunshot and blast injuries. 18.5% of these fractures were bilateral, 35.1% were on the right side, and 46.4% on the left side. Associated ophthalmic complications that we encountered were eyelid lacerations, corneal abrasion, chemosis and hyphema, restricted eye movements, blurring of vision, diplopia and vision loss. We classified our patient trauma according to Hammer's classification. According to type 1, that is orbital fracture along with the zygomatico complex fractures, type 2 internal orbital fractures, type 3 fractures associated with NOE, and type 4 constitute the complex facial fractures. 82.5% of our cases were type 1, 0.5% type 2, 5.2% type 3 and 5.7% type 4 fractures. Rest of the fractures were combination of 1 and 3, 1 and 4 and 3 and 4 respectively. These are the different pictures from which patient presented to us involving the orbital fractures. Here I am just giving a brief review of a case presented to us with a complex facial fractures. This is a pre-op picture in which we raised a biocoronal flap, orifice was done, and the last two pictures on the left side shows frontal and profile views. Different treatment strategies were adopted as per availability of the facilities and expertise, most of which were open reduction, internal fixation. We will also treat patient conservatively in few cases, ranging from transosseous wiring, craniomandibular suspension and elevation techniques. Of total 825 trauma patients that we encountered in 2 years,
25.5% of cases are of orbital fractures with a male predominance and mean age of 25 years. Whereas a similar pattern is seen in Western world, where there is a male predominance along with, but there is an age range of 48.3 years. But we are having a younger population as compared to Western world. In our study, the most common mechanism was RTA, whereas in other part of the world, the physical aggression and falls were the major causes, followed by a road traffic accident. Bilateral fractures, as already discussed, were lesser as compared to the fractures on the left side, and similar patterns were seen in the rest of the world. Ophthalmic complications that we encountered were major ophthalmic complications that include restricted eye movements in 4% of cases, blurring in 7%, and diplopia in 4% of cases, where in the Western world, in the study conducted in US and South Korea, diplopia were much significant, like 37% and 44% respectively, as compared to our studies. Among 211 patients, different treatment strategies were adopted. Most common that we are used to treat our patient with open reduction. But in the study at the Netherlands, we appreciate that most of their fracture was orbital blowout fracture, in which they choose the treatment of modality conservative, that is 69.2, almost 70%. Zygoma repositioning with fixation and without fixation were 6.6 and 9% respectively, and plating was done in 11% of cases. Conclusion. Understanding the cause, severity, and type of facial fractures can help in effective prevention of these injuries, such as by wearing helmet and obliged traffic rules, as well as reduction of aggression and violence. The epidemiology of orbital fracture is constantly evolving, and a periodic review of these fractures can provide valuable clinical information. The goal of the study is to evaluate the most common type of the fractures, associated facial fractures, etiology, ophthalmic complications, and their management in patients with orbital fractures. Referral to consult department in timely manner is the key to adequate management of the patient. Multidisciplinary team approach should be adopted. In the end, these are the references. In the end, I would like to thank my colleagues for helping me out in statistical analysis and data collection. Thank you.
Thank you, Dr. Maria. It was a wonderful presentation. Now, last paper is by Dr. Naima Iftikhar. She is resident medical officer at plastic surgery at Shahid Mohtaram Benazir Bhutto Institute of Trauma, and her talk is on the study of the reconstruction of orbit in periorbital area after the trauma. Please, Doctor.
Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Naima, and I'm a resident medical officer in plastic surgery in Shahid Mohtaram Benazir Bhutto Institute of Trauma, and we work under the supervision of our head of department, Dr. Hassan Kashif. And I'll be presenting a paper on reconstruction of eyelid and periorbital area after trauma. And it is an experience from our newly established plastic surgery unit of a Level 1 Trauma Institute of Pakistan. So it is famously said that eyes are the windows to the soul. So we can all very well imagine that if the orbital region is injured, its reconstruction poses a heavy burden of aesthetic concerns. So the objective of our study was to evaluate the types of eyelid and periorbital effects and their reconstructive outcomes, to make a more streamlined plan for management and for community awareness to prevent such injuries. The orbit is a difficult structure to reconstruct because it contains within it a complex architecture with overlying soft tissue and involves many important anatomical structures. And globally, over 500,000 of people are affected by eye injuries each year, which is a heavy burden. So the most common type of injuries that we faced in our department were foreign bodies, open wounds, contusions, and burns. And orbital trauma can result in complications in form and function. However, the education and public awareness regarding the prevention of eye injuries and their immediate management have been neglected. Okay. So the timing of operative repair as well as reconstructive method is dictated by the patient's individual presentation and have wide implications on the end result. This study was a retrospective descriptive study which was conducted at Shaheed Mohtarma Benazir Bhutto Institute of Trauma, which is a level 1 trauma center in Karachi, and it included all the consecutive cases of orbital reconstruction which were carried out in the plastic surgery department from April 2022 to March 2023. The patients that we included presented with eyelid and periorbital wounds requiring orbital reconstruction, and all those patients which had complex facial defects requiring multiple reconstructions were not included in the study. Also, the patients presenting with major polytrauma in which orbital reconstruction was delayed due to more life-threatening injuries were also not included. So the types of reconstruction we performed in our department were repair of complex eyelid lacerations, local flaps, release of contractures, and release of ectropion. The outcomes were measured in terms of function and aesthetics, and it was graded as poor, average, good, and excellent. Also, the complications and patient satisfaction were also measured. So the results that we have seen, we performed 6 cases throughout the study period, out of which 5 cases healed without any complication, and there was only 1 case in which a secondary correction was required after the primary procedure. So this is one of the cases in which this middle-aged lady presented with history of road traffic accident, and she had left lower eyelid and periorbital injury and loss of tissue. So after initial debridement, we performed local tissue readjustment, and the second picture is of 14th post-op day in which the patient presented with post-operative, post-exposure keratitis. So this patient required a reconstruction of the lower eyelid. Bilaminar reconstruction was performed. The outer lamina was constructed with nasojugular flap, and the inner lining was taken from labial mucosa, and you can see the graft is well taken as a conjunctiva. So you can see this is after 3 months post-op, and this patient had a good aesthetic outcome, and the patient was very happy. So this little child presented again with road traffic accident and had full thickness loss of the upper eyelid. Again, the reconstruction was performed, which required bilaminar reconstruction, in which the outer layer was recreated with nasojugular flap, and the inner lining was taken from the labial mucosa. And you can see this patient, this final picture is before the division of the flap. And the family was quite happy with the results, and it has a good outcome. This was a lady who presented with road traffic accident, and she had a deep laceration of the lower eyelid. After initial debridement, it was grafted with full thickness skin graft taken from the post-auricular region. Also, this patient had a good aesthetic result and was satisfied. This is a patient who presented with road traffic accident, and he had a post-traumatic upper lid contracture and a lower lid ectropion. The contracture and the ectropion both were released, and both of the upper and lower eyelid were grafted with full thickness skin graft. So the aesthetic result is quite good, and the patient was also very satisfied with the results. So after the end of this study, we can conclude that every visible deformity in the facial region of the patient affects their mental wellness and perception by the society. Deterioration of health leads to decrease in the performance, and timely intervention with proper preoperative planning and availability of multidisciplinary care can result in good aesthetic results. Thank you.
Thank you, Dr. Naima. I would like to thank all the participants and speakers for being a part of this exemplary session. We would like to proceed to the panel session, until the arrangements are made for the panel session. I would like if all of you could take a quick 10 minutes tea break. Go, please, and bring your tea back here so that we can start off with the panel discussion, because the next session is already in waiting. 5 minutes, okay. Running tea. So please bring your tea back here. We would be really grateful. And I'd like to request the organizing team to kindly make arrangements for the panel session in the meanwhile. And we'll take the question and answer session right at the end, right? Thank you. Please, 5 to 10 minutes. 5 minutes, please. Again, just a reminder. Thank you. Chal raha hai? Okay. Could I request all the participants to please come back? Dr. Hassan, could you please tell the participants to join us back? Thank you. Presentation laga. I think we should start now. Most of our participants are back. Aajo, aajo. I think most of us are here. Thank you all for waiting. Proceeding further with this session, we would like to start with the panel discussion.
Hello, hello. Hello, hello. Hello, hello.
Can we all please be seated? Dr. Shahjahan?
Hello.
Okay. So starting with the panel discussion, I would like to request Professor Shahjahan Katpar to please come on the stage to moderate this panel discussion. Next, we would like to introduce and invite the panelists for this discussion on the stage.
Professor Dr. Huma Khiani Saigal, HOD Ophthalmology at Fatma Jana Medical University and Sir Ganga Ram Hospital, Lahore. Professor Dr. Sajda Qureshi, Professor of Surgery at Dow University of Health Sciences, Karachi. Professor Dr. Kashif Chandrad, Chairman Oral and Maxillofacial Surgery at Liaquat University of Medical and Health
Hello.
Sciences, Jamshoro.
Hello.
Dr. Azhar Sheikh, Head of Department of Emergency at SMBBIT. Dr. Asad Shabir Bukhari, Classified ENT Surgeon at CMH Banu. Please, sir.
Next, we have Professor Dr. Safia Zafar, Head of Department of Anesthesiology at Ruth Fowle Civil Hospital, Karachi. Dr. Nasser Sadal, Pediatric Surgeon and Executive Director at NICH. Professor Dr. Tawqeerul Islam, Consultant Oral and Maxillofacial Surgeon at Liaquat National Hospital, Karachi. Dr. Fiza Iftikhar, Consultant Thoracic Surgeon at Shaheed Mohtarma Benazir Bhutto Institute of Trauma. Dr. Saeed Amir Ali Shah, Consultant Orthopedic Surgeon at SMBBIT. And Dr. Hassan Kashif, Consultant Plastic Surgeon at Shaheed Mohtarma Benazir Bhutto Institute of Trauma. I think Dr. Imran will join us in a few moments. He's in his session. And likewise, Dr. Fiza will also be joining us soon. Thank you.
Assalamu alaikum. Can you all hear me? I'm heartened for all the participants for their participation. This is a new era, I feel. Dr. Haja, can we have the please case report?
So I will be presenting a case about one of the thousands of trauma patients received at Shaheed Mohtarma Benazir Bhutto at OMFS department, and how he was managed in a stepwise manner via a multidisciplinary team approach.
Now let me finish my job, please.
Okay, so we have a 20-year-old male plastic collector by occupation from Karachi. He presented to us with history of road traffic accident. His chief presenting complaint was facial lacerations, loss of consciousness, and inability to maintaining oxygen saturation. He presented with nasal and oral bleeding, and there was a swelling at right thigh. On further examination and history taking, this was a history of road traffic accident where was the collision between a bike and a car. He was taken by the ambulance to Shaheed Mohtarma Benazir Bhutto Institute of Trauma, Karachi Emergency, where first aid was given. He was brought and all concerned departments were called as part of the multidisciplinary team approach. There was positive history of loss of consciousness, and at that time in the ER, his GCS was found to be 8/15, and there was nasal and oral bleeding. Multidisciplinary approach team was taken, and first aid was given. Neurosurgery teams, ENT team, OMFS team, GS team, and cardiothoracic team, along with orthopedic anesthesia team, they all attended the patient likewise in a stepwise fashion. He was retained in the ICU by the neurosurgery team due to poor GCS. The clearance from all specialities was advised before he was admitted in the Department of Oral and Maxillofacial Surgery. His past medical history was just that he had jaundice 1 year back, but he was hemodynamically stable and proven by lab investigations. There was no remarkable surgical history or dental history. Family medical history was just that his father had diabetes type 2. His parents were alive, having 3 siblings, all were healthy. And he was a driver by plastic scrapper collector, having poor socioeconomic status. So when we see his management that was done at the SMBBIT emergency, so the emergency team, they managed him as a polytrauma case and first aid was given. Anesthesia team, anesthesia team attended the patient, and since the patient was not able to ventilate and he was not maintaining his SATs, so the intubation was done in the ER. Neurosurgery team attended to him because of the base of skull fracture, and he was advised to retain in the ICU again because of low Glasgow Coma scale. General surgery team attended the patient because he had bilateral pneumothorax with lower lobe collapse. Lobe was collapsed. So chest tube replacements were done, and they were done in the ER under local anesthesia, which was initially very painful for the patient, as patient was not intubated by then. Orthopedic team had attended the patient, and he had a femur fracture. Skin traction was done, wound was cleared, and ORF was planned for later once the patient was stable. He was operated, although under GA later on, but it was not joint surgery by us and or by maxillofacial and orthopedic. It was a separate surgery, so 2 general anesthesias were given. Then when the patient was admitted with us, he had lacerations. He had a symphysis fracture and a right condylar fracture also. So in the ER, lacerations were repaired, wiring was done, and for later on stages, or open reduction internal fixation was planned. Cardiothoracic team was following the patient for the chest tube that was placed in the ER by the general surgery team. And they were looking after the local wound and chest injury. Post-op care was done. Infectious diseases was always on board for infection prevention and choice of antibiotics in our patients. That's his consent form that we take for procedure and research and purposes. These are some clinical pictures where we can see the bilateral chest tube which is placed, the patient's clinical facial profile picture, and then this traction for femur fracture is also placed in the lower left picture. These are his radiographic examinations where he has a chest x-ray, chest CT cap was done since he had a bilateral pneumothorax, and there was a PA view of right leg for the femur fracture so that further management was done according to these. This is the CT scan head and face with 3D reconstruction where we can appreciate a symphysis fracture and a right condylar fracture, left condylar fracture. For definitive diagnosis, once he was cleared, his GCS was normal, he was awake and stable. So there were 2 definitive diagnoses. One was that he had an orthopedic problem that was a right femur fracture, and then he had a symphysis and a left condyle fracture of the craniofacial region. So both were treated with open reduction internal fixation under GA. For maxillofacial, we was treated with mini plates and MMF via arch bar under general anesthesia. These are some of his post-operative pictures where we can appreciate his occlusion. That's exactly our main concern. And we can see the bony reduction in the X-ray also. These are his post-operative radiographs for the femur fracture that was undertaken by the orthopedic team at our hospital. So I would like Professor Shahjahan Katpur to please take it from here to moderate the session further. Thank you.
Thank you, Hajra. I'm heartened to see, and yes, we are running short of time, but there are a few things which I would like to explain. The objective of this entire exercise is not to target any specialty or any individual, but to reduce the gaps. We talk a lot about multidisciplinary team management, but we hardly perform. We are all performing our own work at a respective specialized individual areas. So we will try to bridge this gap. Perhaps this is a new dimension which we need to follow. My first question would be to Professor Huma. Tell us about what are the clinical features of retrobulbar hemorrhage, and can any other non-ophthalmological surgeon perform this life-saving procedure for a person?
Okay, so there are 2 questions, right? One is, what is the treatment management of retrobulbar hemorrhage?
Precisely.
And second, can anybody else do it
Yes.
also? Okay. If you're talking about a doctor, yeah. But if you're talking about a non-professional, I would refrain somebody from doing that. That's the answer to the second one. And again, I'll talk about in a little detail about why I'm talking about that a doctor should do it and they should know it. When we talk about retrobulbar hemorrhage, we need to look at the point, what exactly is a retrobulbar hemorrhage? It can occur due to many reasons. It's not just because of the trauma to the eye, just not it can be due to your surgical procedure also. Many of the plastics that people are operating now, simple blepharoplasty, a simple eye change, or a simple retrobulbar injection given to the eye can cause a bleed at the back of the eye and can result in a very tightening of the eye. So you need to know what are actually the symptoms that are causing these retrobulbar hemorrhage, whether you need to observe these patients or whether you need to treat these patients. There are certainly certain retrobulbar hemorrhages that can be just prevented by just simple massage of pressure on the eye. It can reduce the leaking blood vessels. And there's a retrobulbar hemorrhage that will just cause such tremendous pain, pressure, double vision, and a compression to the optic nerve and vascular occlusion. So all that becomes an emergency. So both ways you need to look. If it is like due to a surgical procedure, and everything has to be done within a couple of maximum few hours. Because if the optic nerve, I'll repeat again, if the optic nerve gets affected, so optic nerve, because eye is a part of the brain, so if the optic nerve gets compressed or gets affected because of this pressure effect of the retroviral hemorrhage, it has got 100 minutes. In 100 minutes time, there will be, let's say, there won't be any reversal then. And if the 200 minutes have passed by, then there will be a total optic atrophy. So that patient will go blind, whether their retroviral hemorrhage is removed or not. So it's like a tick-tock, time is ticking. So now you need to look at what has caused it. If it is because of your surgery, if there is a bleed or a trickle, you can apply pressure. So important thing is that you look at the pain element and the vision. Check the vision if the vision is, getting affected, or even if you can't check the vision because the patient is in pain, look at the pupils. So if the pupils are getting dilated, there is a relative pupillary defect coming up, that means the eye is getting affected. So that retroviral hemorrhage has to be evacuated. How can you evacuate? You can do a pressure, you can do medical treatment in the form of you give them hypoosmotic agents. The hypoosmotic agents can reduce the intraorbital pressure.
Thank
right?
you. So what I can understand from your input is that just like cardiac tamponade, which is again a life-saving emergency procedure, we can all perform this particular treatment if there is a requirement.
No, you can. You can just give a cut on the lateral side and you can allow the blood to come. But that is if it is actually threatening your vision. If not, you can wait.
Okay, fine. Thank you. My next question would be to Professor Nasir Sadal. We also get maxillofacial pediatric trauma, infants trauma at the same time. Since you are working as a pediatric surgeon at a very important unit, so what is your experience? How do you manage these patients with facial trauma and general trauma, and what is your input about the referral culture?
Thank you. Bismillahirrahmanirrahim. Yeah, I am, because everybody is doing his work at his stations very nicely and performing things very good. But I am morely concerned the referral conditions of our city, which is not that good. I think so this child is very lucky that he has been reached in a time and receive all the services from all the vicinities on a single roof. But most of the time, the patients which approaches to us is dependent upon the driver, who is the ambulance driver who is bringing the patients. So where he gets to land the patient first and when the patient goes there, so most of the time is wasted during this transportation of these patients. That is my first concern. So should we have some special arranging on this organ that they should plan, they should know where to send the patient first of all, and where this patient get the benefit of his for all of his management plans. Second, the question regarding the management of such cases, no doubt, in pediatric cases, as we also adjacent having our mother institute of Jinnah Institute, so maximum of the trauma patients which are being came with the head injuries or roll traffic accident, they are first landed to the JPMC, and after that they had been referred us. If they have other than some organ injuries, abdominal, thoracic, they have been referred us. So we are the second on that part. We didn't receive directly maximum injury patient from our side. But no doubt, the referral is the main concern for me, because most of the patients which landed to us after 38 hours or 48 hours of their injuries. So at that time, to manage that patients make us more difficult, and the morbidity is more in that patients.
Okay, thank you, sir. Dr. Fiza, is she here? Okay, so since we do not have a thoracic surgeon, I'll skip that particular area. My next question would be to Professor Sajida. How do you handle patients with facial trauma, with abdominal trauma, because it is important, and sometimes these patients who have facial trauma, they get neglected and they're not properly examined because of different reasons. So how do you see that? And another important thing is that we are trying our best to give patient a single general anesthesia and do collaborative surgical procedures at the same time. So
thank you, Shah Jahan. I think that's a very relevant question which we face all the time. And I think general surgeons would be the first ones to agree with you with the concept of MDT in trauma, because we are the ones who face the brunt of it, and we end up having the patient, and then we are running after different specialities to please come in and give their input. So the way how things go right now is that at the time when we receive the patient with multiple injuries, naturally, along with GS, other units are given the call as well. So it all depends on the synchronization and whether you are getting any response from them or not. So as far as abdominal trauma and naturally facial trauma, like you told us that it's very important because the major airway needs to be protected. So there we are usually helped in, even if the relevant specialty does not come in on time, we are helped by our anesthesia colleagues always to maintain the airway and all. And then once the patient is stable and after naturally addressing the abdominal trauma, then we face that dilemma of getting the relevant specialties on board. The good thing about trauma center nowadays is that we do have the system in place in which multiple subspecialties are called at that time. But what we have been facing so far is in majority of the instances, majority of the subspecialties would just come and say, oh, doesn't need any emergency treatment. You deal with the emergency aspect of it, and then you refer the patient to us. That's the commonest, that you would hear in emergency situations. So that is what it is, and I think we as general surgeon, I'm sure I'm representing all the general surgeons when I say that we would like the multidisciplinary, team effort in trauma, because that is going to be really, really very helpful in future.
Grateful, thank you. Next question, Professor Safia. Since we are trying to promote multidisciplinary team, and every surgical procedure is time consuming depending what you are doing, maybe half an hour to 1 hour. So what is the maximum time duration for which a patient can be anesthetized in an emergency case? If you're talking about at least 2 to 3 specialties being involved, because the drug interactions and everything. So you're the best person, and for how long? 12 hours, 8 hours, 10 hours, what?
Thank you, Shahjahan. सबसे पहली बात ये कि आप मुझसे डर के खड़े क्यों हो गए? इसका मतलब ये कि एनेस्थीसिया वालों का थोड़ा रोब है हमारा. Thank you for your question. Actually, there is no time. We can give anesthesia for a minute or for a day, for 24 hours, for 48 hours. When the patient is on ventilator in our ICU, we are producing sedation and muscle relaxation and anesthesia to him. So there is no time limit. We can give anesthesia whatever you want.
Okay, that's great, because this is one thing which I used to hear from my colleague है जी, इस पेशेंट का पैर टूटा है, ये टूटा है, तो उसको एनेस्थीसिया हम इतना दे सकते हैं, उससे ज़्यादा नहीं दे सकते.
No.
इसको let me say what I have to say. And then once one surgery is done, patient एक specialty से फारिग हुआ, ICU में गया, HDU में गया, बाद में इसकी फिर surgery होगी. So multiple anesthesia will cause hepatic toxicity, which is not right. So thank you, आपने आज ये बात कह दी, which means के at least 3 to 4 specialties can serve a patient, save a life.
Yes.
Dr. Azhar, sir, you are the most important person because you receive first hand the patient. आपकी बहुत बड़ी जिम्मेदारी है to establish, prioritize patients, to coordinate, and at the same time to give messages. And yes, ATLS basic protocol is always followed, but sometimes I feel कि हमारे patients जो हैं वो रह जाते हैं, कभी उनका opinion नहीं होता because of different reasons. And yes, limb injuries and all these things are very important. So sir, your input.
Thank you very much, Professor Katpar. It's a good talk. Really appreciate it. Was long awaited. We were discussing for several months. So this is a good opportunity. The right audience, all the specialties are here. Being an emergency physician, as you already mentioned, that we look after all the patient, whatever is coming through the door, especially in the trauma center. So you mentioned about the ATLS, so we cannot put the ATLS away from our practice. We've been doing it in our own way or different way, but we have to follow it. Primary survey is the important thing which we all know, and this is what we prefer. The patient comes in with the polytrauma, my priority is A. Once I have done with the A, including a hemorrhage, then I will move on to the B, and then C, and then D. So if the maxillofacial concern is related to the airway, say for example, if there is a shattered fracture of the mandible, which I predict that this is going to make a problem with the airway. So I'll look into that first, okay? Most of the times what we face here, that the initial management which has been done in the ER by other specialties, including the ER, is done quickly. The problem starts when the patient gets admitted into the ward. Suppose we talk about the trauma center, we've got Bay 1, Bay 2, ventilation bay. Once the patient is moved there, there is a need to do the secondary survey. We lack this, okay? We all know about the ATLS primary survey being done, okay? But the secondary survey is the one where you pick all the problems, even if it's related to the maxillofacial, if it's related to the ENT or any other specialties. So my priority is A, B, C, D, E. Once that's been done, then we will move to the secondary survey. So I think the next thing should be that we should have organized MDT meeting in the organization, in the hospital, where all the stakeholder comes and discuss individual patient. So we take a lesson. We all go for the ATLS and different trauma courses, but we need to take it further to make it practically happen. Thank you.
Grateful. Thank you, sir. Next, Professor Kashif. So what is your...
Can I add something?
Yes, sir. Please, Professor Tawqi.
I think this is what Dr. Saab has said. It's always better to have a trauma team constituted by the organization. There should be a trauma team which has all these specialties, and that should be on call at once. So the primary survey is taken care, as he said, ATLS. Then those who are involved, it's all already written down. What is who's the problem has got. So that can be taken care of by the secondary survey. So I think that what we are lacking in major hospitals is a proper trauma team जिसको call किया जा सके for the emergencies at that time.
Great.
That should be initiated up, and it should be composed of everything which is there, and that I hope will cover up a lot of problems, because I have seen हम लोग हमारे अपने सेटअप में इलाका नेशनल की सेटअप में भी होता है, हर जगह भी मैंने उससे पहले भी सिविल में बहुत काम किया. तो क्या सर्जन आया, काम किया, फीमर वाले ने अपना काम करके चला गया, वो चला बैठा हुआ. आई में अगर देयर इज अ ऑर्बिटल ट्रॉमा, तो द पेशेंट हैज़ गॉट दैट हैज़ टू बी वेट फॉर कि जी के उसको आई की कंसल्टेंसी चाहिए, एंड नाउ ही हैज़ गॉट डिप्लोपिया, ही हैज़ गॉट एनाप्थेलमस. उसको करते करते पता चला जना 15 दिन गुजर गए. एंड दिस इज सो कॉमन. आई रिसीव पेशेंट्स, तो उस एनाप्थेलमस और डिप्लोपिया फिर वो ठीक नहीं होता. So the time bar is very important for the secondary people to evaluate. About that all matters with the trauma team. और trauma team के साथ आप initiate करेंगे, आप अपने hospitals में ये trauma team initiate करेंगे, तो उनको पता होगा यार this is the management of this particular cases has been done. अब GCS 3 में बैठा हुआ है, 4 में बैठा हुआ है, एनेस्थीसिया वालों ने एक को लगा दिया, दूसरे को कह दिया जी आपके लिए टाइम नहीं है. ये कॉमन है, दिस इज वेरी कॉमन. अभी उसके लिए ठीक है, हमारे लिए ठीक है.
Thank you, sir. Dr. Ahmed Ali Shah. My apologies to the second session. We are getting late, I can understand, but because this is a very important topic, I feel, so I will need your support. My humble request. I know, I can understand we are all getting late, but please bear with us for 10 minutes more. Sir, a limb trauma, how, the problem which we face is कि जी limb टूट गई, fracture हो गया, आपने उसको ठीक कर दिया या नहीं किया. हमने maxillofacial ने, we close the mouth, and then after a week you come up, he needs to be intubation, and then please open the mouth. So that creates problems for all of us. Patients who are given fixed implants, that is fine, but some patients we cannot provide rigid fixation, so their mouth has to be closed. Sometimes there are complex facial trauma cases where it is very difficult, and the only way to restore the facial trauma is through the occlusion. So in this particular area, my humble request to your specialty and to your colleagues and your seniors would be to bridge this particular gap, because again, single anesthesia, We do not want to open this patient's mouth, which again creates problems for all of us. So your say, sir.
So, Assalamu alaikum. As you know, that we have been working in trauma center for last 5 years now as an orthopedic department, and there's so much influx of patients that are coming, and most of the time the problem is the prioritization of patients, whom we should do first, which patient can stay for a bit. So problem यहाँ पे आती है. दूसरी चीज़ जो है कि occlude कर दिया आपने अपना, then again we have to come. So इसमें थोड़ा सा issue जो है ना anesthesia department की तरफ से भी होता है, because they say, so why do we request or why do we wish you to reopen the mouth? So the problem is that when our residents go to the anesthesia department for getting the fitness for the patient, what they usually say that, okay, it will be a very difficult intubation, and probability, they don't prefer to do a nasal intubation, rather than they want the mouth to be open. So we have no issue, we just have to fix the bone. It's all about the anesthesia that they have to give. Issue ये होता है कि,
I understand, thank you. So that means कि आप दोनों की bridge मुझे करनी पड़ेगी. अच्छा, say something important I would to say. 1 second, sir, please. Maxillofacial surgical specialty is the only specialty perhaps which 90% of the work is nasal intubation, because we work inside and outside the mouth. And for us, the oral cavity is of prime importance. Professor Kashif, sir, tell us your experience at Jamshoro and Hyderabad, at your unit.
Sir, thank you very much. First of all, you have done a very tremendous job. Multidisciplinary approach, government sector में करना one of the difficult tasks. ER तक तो initial management सारी हो जाती है, but later on वही problem होता है कि sometime all limbs fractures होते हैं और patient is sent to maxillofacial department for surgery, या otherwise जो आपने अभी discuss किया कि after doing all work जब आर्थो वाले जाते हैं तो they used to ask के open mouth. उसका solution मैंने ऐसे निकाला था कि when we feel that orthopedic surgeon will go for second surgery या कोई और specialty, then I used to keep immobilization with arch bar and elastics. So elastics is very easy to remove, and especially initially I used to try to fix all facial fractures which are rigid fixation, but sometimes if it is a condyle fracture, which usually done under conservative treatment. So one of the best option is arch bar and elastics, and we can send a resident to ortho department. It is very easy to remove, and after their surgery we can easily replace it back.
Thank you, sir. Professor Imran, and yes, we are running short of time. Sir, आपकी इजाज़त, 2 minutes और. Mike? Neurosurgery head injury always takes precedence because the life is at stake. GCS बेहतर होगा तो patient, So, since we work also in a close collaboration with the neurosurgical department, your say, sir, because ये भी एक gap है कि आपका patient neurosurgically when the GCS improves, then the patient is rendered fit for surgery. And then at the same time, the problem which we face, malunion, non-union, and orbital issues and so many things which lead to cosmetic deformity. So it's a big challenge for all of us. Can we decrease this gap, sir?
एक छोटी सी बात बीच में बोलूं, GCS जो भी होगा हम एनेस्थीसिया देंगे.
Love you. Thank you.
Hello.
Sir.
Just concluding, remarks that always we get complaints from the maxillofacial side that why we are not on board, why we are not on board. This is the biggest issue from maxillofacial side. But the thing is that majority of times we get polytrauma patients who have got abdominal injuries, chest injuries, maxillofacial injuries, and as well as intracranial injury. So once you widen your canvas, for example, if you are doing any surgical intervention is an organized insult. So once the patient who has come to you with multiple injuries, and you have to prioritize, like Dr. Amir said. For example, if somebody has got a subdural hematoma, a young patient who has got GCS of 5, 6, and his prognosis We don't know what is going to be his outcome because we do not have any rehabilitation centers. Yes, we have got good surgical ICU, but it cannot supersede a good rehabilitation center. So operating upon those patients with acute subdural hematoma like GCS 5, 6, let me complete. All, like minor fractures, yes, we will not recommend. Yes, we can have you on board, but we have to have guidelines.
Sir, one
for
second.
that.
मैं आपकी इस चीज़ का वेट कर रहा था. If there is a subdural hematoma, which is a life-threatening emergency, has to be done immediately. Once you do that, if the same patient has facial trauma, can the second team be involved to do something which will prevent post-traumatic deformities and other associated issues?
For example,
that's a simple question. Can the maxillofacial team be involved?
Sorry?
Once you are trying to do the hematoma drainage, can the maxillofacial team be involved in the same procedure second?
I'm saying that we have to make guidelines. Sometimes we get extradural hematoma.
Okay, great.
For example, GCS with 10, having GCS 10, and we know that his outcome is going to be good. In that case, yes, we are happy to take you on board. We have to see our circumstances as well, our resources, our theatre's occupancy. We have to keep all these things into account. We just not have to decide that you have to put the plates on the face.
Agreed,
yes, if
sir.
there is any respiratory compromise, for example, because of facial fractures, in these patients, anyway, we have to do the tracheostomy. So their airway will be controlled.
Thank you,
so
sir.
You can go later on.
Thank you for your positive input, which means we need to sit down from the guidelines so that we can move forward. So last question to my ENT friend,
Guidelines.
Dr. Your role in terms, because tracheostomy is again very important, neurosurgery, maxillofacial and everyone, and also general surgery, because for long procedures and at the same time for different reasons we need tracheostomy. So your experience, sir?
My experience is that as per ATLS, it is that if...
Sir, 1 minute में देना आपने जवाब.
Yes, sir, I will take more time. First of all, if there is easily undertaken intubation by anesthetist, it should be done. And if you want like procedures in which later on the mouth will be closed and other things, then after the intubation, tracheostomy can be done early in first few hours of the trauma. And if, let's say, our anesthesia colleague is unable to pass the intubation, and then we should go for needle cricotherotomy for 30 minutes time, and in that time it is recommended that first you perform this surgical cricotherotomy, preferably who is skillful, any surgeon, even a statist and ENT specialist.
Sir, thank you
And
so much.
After the surgical cricotherotomy, I perform just after 10 minutes formal tracheostomy, because we cannot place the patient in surgical cricotherotomy because of cricoid ring. It may be subglottic stenosis. So we go for early tracheostomy. I usually perform after 10 minutes because we want.
Sir, I get your message. Thank you so much.
Sir.
For long procedures, tracheostomy is the safest and the best way
Safest.
to do that. Dr. Kashif, sir, plastic surgery. Your input regarding acute trauma, because being maxillofacial surgeons, we are trained in plastic surgery. We deal with the basics. My team is doing that. But in elective cases, we need your support for raising different flaps and your input, sir. Only 1 minute ताकि हमें इसको bind up कर दूँ.
Thank you so much, Dr. Shahjahan. It's very important. I think we all as a surgical colleague should know what are the things the plastic surgeons can do at the time of injury at the same procedure. The plastic surgeons in a complex facial traumas with soft tissue loss, with multiple bony fractures, the plastic surgeons, if he is called at the time of initial debridement, he can tell where to debride, what to debride, and what to save. Especially if I'm sorry to say, but if the maxillofacial surgeons want to repair any complex laceration or any laceration which has the soft tissue loss, they might do some cuts that might compromise our future flaps. So it's very important for us to be called on board, and then we can guide. Even if the wound condition is very good, we can do at the same time. Initially, we can cover with the local flap. that might be little difficult for our maxillofacial colleagues. So, and also in facial reconstruction, even a 1 millimeter step or a scar on the upper lip, white roll, that is very significant. So we are saving life, and also we want them to be aesthetically as good as possible. So this,
thank you, sir.
we will help this.
I will slightly disagree with you. We've been dealing with cervicofacial necrotizing fasciitis. Perhaps this is the largest center in Pakistan. I can proudly say that. We have unpublished data, and we have seen patients getting this particular complication because of mismanagement, because of not timely intervention. I will not go into the details. Yes, my team is very well equipped to deal with the basics of plastic surgery. Yes, wherever we feel, we will include you, sir. I will end this session with a big thanks to all of you for your contribution. This has been a wonderful crowd and a panel.
Let me, I'm sorry, Shahjahan, just give me one.
Talkie, ek minute. No, sir, I'm running short because I've been told. The take-home message or the summary is that yes, we need to form guidelines. Perhaps the most important people in this whole exercise is anesthesia and ER team. And we need to bridge these gaps because the primary objective of everyone is to save a life. Thank you so much for your time and attention. Thank you.
Thank you so much, everybody. We won't be giving out the shields since we're running short of time, and I'll make sure that all the shields to the panelists and the speakers and Dr. Mansoor, it reaches you. I'm so sorry we can't do the shield distribution ceremony since we're already short of time and the next session speakers are waiting. So thank you so much for being here. Thank you, so everybody. Thank you.
Assalamu alaikum, everyone. And we all know trauma starts with general surgery. And general surgery only is the speciality that takes on all trauma for everybody else. So let's start with abdominopelvic trauma here. And our session starts, the session would be chaired by Professor Nusrat Shah, Professor of Gynecology and Ops, ex-Pro Vice Chancellor of Dow University of Health Sciences. It's an honor, ma'am, to have you with us. Ma'am, udhar. Our co-chair is Professor Zubair, head of the Unit 2 at Dow University of Health Sciences. He is a renowned general surgeon as well as esteemed interest in medical education. And he is heading the Dow University of Health Sciences distant medical education department. We have as panelists Dr. Saeed Abdi. He is Associate Professor of Urology at Sindh Institute of Urology and Transplantation. We have okay. May I have your all attention, please? Please be seated. We are still, as we are running short of time, we will try to finish our commitment and our presentations on time as well. Let me also invite Brigadier Ehsan, who is joining us from CMH Rawalpindi. He is trained general surgeon and a vascular surgeon, has worked with NHS. Can we have Brigadier Ehsan? Oh, yeah. Thank you so much, sir, for being with us. Let's start our session.
So, first speaker for today, today's session is Professor Sheria Ghazanfar, who is the Chair of Surgery at DOHS with special interest in upper GI oncology and pancreatic surgery, an excellent robotic surgeon, and an avid researcher with over 30 publications to his record. Sir, please.
Bismillahirrahmanirrahim. Mr. Chairman, Co-Chairman, ladies and gentlemen, Assalamu alaikum. I'll be focusing my talk on the local perspective of abdominal trauma, what is the local data that is available. Also, I will also focus on the recent studies about abdominal trauma. Now, as we all know, that trauma is one of the leading cause of mortality in the world, puri dunya mein. And one of the most important cause of this trauma is road traffic accidents. Now, as the word, this trauma, it is not only limited to the victim who suffers this trauma. For example, if we talk about the road traffic accidents, it is the people who witness such traffic accidents. They are also traumatized. It is the healthcare professionals who deal with such patients who are traumatized. This is, depicted in this picture, in which they show a trauma patient and a chaos in the ER or the resuscitation room. This is, I think, an everyday happening in an ER of a busy government hospitals, or probably a big private hospital as well. And the ultimate goal or the intention of these healthcare professionals is to save the life of this patient. But if you look at this picture, it shows that the soul or the life of this patient has already left the body. But still the team is working, trying to save the life of this patient. Abdomen is a compartment that is not guarded as much as the thoracic cavity or the cranium, which protects the brain. When we talk about the abdominal trauma, we know as a fact that if a patient with a trauma presents in the ER, there are chances of less than 10% that this patient will sustain abdominal trauma. Let me put it another way. If you have a severely injured trauma patient in an ER, there are 1 in 3 chances that this patient will have abdominal injuries. So that means that in a severely injured patient, there are 30% chances of abdominal trauma. But if you look at the trauma as a whole, there are less than 10% chances of abdominal trauma. And when we talk about abdomen, we talk about injuries to the solid organs, to the hollow viscus, to the retroperitoneum, and to the diaphragm. And we usually don't take such injuries as isolated injuries. We take them as combination of 1 or 2, or maybe more than 2. This is one of the data from the trauma registry of Stavanger University Hospital in Norway. It's a 14 years data of trauma patients, and they had around 7,000 patients in which they found out that the abdominal trauma occurred in 6.2% of the patients, which is in line with the international literature that also suggests that the trauma is less than 10% in a trauma patient, abdominal trauma. We will have data if we put the data in the electronic system. If we do not put it, or if there is no way of putting the data in an electronic system, we will not have any information as we stand today. We do not have any information about the incidence, prevalence of any disease in this country. We do not have any data because simply we do not put in the data. Or if you try to introduce such systems, there is reluctance on the part of the healthcare professionals because they think that this will overburden them. And sometimes they are true, because they are not only putting the data electronically, but they are also putting the data manually, and that does stress them. So about the Trauma Center of Civil Hospital, Karachi, they introduced a trauma registry in November 2016, which was purchased from American system, and they had to pay annual fees for that. And they developed their own local software, and I think it had started working in 2022 early, and now they have the data, although I'm not sure what kind of a data is this, how complete is that data. What is the local data on abdominal trauma? We have done a Park Medinet search. We queried abdominal trauma, and we selected 28 articles in all from Pakistan. Most of the articles were published in the Pakistan Journal of Medical and Health Sciences. Only 3 journals were Medline indexed, and one study was published in those: JCPSP, JPMA, and Journal of Ayub Medical College, Ahmedabad. The distribution of these studies were, I think, in all the major cities of the country: 7 from Lahore, 6 from Karachi, 2 from Multan, 2 from Peshawar, and then Quetta and Rahim Yar Khan. And province-wise also, there was, most of the studies were from Punjab, and from Sindh, and then Balochistan and Khyber Pakhtunkhwa were equal. 13 of the studies only dealt with blunt abdominal injuries, while the penetrating injuries were dealt in 4 studies, while the mixed blunt and penetrating were 9. Most of the studies was prospective, which is a good thing. The minimum number of patients in the studies were 33, and the maximum was 667. And most of the patients were male, around 82%. And the duration of the studies ranged from 6 months to 5 years. And this is one of the important slides that tells you that most of the victims that presents of road traffic accidents or the trauma, their mean age is 31 years. Now, 31 years is the age where you are at the prime of life. Maybe you are supporting your family, your children, education, or maybe you are the sole earner of your family. So this is unfortunate that this is the age where most of the trauma victims present. This is also confirmed by the WHO, and which also says that 3 out of 4 road traffic deaths are among men. Again, the local studies tells you that 52% of the patients were from road traffic accidents and then fall. We as a nation, हम कहते हैं कि ये एक अफरा तफरी है, हमारी जो नेशन है ना, ये एक अफरा तफरी है, ये एक chaos है, और ये chaos ये रोड पे नज़र नहीं आता, ये हमारी public dealings में भी नज़र आता है. Everywhere, wherever we go, there is chaos. And this is the state of affairs. और इसी के साथ हम चलते हैं, हम सिर्फ अपनी देखते हैं, we do not care about the others. Again, blunt and penetrating injuries को देखें in the local studies. If you look at the blunt, which is in orange, the most of the blunt injuries were of spleen and then liver. Penetrating में intestine or mesentery ज़्यादा common थी. And it's not only single organ injury. Usually there are more than 1 organs that are involved. This may be 45% were more than 2 organs that were involved. The average length of stay of trauma patients was 7.47, less than 10 days. Lekin that does not mean that 10 days के बाद वो patients will resume their normal activities. No, sometimes the rehabilitation is long, months, years. Sometimes they're never back to their normal working. And then simply in blunt trauma, usually we have non-operative management as well. This may be around 50% are non-operative management. And the mortality was less than 10%. Let's look at some of the studies, recent studies about abdominal trauma. Artificial intelligence is something that we talk about every day. Sari conversations में आजकल artificial intelligence आता है. And I'm afraid for the radiologist कि probably radiologist के future बड़ा bleak नज़र आता है artificial intelligence को देख के. ये भी paper इसी month का है. It tells you about what is the accuracy of fast examination by artificial intelligence, and it's close to 94%. You do not need a radiologist. You do not have to wait for the radiologist. It is an instant reporting that is standardized. Again, is there any relationship of obesity and penetrating injuries to the abdomen or thoracic? इसमें इनका result ये था कि they classified these patients into obese, more than 30, and less than 30 BMI. इनका ये था कि there are no difference in when you compare the abdominal injuries in a normal, less than 30 BMI and more than 30 BMI. But in chest injuries, especially gunshot injuries, they sustain less injury, जो obese patient होते हैं. Intra-abdominal packing does not increase the infection risk. This is the conclusion of the study, and it does not mandate that you have to increase the duration of antibiotics. No, you do not need to. Is there any radiological or clinical indicators to tell you when to go for an operative intervention in patients, especially of blunt abdominal injury? Yes. And the factors that they have identified are active extravasation of contrast, pneumoperitoneum, hemoperitoneum, and mesenteric stranding and peritonitis. Temporary abdominal closure, vacuum closure is one of the common form, or just simple skin closure that is not recommended. What is the diagnostic accuracy of clinical examination? Clinical examination is dying. You cannot rely just on clinical examination because there is an uncertainty in that. Okay, lag raha hai ke kar lo, lag raha hai ke wait kar lo. No, you cannot do that. The uncertainty nahi honi chahiye. Do the radiological investigations and then decide. Abdominal compartment syndrome, more associated with vascular injuries, with pancreatic injuries, and the number of organs that are injured. Laparoscopy, जिससे सब डरते हैं trauma में, no, it is feasible. Do it. In a stable, hemodynamically stable trauma patients, do it. Blunt trauma में करें. Conclusion, in spite of limitations, lack of standardization, lack of data that is available, हमारे पास जो अभी pathway है वो यही है कि we should move forward. Positive approach के साथ we should move forward. अगर हम वो pathway लेते हैं जिसमें blame चलता है, जिसमें आप ये कहते हैं कि सिस्टम ही ख़राब है, कोई चीज़ें अवेलेबल नहीं हैं, तो हम काम नहीं कर सकते, then you will not be able to, demonstrate your skills. Positive approach के साथ करना चाहिए, and always blame yourself. जब भी कोई problem हो, blame yourself, ताकि आप अपने आप को ठीक करें. And when you do that, you improve. Thank you very much.
Thank you. Thank you so much. Thank you for an excellent time management, Dr. Shahryar. That was wonderful.
Thank you, Professor Shahryar, for a very informative meta-analysis. My next speaker is my teacher as well, Dr. Faisal Siddiqui, Associate Professor and Consultant General Surgeon at Liaquat National Hospital, with special interest in minimally invasive and trauma surgery. Sir, please.
Assalamu alaikum, everyone. First of all, I would like to thank the management here for inviting me here, and it's indeed a pleasure to be addressing such a nice gathering. So, I'm going to be talking about abdominal trauma and damage control surgery. Dr. Shahryar has set the stage for this talk with a very good data set that he had. And I'm telling you, we really, really lack that kind of data in our country, and we need that. So, I'm going to be talking about abdominal trauma and damage control surgery with an aspect of approach and evolution. I'm not going to be delving into all those high-class statistics or anything. We're just going to be very simple about it, and we are going to go through trauma as it evolved over the years, over the century, in fact. So, as rightly pointed out in the earlier presentation, one of the leading causes of death is trauma in the ages between 1 and 44, according to most of the studies. Hemorrhage being a major cause that leads to these mortalities, and the mortality rate is as high as 30 to 40%, and that's because of hemorrhage. And hemorrhage is the basic thing that actually sets in motion the whole cascade of physiological derangements that actually lead the patient down the downhill and leads them towards a bad outcome the worst being a mortality. So damage control surgery or damage control approach is a better word for it. Damage control approach is a staged approach, and a staged approach to a physiologically compromised patient who has come to the ER after severe trauma, and it has different phases like identifying a patient and then assessing the patient initially, resuscitation, surgery, and so we'll go on with it as we as we proceed with the presentation. So this figure of 10%, this is very important to understand. And as I was talking earlier to my colleague, that I am not here to advocate damage control surgery. I'm here to put into the mind of the residents and the postgraduates that damage control surgery is a tool, and it needs to be used judiciously, because if you don't use it judiciously, the patient can end up with a whole different set of complications which he did not have earlier, and he does not need to have. So moving forward, okay, we are going to use history to actually tell us how and when things changed and how it progressed over the last more than a century. So historically, we all know the name of Mr. Pringle. The James Hogarth Pringle, in 1908, he published a paper which talked about arrest of hepatic hemorrhage. Now, Mr. Pringle is someone who we owe a lot to. He is the one who did the first free venous graft. He is the one who started the hind quarter amputation. He is the one who devised the Pringle maneuver, and he is the one who was one of the first people to actually publish something on hepatic packing after hepatic trauma. So it all started, we can say, documented. It was documented first in 1908 with Mr. Pringle being one of the pioneers of this liver packing technique. So now we jump forward a lot of decades, and then we come to 1970s. In 1970s, it re-emerged. The concept of hepatic packing re-emerged. The damage control surgery is still not established at this point in time. So in 1970s, there was a lot of hepatic packing going on, and it was one of the recognized modalities in which the patient benefits from being packed if the hemorrhage is uncontrollable. So in 1970s, Lucas, Walt, and all these people, they published a lot of data about hepatic packing, and but still it was largely focused on hepatic trauma. So come 1979, यार वो टैप करना है, it is just that, not that, वापस जाइए, go back, वो क्लिक पे है, नहीं ये वाली क्लिक नहीं यार, वो माउस पैड पे क्लिक करो. Go back. इससे पहले वाली साइड है. On, I'm running out of time. माउस टैप कर दें. नहीं हो रहा वो, it's not working. अरे नहीं यार, चलो ठीक है, ठीक है, ठीक है. ये तो वीडियो नहीं है. It's just, you know, you tap it and the thing comes on the screen. आप इस पे सिर्फ टैप करते हैं. Tap anywhere. No. चलो ठीक है. उमर उस पे एनिमेशन ऑफ कर देगा कोशिश करके. Okay. All right. So no problem. We are just gonna. I'll just narrate it. Not a problem. So in late 1970s, what was realized was that apart from bleeding, patients were dying of coagulopathy, and you know, bleeding was leading to coagulopathy, and the major cause of death in this era was because of the coagulopathy and the acidosis that accompanied this severe hemorrhage. And so in 1979, the lethal triad of coagulopathy, acidosis, and hypothermia was actually introduced. So we have this acidosis, coagulopathy, hypothermia. We all know about it. We needn't go into much detail. One interesting thing that I found during my literature search was that interleukin-6 plays a very vital role in augmenting this lethal triad. And there was a study in which they assessed the levels of interleukin-6, and the patients who did not survive had much significantly higher levels of interleukin-6 in the blood. Okay. So, in 1981, then intra-abdominal packing and delayed removal of packs became much more established, and it was a more of a mode of treatment for more established mode of treatment for liver trauma. But still, it was just confined to liver trauma, and when the patient used to deteriorate intraoperatively, that was when it actually helped a lot. So in 1983, then Stone et al., they formally introduced the concept of stage laparotomy. They published their own paper upon it. And then in 1993 was the time when damage control surgery the term was actually coined. That was in 1993. And Rotondo and his team, they actually coined the term damage control surgery, taken from something from the Navy that was some procedure that they did. So historically, we have abbreviated the damage control surgery consisted of abbreviated laparotomy, resuscitation, and then definitive surgery. So this was the historic and the initial definition of damage control surgery. Patient comes to the ER, you take the patient for surgery, then you take them to the ICU, resuscitate, and then come back for definitive surgery. Now, in the same era, again, is it working? No? Okay, no problem. Now, around the same era, what happened was that those who are familiar with the ICUs and everything, they must be knowing the name of Shoemaker, who is one of the leading research persons in critical care. So what he published at that time was his study, which actually advocated supranormal resuscitation. Like, you know, the patient comes to you load the patient with fluids. Now, what started happening was that these patients were surviving initially. They made it through the initial part, but then when they came to the ICU, they did not make it through that because they had complications
please conclude your presentation. Your time is over. Please conclude your
Yes, please. So there were a lot of complications of DCS. I would have been happy to actually have that. So we are going to move on. As I said, damage control surgery is not for everyone. There has to be a proper selection, and as time is progressing, damage control resuscitation is becoming more and more important, and it is actually reducing the need for damage control surgery. Okay, so patient selection, I'm sorry I don't have time, so I would have liked to elaborate more. The damage control resuscitation indications being these couple of parameters that we have. Damage control surgery, these are the different things that we look for and then go for damage control surgery. In this case, again, way forward is not working. Okay, chalo. Oh, it is working. That's good. Okay, so the way forward, because randomized trials are not possible with damage control surgery, we need to have prospective cohort studies that address physiological derangements and injury characteristics. We need to take the benefit of improved resuscitation techniques, which is decreasing the chances that we have to do damage control surgery. And most of all, there has to be an awareness of the fact that damage control surgery should not be used across the board. It is dangerous. It can have long-term consequences. We need to train our people, and we need to have a teamwork, and everybody and every specialty needs to be on the same page if damage control surgery is to be practiced. It is not a one-man's game. Thank you.
Thank you, Dr. Faisal, for the insight on judicious use of damage control surgery. Next speaker is Dr. Zahid Raza, who is a consultant vascular surgeon at Health Point Hospital in Abu Dhabi, with clinical interest in vascular trauma, open aortic, and awake carotid surgeries. Sir.
Okay. Assalamu alaikum, everybody. It's an absolute pleasure being here. Thank you for the kind invitation. I'm going to really talk about improving the potential, the survival of the patient, rather than actually talking about managing vascular injuries, because that will be done throughout your training. So first of all, know the background to the trauma. If there's a road traffic accident and there's a death and the passenger has walked out, the chances are that they might decompensate, and so you need to keep a close eye on these patients. Then you need to examine the patient. This patient, he got stabbed by his wife because he said her breakfast wasn't very good. But when he was examined, he actually had 2 stab wounds around the back as well. So you're not actually looking at the isolated knife, you're looking at other aspects of the injury. I'm just going to talk very briefly about my credentials. I'm part of the trauma team in Edinburgh, and I'm also a convener of exams for the College of Surgeons of Edinburgh and member of council. And one of the best things I've done, I think, is to bring the MRCS to Pakistan, and I'm actually looking for potential examiners from south of Pakistan. So please give me a shout if you're available. So principles of vascular trauma. Don't think that you're the hero in this. It's your team that makes up the heroes. Keep things fairly simple and stick to your proficiency. This is not the time for you to try out a new procedure. You want to minimize the amount of time you're spending with the patient. Theatre is a very high-stress atmosphere. If you keep calm, your team will perform better. So always try and keep calm. And get help. Even if you're the most senior surgeon in your hospital, you will need help. And this is my colleagues in Edinburgh, all 7 of them. All 7 of them, over the years, I've asked for help. And the strange thing is that all of them were my registrars. So never be afraid to ask for help. And the patients, as previous speakers have mentioned, patients will die from bleeding. So this is what you need to do to arrest bleeding in order to initially improve their survival. This is a concept that we are now training surgeons about, situational awareness. Is to looking at the bigger picture and not just homing in on the surgery. Now, the anesthetic shuffle is not the anaesthetist trying out a new dance in the operating theatre. This is when you're operating and the drapes are moving everywhere, and you know there's something's wrong. It might be something like the pulse oximeter's come off, or it might be something that the ET tube's not put in correctly. So always ask the anaesthetist what's going on. Speak out loud and confirm what's been said and what's going to be done. Aware of your limitations, aware of your surroundings. There's loads of noise in theatre, but the only noise you should be hearing are the alarms. And also make sure that blood loss, you're aware of this situational awareness of blood loss. You can lose a litre of blood within a minute and not be aware of this. And the good scrub nurse is the one who's going to think ahead of the surgeon. Many times, if I've been doing a ruptured aneurysm, I'm down into the abdomen and I hold out my hand, and a really good scrub nurse is going to hand me the clamp and not going to hand me the suture or anything else. And then the sterile cockpit. In this situation, it's not a time to take selfies, go on your Facebook page. Everything needs to be totally silent unless it's absolutely necessary. And these skills we've learnt from pilots over the years. So types of trauma that might be arterial, venous, or combination of both. Blunt, penetrating, and more we're getting iatrogenic trauma. And don't always believe what the doctor has said. If they say, oh, I think I damaged the left iliac vein, and the number of times I've gone in and looked at the iliac vein, dissected it out, and it's actually something completely different. So go in with an open mind. You might need open, endovascular, or a combination of the two. And one of the speakers mentioned the hard and soft signs of bleeding. And decide on your incision. Are you going to use a transverse or a midline laparotomy incision? And the key thing here is get the patient off the table as soon as possible. The longer the surgery takes, the higher the patient's mortality. So before you start, this is what I do. I want to see that there is a vascular tray available. 3 things minimum that I need is the aortic clamp, Dardic clamp, and the Omnitract. The rest of the things will fall into place. You need to make sure blood's available and products, and if you've got the facilities of having ROTEM, that's ideal. Permissive hypotension has been mentioned, and this is what we want to do, is to keep the blood pressure low, but maintaining perfusion to the vital organs. And make sure you have 2 suctions with a cell saver. These are the different zones of the abdomen, and really the last one here, the perihepatic area, is a new concept. And this is really no man's land unless you happen to be a hepatobiliary or a liver surgeon. And what's the hemodynamic status of the patient? Either you need an immediate laparotomy, or you can wait and get some imaging done. And if you've got thrombosis of a significant vessel, again, you can buy some time. I'm not going to go into details of the different types of injuries, but the key thing here is that the IVC is the most commonly affected vessel in the abdomen, and over 50% of patients will actually die before they reach hospital. The zone 2 injuries, the key message here is if you've got a short ischemia time, then perhaps attempt revascularization, but otherwise just leave the kidney, unless if they've got bilateral renal damage or they've got a solitary kidney. And remember, the left renal vein is more forgiving than the right renal vein. And the retroperitoneum, again, this is probably the easiest area to deal with during vascular injury. And what are your priorities? Well, I've seen a lot of midline incisions, but my favorite incision is a transverse rooftop supraumbilical incision. And then get the anaesthetist to catch up. You don't want the anaesthetist catching up all the time. What you want to do is pack the abdomen, get the patient stable, and then start from ground zero. And if you're dealing with an artery, clamp the proximal and distal end. If there's venous bleeding, I mean, one of the most frightening things I come across is venous bleeding. Probably the second most frightening thing is an angry wife, but this is a small hole in the vein will cause a huge amount of hemorrhage. And if you're an extremist, then tie off the IVC or plicate it. And always revascularize the bowel and abdominal compartment syndrome, and remember second look laparotomies. And this is the access to the supraceliac aorta, going through the lesser sac, dividing the left crust of the diaphragm, and then clamping the aorta. And then you can do your medial visceral rotation and get a very good image of all the branches of the aorta coming at you, and you can actually repair them. If you're looking for the caval injury, then it's right medial visceral rotation, or if you want to access the aorta, then it's cauterization of the duodenum, and your key thing here is your left renal vein is the thing to remember not to damage. And again, venous bleeding, it's mainly pressure, and sometimes you have to transect an artery to get to the venous bleeding. Difficult situations when you've got a retrohepatic IVC bleed, the junction of the SMV portal vein and splenic vein, and I remember one case where I actually had to divide the neck of the pancreas to get to it, and you have to repair these, otherwise you'll get bowel ischemia. Bowel ischemia in terms of venous congestion. And the aorta, celiac axis, and the SMA, again, challenging, and the bifurcation of the IVC where it's hidden because of the artery overlying it. This was a trauma patient whom I saw, and afterwards I didn't examine the patient, and it was the student nurse who said to me, "Can you have a look at this foot?" So don't forget checking the peripheries. If you've ligated the IVC, then remember stockings. These are the complications that can occur, so remember you're not out of the woods until the patient is well past, it might be a few years down the line that they might get some of these complications. So in summary, it's a high-stakes surgery, but basic principles will be life-saving. Do the least to maintain life, organ and limb, keep calm in theatre, communicate with your team, and always ask for help. Thank you.
Thank you, Dr. Zahid, for the situational awareness and for reinforcing that principles should be applied even in the settings of trauma. So our next speaker is Professor Nighat Shah. Professor Nighat Shah is consultant obstetrician and gynecologist, currently heading Unit 9B of GPMC. And she has special interest in medical education. She is also the Director, Board of Governors of People's Primary Health Initiative, Sindh, and Director of Reproductive Health at JSMU. Ma'am, please.
Thank you very much. It's indeed an honor and privilege to be able to communicate with you. My topic is trauma in pregnancy, 2 lives at stake. Just check this, yeah. So I have no conflict of interest to declare, and this is the overview that I'll be talking about, slightly incidence, prevalence types, and I'd like to discuss few cases ताकि मैं ये देख सकूं कि audience सो नहीं गए हैं and they are with me, and then maternal resuscitation, maternal fetal workup, and the resuscitation, is it slightly different from the way we do it in a non-pregnant patient, and a little bit about minor trauma, and then summary. So Pakistan में हर साल around 6 to 7 million pregnancies होती हैं. So अगर हम इनका 1/3 लगाएं जो कि trauma patients present करते हैं, तो that's around 3.5 lakh patients हम trauma के pregnancy में देखते हैं. So the art and science are definitely lacking here, and there is a need to combine together with trauma people so that precious lives are saved, and here in this case there are 2 lives. So 9 out of 10 traumatic injuries are minor, but 60 to 70% fetal loss is in those minor cases as well. So as I keep saying, it's a unique challenge because otherwise, har cheez mein chahe cancer, you just heard excellent presentation on vascular abdominal surgeries. It's just one patient at stake. Here there are two patients at stake. The one hidden one is also a challenge. So knowledge of pregnancy-related anatomy and physiology are basic to be able to form teams to do worthwhile resuscitation. So a little bit about physiology. Pregnancy is high risk and low resistance states, and plasma volume increase up to 50%. Uska 1/3 uterus में जाता है. And in patients में बहुत capacity होती है masking की. So whenever you have signs and symptoms actually of hypotension or shock, that means the water is over the head already, because छोटा मोटा trauma पे बहुत masking होती है and it's difficult to recognize the cases. So when there is actual signs and symptoms, that means you are now on the border and have to act. So the effects pregnancy के जो होते हैं, amniotic fluid is a cushion. It protects the baby from a lot of trauma. Unfortunately, in third trimester, it decreases. The uterine wall also, though thick, but it decreases, the thickness decreases in the last trimester. And placental damage or placental shredding or placental abruption is also one of the leading cause of death, which is secondary to trauma, of course. So ये थोड़े causes हैं. 50% आप देखेंगे कि motor vehicles हैं. One of the first speakers spoke about the organized chaos we live in regarding जो road traffic accidents हैं हमारे. So वो हम देखते हैं. There are falls also, assaults, gunshot injuries, suicide. Intimate partner violence का जो data था वो usually Western world का था, but हमारे पास हम बहुत ज़्यादा cases देखते हैं. Mostly we shy away from social issues, so we don't discuss and we just treat the wounds and don't get into the deeper end, because then we don't know what to do about it. अगर वो कहती है कि मुझे domestic violence होता है, तो we don't have shelters available, we don't have that kind of social network. So बस हम सिर्फ पट्टी करके फिर भेज देते हैं कि go back to the vicious cycle, which is sad, of course. So again, to wake you up, this is a little case that, and this is a real case that you saw, that you may see in the clinic day on and day off. This is a young patient, 28 weeks pregnancy, walking with difficulty, having bruises in face, elbow, knee joints, fetal hearts are normal, probably due to intimate partner violence, car accident, motorcycle accident, brain injury. बता दो ना. क्या कॉमन है हमारे पास? सबसे ज़्यादा 80% हमारी इमरजेंसी में मोटरसाइकिल इंजरीज. वो अभी आएगा. तो 80% यही होते हैं, मोटरसाइकिल इंजरीज होते हैं. एंड इनमें आपको ऐसे मिलेगा कि इंजरीज the knees and elbows, और ऐसे पेशेंट्स अपने एब्डोमेन को बचाने की कोशिश करते हैं, चाहे वो फेस पे खा लें. फेस इज़ अ सेंसिटिव एरिया इन फीमेल्स, लेकिन वो वहाँ भी चोट खा लेंगी कि एब्डोमेन पे ना लगे और बेबी प्रोटेक्ट हो जाए. So motor vehicle collision में prevention is very important. हमारा मुल्क is very bad. We don't wear seat belts. ये seat belt जो pregnant औरत का होता है special होता है. This goes like this across the rib cage, across the chest, and also supports belly. So like this and then like this. So belly को भी support करे. अगर ये proper positioning है तो बहुत injuries इससे रुक सकती हैं. फिर अगर airbags वाली आपकी गाड़ी हो तो इसमें और बचत हो सकती है. So again, this is case number 2. This is Mr. and Mrs. Ali Dino, and in their 4th pregnancy at 34 weeks in emergency. And Mrs. Ali Dino says she has fallen from stairs, has black eye, redness, swelling in face and arms, abdomen, also has bruises. Mr. Ali Dino is a very caring husband. He's holding the hand and has tears in his eyes and is imploring you to look after his pregnant wife. The doctor in ER remarks that Mrs. Ali Dino is extremely careless, as this is the 4th time she has fallen in this current pregnancy. Most probably this is... Sir, sorry? नहीं. SARS is absent on the scene. This is intimate partner violence. And again, as I said, we move in circles here. Patient को तो हम थोड़ा बहुत ठीक कर देते हैं. But there is lot more to be done. अगर shelters हों, अगर proper counseling हो, social services हों, वो network missing है. So intimate partner violence, pregnant औरतें weak and fragile होती हैं. जो जितना fragile होता है वहाँ ज़्यादा होने के chances होते हैं. And this increases in pregnancy because pregnancy is a fragile state, and there is now a lot of documentation and evidence in it. RCOG के हर एग्जाम में एक स्टेशन डोमेस्टिक वायलेंस का होता है, वहाँ वो पेशेंट ब्रूज होती है और बैठ के रोती रहती है, और अगर कैंडिडेट वहाँ ये कह के उठ जाए कि ये थ्रोम्बोसाइटोपिनिया है, द कैंडिडेट डज नॉट पास. You at least have to recognize that patient is consistently crying, so there's more to it, and it's not thrombocytopenia. जो कि हमें medical issues डालने का शौक होता है हर चीज़ में. We recognize them, we do not recognize the social ills. So injuries are inconsistent with stated history, diminished self-respect, esteem, depression, ये सब कुछ common होता है. अब universal screening है depression की. In every OPD, there should be the 4 questions which are there in your file that you ask to screen for anxiety and depression, which is a very good step, I think. So self-blame hota hai, and बार-बार वो यही कहती हैं कि मैं गिर जाती हूँ, whatever. So we come to a third case. Now you are covering for your colleague, and she is on summer break, so you don't know the full history of this patient. This is Mrs. Aman. She is 30-year-old female with 37 weeks, that is term pregnancy. This patient had history of multiple stab wounds in her last pregnancy, due to which the previous baby did not survive, and mother herself went through extensive laparotomies. The patient is now very anxious about baby. अब आपका पास 37 weeks पे pains के साथ आई है. I know very few of you are OBGYN here, but this is simple logic. It's not rocket science. आप cesarean करेंगे या normal delivery करेंगे? सिजेरियन करेंगे तो आपको बुलाना पड़ेगा. अंदर इतने मसले होंगे कि पूरा दिन निकल नहीं सकते. We'll try for normal. There's no obstetrical cause here. अगर uterus last time बहुत ज़्यादा rupture हुआ था या कुछ, तो then we may think, but I would try for normal, and I did, and I delivered her. So this is Mrs. Bashira. She's known case of severe hypertension, cardiac disease. In her 7th pregnancy, she comes with a history of assault, which is also very common, and shock. She has shortness of breath. Her respiratory rate is 35. Oxygen saturation is 80. Fetal hearts are feeble. Maternal pulse becomes unrecordable in next few minutes. What are the main difference in resuscitation of this patient as compared to non-pregnant women? So resuscitation should be in supine or left lateral. कैसे रिसर्च करेंगे इसको, क्योंकि यूट्रस का प्रेशर है ना. पहले तो लेफ्ट लेटरल होता था कि लेफ्ट लेटरल में करेंगे, अब वो चेंज हो गया है. यू जस्ट हैव टू टिल्ट द प्रेग्नेंट बेली टुवर्ड्स वन साइड, क्योंकि आपको जो प्रेशर देना होता है हार्ट को वो प्रॉपर दें ताकि रिकॉइल हो और ब्लड फ्लो आपके कैरोटिड्स पे जाए और आपके एसेंशियल ऑर्गन्स की परफ्यूजन नहीं डिस्टर्ब हो. इसलिए लेफ्ट लेटरल टिल्ट का अब ख़त्म हो गया है. बाकी रिससिटेशन उसी तरह की है जो आप इन्वेस्टिगेट. इन औरतों में हम इन्वेस्टिगेशंस में हेजिटेंट होते हैं अगर ट्रॉमा के साथ आएँ, तो वी थिंक कि बाय डूइंग एक्सरेज वी आर putting the baby at risk of radiation. That's not true. Maternal life is important. जो पुरानी फिल्मों में देखते थे कि मोहम्मद अली आ रहा है, कह रहा है या माँ बचेगी या बच्चा बचेगा, ऐसा नहीं है. माँ बचेगी तो बच्चा बचेगा. The narrative has to change. If the mother lives, then only the baby survives. So ये ABC आप सब लोगों को पता है. मैं इतने पढ़े पढ़ाऊँ को क्या पढ़ाऊँ, आगे नहीं पढ़ाऊँगी. So maternal cardiac arrest में the important thing to understand is if in 4 minutes your resuscitation doesn't work, then do emergency hysterectomy to save the life of fetus. अभी 2 दिन पहले हमारे पास emergency से dead on arrival patient refer की उन्होंने कि आप baby निकाल दें, लेकिन it was more than 20 minutes since she had died, so we couldn't save the baby. It's just precious 4 minutes you have to deliver the baby and give it to Dr. Nasir Saidal sitting here. So maternal complications after resuscitation ये सब हो सकता है. अगर आपने माँ को बचा लिया तो फिर rib fractures हैं और फिर आप लोगों की पूरी टीम है जो ये सब कुछ कर सकती है हमारे साथ. माइनर ट्रॉमा के ज़्यादा केसेस होते हैं, बट इनमें fetal loss ज़्यादा होता है. Won't go in those details. And in summary, I would just like to say कि consider the physiology in mother and then accordingly resuscitate. Thank you very much.
Thank you, Professor Nigat, for a very informative talk on trauma and pregnancy. Moving on to the next speaker, Dr. Syed Rabiullah, who is Assistant Professor at SIUT-Karachi, a dedicated urologist with a strong track record of success in treating advanced urological conditions. Please.
Thank you for inviting me. Today I am presenting the topic of blunt renal trauma. Already we have discussed about the abdominal trauma. So kidneys lie in the retroperitoneum, as we all know, and we more focus on the blunt. First, we discuss the epidemiology. The genital injuries account for about 10% of all the abdominal trauma. And out of genitourinary, renal trauma is most common, and it accounts for 5% of all trauma cases, which of 80% are more than blunt trauma, and rest are the penetrating trauma. Children are more associated with renal trauma as compared to adults because they have less tissue and less cushion effect due to, and their rib cage is also softer as compared to adults. As we already discussed the classification, we have blunt renal trauma and penetrating. Blunt renal trauma is more common. It's occurred due to the direct blow to the injury, or it can occur due to the rapid acceleration or deceleration injury, secondary to RT, or there can be a combination of the both. And penetrating normally occur due to the gunshot injuries and stab injuries. We all know about the American Association of Surgery, the trauma classification. This scoring system basically help to predict the outcome of the patients. We have basically 5 grades. Grade 1 to 3 are the low grade injuries, and grade 4 and 5 are the high grade injuries. This also helps in the clinical significance and management of the patient. And it also predicts the morbidity and mortality in the patients. So we all know about the grade 1, there's a normal contusion and hematoma, non-expanding. And grade 2, there is less than 1 centimeter involving the perinephric region. And there is a cortical laceration that's less than 1 centimeter. Grade 3, there is more than 1 centimeter laceration without involvement of the renal collecting system. And grade 4, there is involvement of the collecting system along the laceration. And there can be a vascular injury involving the renal artery or main renal vein. Grade 5 is the shattered kidney or the uretropelvic junction avulsion, or there is complete laceration or the thrombosis of the main renal vessels. This is the pictorial image of showing the classification of the different grades. So how the patient present to us? Normally the patient present with, doesn't normally present with significant isolated injury. They are normally associated injuries in more than 70% of the cases. Patient can have gross hematuria, microscopic. There is a tenderness or ecchymosis over the flanks. Patient can present with acute abdomen if there is more likely the associated gut injuries. Patient can have distended abdomen with absent bowel sounds, and patient can even present with large peritoneal retroperitoneal hematoma, which is known as Gray Turner signs. We can see the flanks. There is a bilateral bruising of the bilateral flanks. This is the Gray Turner signs. Normally we go for the imaging in every trauma patients, but there are some indication for the renal trauma. If there is visible hematuria or there is a non-visible hematuria, which is microscopic hematuria with hypotension. There is a history of rapid deceleration injury associated with significant associated injuries, or there is a penetrating trauma. There is a clinical signs suggesting the renal trauma like flank pain, abrasions, fractured ribs, abdominal distension, mass or tenderness. And in pediatric population, patients with RBCs more than 5 per high power field. Then there is a multi-phase CT scan, which involves the arterial phase, nephrogenic phase, and there is a delayed phase. Delayed phase helps to identify the injuries of the renal collecting system and the ureters. This CT scan is the modality of the choice in renal trauma. The findings of medial hematoma, medial urinary extravasation, which signifies the pelvic junction injury. And there is a lack of contrast enhancement of the parenchyma, An active intravascular contrast extravasation signifies the renal vascular injuries. Ultrasound can be done. We all know the fast scan is done to see the collection in the different compartments of the abdomen, but this is inferior to the CT scan. IVP is basically the past. It's not normally done routinely. There's a role of one-shot IVP, which is normally done on table when we are called for the exploration of the retroperitoneal hematoma. In case we need nephrectomy of the ipsilateral side, so we have to see the contralateral side, and we are not sure about the history or radiological findings, so there is a role of one-shot IVP. Evaluation. After primary and secondary survey, we have already discussed. Normally as a urologist, we are called after the basic management of the patients. So we have to see the hemodynamic stability before exploring any retroperitoneal hematoma. Record the past renal surgery and known pre-existing renal abnormalities like POJO, stone disease, and whether it's a solitary kidney. Test for hematuria in a patient with suspected renal injury. One thing is important regarding hematuria, that the degree of hematuria is not the direct relation with the grade of the injury. You can have no hematuria in grade 5 injury, and you can get a massive hematuria in grade 2 or grade 3 renal injury. Most of the patients with blunt renal abdominal trauma are managed non-operatively, more than 90%, with close monitoring and re-imaging after 72 to 48 hours if required. There is an option of selective angioembolization for active renal bleeding, and if there is no other indication, for the immediate surgical exploration. Only exploration if required. There is the persistent hemodynamic instability after aggressive resuscitation. Grade 5 vascular or penetrating injury, even the grade 5 blunt injuries can be managed non-operatively. Expanding or pulsatile renal hematoma have to be explored of zone 2 as discussed previously. So the overall exploration rate for blunt trauma is low. The goals of exploration should be the control of the hemorrhage and renal salvage. Most series recommend the transperitoneal approach for the surgery. But as a urologist, I must say that we prefer the flank approach, as we are more comfortable with the anatomy and in case of isolated renal injuries, and the other injuries are ruled out. The overall rate of patients who undergo nephrectomy during exploration is around 30%. And other intra-abdominal injuries also increase the likelihood of nephrectomy. Repeat imaging is in high grade and penetrating injuries in case of fever, worsening flank pain, and falling hematocrit. Measure blood pressure annually in case you have managed the patient non-operatively to diagnose renovascular hypertension. There is a phenomena called gold blood hypertension, where there is renovascular thrombosis, which leads to the activation of the renin angiotensin vascular hypertension. And there is a page kidney where there is a compression of the renal parenchyma after there is a large perinephric hematoma. So you have to monitor the blood pressure annually to see these phenomena. Once the patient is explored and there is patient is on table, there is a rhinorrhaphy is the most common reconstructive technique. We can do the partial nephrectomy when there is a dead tissue or non-viable tissue. Watertight closure of the collecting system is desirable. So we have to place the internal or the external drainage to avoid the urinary leakage, so there is a proper healing. Close the parenchyma over the injured collecting system is acceptable. We can use the hemostatic agents like Surgicells and other sealants, which can help in the drainage of the ipsilateral retroperitoneum. The repair of the vascular injuries are rarely effective. So, and repair should be attempted in patients with a solitary kidney or bilateral renal injuries. Nephrectomy for main artery injury has outcomes similar to those of the vascular repair and does not worsen the post-treatment renal function in the short term. Bleeding or dissection of the main renal artery may also be managed with a endostent. This is the algorithm. We have already discussed all the things. So in the end, I would like to present the case which we dealt recently.
Please conclude your session.
There is a 14-year-old boy with a history of RTA presented with the RTA has distended abdomen and tender with hematuria and vomiting. Ultrasound shows the subcapsular hematoma with 200 ml collection. CT scan shows, we have done the CT scan, we can see the images. Kidney is shattered with the upper and the lower poles completely disassociated from each other. And the left kidney was slightly smaller, and so we suspected this is a solitary kidney. So we went for the exploration, and the renal-refi was done with placement of the internal stent. Now the patient's wound has healed, and there's initially the leakage, so we changed the stent. Now the patient is on internal drainage and he is dry.
Dr. Bueller, please conclude.
Thank you.
Thank you.
References. Thank you for that. Thank you.
Thank you, Dr. Abdullah. Our next speaker is Dr. Muhammad Arslan, who is a liver transplant and hepatopancreatobiliary surgeon at DUHS, and currently working as assistant professor with special interest in living donor liver transplant, cholangiocarcinomas, and complex hepatobiliary surgeries.
Assalamu alaikum. Esteemed faculty, dear colleagues, a very good afternoon. So I will be talking on the SVP trauma. As you all know, abdominal trauma associated with hepatobiliary injuries has a very morbid event associated with very much complications. So I will try to be a more practical. बहुत ज़्यादा गाइडलाइन से बात नहीं करेंगे क्योंकि HB field is still developing in the country. We have a very few number of HB liver transplant surgeons, so we will talk accordingly. This is a aphorism I saw in a book, very interesting. Trauma surgery is a contact sport. The badly injured liver is a ninja master, a very cunning, vicious, and lethal adversary. It doesn't give you time to react. It doesn't give you time to save the patient. So liver trauma in liver is a very commonly affected solid organ, and complex liver injuries are associated with a very high rate of mortality. And otherwise, patients with minor injuries can be managed non-operatively. So currently, non-operative management is the standard of care with advanced endovascular and multidisciplinary approaches. So if the patient is stable, despite any grade of injury, go for the non-operative management. If the patient is not stable, then you have to go for the operative management. And the management of liver trauma should include trauma surgeons, HPB surgeons for every case of complex injury, that including operative or non-operative management. So this is the classification that you will be reading from ages. Very difficult, but not very practical. I will give you a simpler one that. So grade 1, nothing should be done, manage non-operatively. Grade 2, something should be done. Explore, do local hemostasis with simple procedures. Grade 3, too much should not be done. Simply pack the patient, come out. Do the damage control resuscitation and save the patient. Then grade 4 injuries, only God can do something. You can do heroic measures, but does not depend if the patient can be saved or not. So even today, the complex liver injuries, complex pancreaticodular injuries, they create a sense of fear in the surgical staff because of the lack of an experience in dealing with these injuries. So basically, to fear is the fear of unknown. So damage control surgery of liver injury, abbreviated laparotomy, all the principles of damage control surgery to be followed, effective packing, liberal use of Pringle maneuver, selected ligation of the vessels, routine use of angiography, and then early ICU transfer for damage control resuscitation. Non-operative management should have a particular well-developed team and monitoring all around the clock with ICU physicians, trauma surgeons, HPB surgeons, availability of blood products. These things they need to be available for the whole of 24 hours for non-operative management. So this is a grade 4 injury. You can see the arterial blemishes and not very much extravasation of fluid in the penile cavity. This was managed conservatively. Patient was admitted, monitored in the ICU, then shifted to the endovascular unit for angioembolization, and patient was managed non-operative. Later, he needed a hepatectomy to control the bile leak. So, in which patient you cannot do the non-operative management are very high velocity injuries that can damage the hollow viscus or that are associated with the head and cervical injuries. So you cannot monitor the GCs of the patient. You cannot monitor if it is due to shock or the brain injuries. So better to go for the operative management. So irrespective how complex the injury is, if the patient is deteriorating, go for the operative management. Involve the HPB surgeon, involve the vascular surgeon, involve the endovascular people, and go for the operative management. Otherwise, you are going to lose the patient anyway. So operative management of the liver injury. This is the method that are usually followed to control the hepatic bleeding. Hemostats, hepatic sutures, electrocautery, perihepatic packing, Pringle maneuver, selective vascular ligation, balloon tamponade, and finally hepatic vascular isolation. So laparotomy, do the systemic 4-quadrant packing, remove the packs. If the bleeding has stopped, do nothing more. Just come out and shift the patient to ICU. Okay? If there is simple bleeding, then control with the local methods. Do direct compression, use cautery, argon beam coagulation, use sutures, and perform or do the packing with hemostats. Just simply stop the bleeding, do nothing more. These are the pictures showing use of suture material. When there is a complex laceration or complex injury that is bleeding and cannot be controlled with simple methods, then you can go for bimanual compression. Do the Pringle. After doing Pringle, if you can see that bleeding is stopped, then it basically was due to the pedicle injury. And if it is not stopped, then it was due to the hepatic venous injury or the retrohepatic vena cava injury. So that differentiates between the source of bleeding as well. After Pringle, you can do the hepatic packing. So this is the pictures demonstrating the Pringle maneuver. You can do tamponade balloons for the deep laceration through and through injuries of the liver, or you can do hepatotomy with direct surgical control of the biliary particles. So hepatotomy in a coagulopathic patient is easier said than done. Usually it bleeds a lot. This is the picture showing the tamponade effect of a balloon. Finger fracture method for hepatotomy, and this is with Pringle maneuver. Now you have got a hepatic venous injury or the retrohepatic IVC injury. If you have the facility of Ribovac, go for that. If not, then you have to go for the hepatic vascular isolation after mobilization of the liver. So if you are experienced enough, you have a cover of HCP surgeon, then go for mobilization of the liver. Or otherwise, if you do not know the anatomy, you cannot mobilize the liver, you cannot control the IVC, don't be a hero. Don't mobilize the liver. Just that then compartment with the tamponade and pack the patient, shift to ICU, do the resuscitation, and then plan another surgery with proper resources. This is the picture showing mobilization of liver. So for hepatic vascularization, that is usually done for retrohepatic IVC injuries. The commonest use Haney maneuver, that is you do the Pringle maneuver, you clamp the suprahepatic IVC and you clamp the infrahepatic IVC, then you try to repair the injury in the IVC. Some novel technique, atriocaval shunting is being done. But when the scenario is this, you have to do these techniques, the patient is already in coagulopathy, has bled a lot. So difficult to save the patient with these techniques as well, with a mortality of around 60%. So this is a technique being shown, Pringle maneuver and supra-infrahepatic IVC control. So Hepatic resection should be planned later. Don't go for hepatic resection in the first surgery. Patient's already coagulopathic, it will bleed a lot, it will go into the lethal triad and will not be good outcome. So we are short of time as well. For portal triad trauma, try to save and try to fix the artery and vein. If not possible, try to ligate the artery and repair the portal vein. If you cannot, patient is coagulopathic, just go for the shunt, resuscitate the patient and plan the definitive repair later. For biliary duct trauma, just do an extra hepatic biliary drainage. Complications can be, for pancreatic injury, there is a simple thing to manage the pancreatic injuries. If there is a ductal injury, then decide if you are going to resect the pancreas or you are going to for anastomosis. If not, just debride the tissue, control the hemostasis and come out. This is a picture showing transition of pancreas. For grade 5 injuries, including the head of duodenum and pancreas, you can plan for Whipple procedure, that is emergency Whipple, but it has got a very high mortality. So do in stages. First, in first surgery, do the hemostasis, debride the tissue, and then in second surgery, do all the reconstruction that is needed. So for the isolated duodenal repair, simply repair the duodenum, devitalized tissue should be removed. Repair can be done primarily with a duodenogenostomy, or you can protect the repair with C-tube technique and pyloric extrusion as well. So finally, I will go through a case that was faced in a trauma center just to let you know what we are doing. There's a 38-year-old gentleman presented to the trauma center on 21st of April. I was called around midnight that the surgery team has explored the patient, affected, and the bleeding is not stopping. So as he was hemodynamic stable, he was shifted to OR beforehand. So I've written aphorism below as well. No battle plan survives the first 5 minutes of contact with the enemy. They had planned, they will operate, they will pack the liver, and bleeding will stop. So when I arrived at the findings that there were a lot of around 2 liter blood in the peritoneal cavity. Pringle was done and selective ligation of the damaged pedicle of the segment was done, but there was still bleeding, so I had suspicion the patient was bleeding from the retrohepatic IVC or hepatic veins. So I mobilized the right liver, and there was a right hepatic vein was found avulsed that was suture ligated. So patient was shifted to ICU, CT scan could not be done, patient was re-explored, packs were removed. See, so after pack removal, when the patient was stable, we got a CT scan and it showed complete dissection of the anterior and posterior pedicles of the liver. So right lobe necrosis were eminent and patient was going into liver failure, and the future liver remnant was just this left lobe. So the plan was to let the patient be. In this way, control the bile leak with the drainage percutaneous region, and then plan the definitive surgery later. Give time to liver to regenerate. So fortunately, this patient had a variant anatomy and a separate supply of the segment 6 of liver, separate from portal pedicle and separate inferior hepatic vein, as you can see in this picture. So this was contributing to the future liver remnant as well, though the patient did not went to liver failure. So this was diagrammatic representation.
Please conclude.
Madam, conclude. Was right hepatic vein and damaged pedicles of the segment 7 and 8. So a patient developed biliopleural fistula and definitive surgery was planned. In definitive surgery, we had 3 options: either go for right hepatectomy, go for bisegmentectomy, and go for the ALPS procedure, a stage hepatectomy with portal vein ligation. So operated the patient, found this necrotic segment 8 and 7. Resection was done, that is bisegmentectomy. This is the final result. Patient was recovered well, smooth, and is about to be discharged from the department. So concluding, I will be telling you people that we are a team of 6 transplant surgeons performing complex surgeries, covering emergencies in the whole Karachi as well. So you are free to ask us, consult us, or refer any patient to us for these management. Thank you.
Thank you so much, Arsalan. Before we move on to our paper presentation, I think we would like to have question and answer session first. And any questions from the panelists for all the talks we had? Dr. Nusrat.
I think because we are already running very late and because of shortage of time, if there are 1 or 2 burning questions, they may be allowed, but otherwise we will conclude. Thank you. Just the concluding remarks from all the chairs, and then we'll conclude. If there is any young residents who want to ask any burning question, only that is allowed.
Assalamu alaikum. My name is Dr. Zia. I am a vascular surgeon. I listened to a very wonderful and very informative talk. One of the questions from Dr. Zaid is that where did he place the riboya? And one from the hepatic surgeon is that for retrohepatic injuries, IVC injuries, what is the role of the riboa V? Yeah. That was great talk. I am just wondering where you place the endovascular methods of treating vascular injury. Yeah, riboya. Yeah, so when you are going to in the thoracic aorta. And from the hepatic surgeon, I had a talk with him. Is there any evidence of using the venous riboya for the retrohepatic injuries, IVC?
Sir, there is evidence of doing a ribovac in the patient with injury of the retrohepatic IVC and the hepatic venous injury. That gives you time to save the patient and then proceed for the repair of the IVC after mobilization or the hepatic veins.
Thank you.
Before we conclude the session, I just have one question. As our two major speakers were Dr. Shahryar and Dr. Faisal Siddiqui talked about the abdominal trauma and the concept of damage control surgery, I would like Dr. Zubair to comment something on it, because as surgeons, it's at times very difficult to know when to stop ourselves from doing more. We just happen to do more and we just try to save the patient, but we should know as surgeons where not to do.
Right. So those of you who were present in the previous session, there was a question asked by Dr. Shahjahan that how long the anesthesia can be continued. And when we are dealing trauma, damage control resuscitation and damage control surgery is something now which needs to be kept in mind. So the reconstructions need to be delayed, otherwise we are going to have a well-constructed dead body. It's difficult to decide, as the first thing that I would like to say is that we should apologize to the speakers that the allotted time was 15 minutes and we asked them to finish it off in 10 minutes. So that was some sort of unjust decision, but because of time constraints we had to do it. And probably your question would have been answered by Faisal, but it was not. So it's important that we review our own decisions. Now, damage control, when you start with performing damage control surgery, it has happened that you start overdoing it. And there are people who think that probably there are a lot of patients who do not need damage control, but they were submitted to damage control and we had to face problems. So it's a tricky decision, and definitely you need to apply damage control depending on your own circumstances, the ICU backup we have and the support system that we have. As in trauma settings in our part, probably a lot of patients who can be dealt conservatively, we try to operate them. And the reason being the availability of ORs at odd hours if required. So all these decisions need to be contextual, and the best way that we could come to a definitive decision is probably auditing our own practices and having a look at the outcome in our own practices and setups.
Thank you so much, Dr. Zubair. We are still in our session. Dr. Nusrat had to go somewhere, so we will be continuing with the free papers now. Dr. Waqas, pediatric surgery, would present his free paper on pediatric trauma.
Thank you very much, Imrana, for letting me go a little bit early because I have an important meeting. But I would just like to say a few words for Trauma Center. First of all, congratulations to the whole team of Trauma Center, including Dr. Sabir and including the everybody who has participated in organizing this unique conference, because I think this is the first trauma conference of the whole of Sindh province. I've never seen any trauma conference before. And it's a great educational activity for all the young trauma surgeons who have to be trained, and the critical care emergency specialists that we need. And I just want to say that this trauma center, Shaheed Mohtarma Benazir Bhutto Trauma Center, has come of age now, and it has given birth to a baby trauma center, which is in Larkana. And since I'm working as a Vice Chancellor in Shaheed Mohtarma Benazir Bhutto Medical University, Larkana, so I would like to request similar educational activities and support of this trauma, because this trauma center is going to monitor and supervise the working and the whole activity of that trauma center. The whole team of civil hospital will also be requested to get involved, please, because we have SIUT also in Larkana, but we have no vascular surgeons, we have no plastic surgeons. A lot of specialists are missing over there. So because this trauma center is going to look after our baby trauma center, so a lot of support is required from all of you, and to develop that trauma center in the upper part of Sindh, that is getting patients from Balochistan also, and from southern Punjab also, and a great number of patients who are suffering and they have to be referred to Karachi. That need will be countered by this trauma center. So thank you very much for having me as a chair, and this was really a great session by all these wonderful speakers. They have done their job in an excellent way. Thank you.
Thank you so much, Dr. Nusrat, for giving us an honor to be presiding this session. Let's start with the free paper presentation.
Bismillahirrahmanirrahim. Assalamu alaikum. My name is Sayyid Waqas Ali. I am Senior Registrar at Department of Pediatric Surgery, Dow University of Health Sciences, Civil Hospital, Karachi. Today I am going to present our experience of managing high-grade pediatric liver injuries with multidisciplinary approach. As you all are aware that the pediatric injury has become a significant global health problem, and over 2,000 children die every day because of road traffic accidents, in which in the abdomen the liver is the most frequently involved organ. Fortunately, 80% of these blunt liver injuries are low grade and they are managed non-operatively, as Dr. Arsalan has also highlighted. But the high grade injuries, they pose significant challenge to management, both for the emergency physician and pediatric surgeons. In these cases, 2/3 of the patients need operative approach to control the hemorrhage. But more recently, we are seeing that there has been a shift towards the non-operative approach in dealing with high-grade liver injuries in the pediatric patients. And this is happening with the advancement of interventional radiology and minimal access surgery. We are sharing our experience of managing high-grade pediatric liver injuries in Shaheed Mohtarma Benazir Bhutto Trauma Center, Karachi. This is a retrospective review from March 2019 to 2021, and out of 17 patients presenting with blunt liver injury in this period, 4 qualified for the criteria of grade 4 and above blunt liver injury. None of these patients received any pre-hospital care, and at the trauma bay, all patients were approached by ATLS. Further evaluation was done with FAST and CT scan, and liver injury was classified according to AST grading. So this is the AST grading, and we will be focusing on the grade 4 and 5 liver injuries. Coming to the results, the case number 1 is a 6-year-old boy who had a run-over injury by a light pickup truck. He presented with grade 2 circulatory shock, and abdomen revealed extensive abrasion over right hypochondrium with marked tenderness. Aggressive resuscitation according to ATLS was initiated, and then after stabilization, a CT scan of the abdomen was done, which is showing extensive damage to the right lobe of the liver involving segments 7 and 8, with the laceration going towards the anterior part, virtually splitting the liver into 2 halves. Similarly, in this coronal view, in a posterior view, you can see involvement of left lobe as well, and damage to the segments 2 and 3. This patient was subsequently admitted to the PEDS ICU, where he remained stable without any need of further transfusions, And over the next 6 to 7 days, he started tolerating oral diet and his LFT showed significant improvement. On day 7, he passed a large melanotic stool and his hemoglobin and LFTs got deranged and he was resuscitated with IV fluids and blood products. He became stable after that and there was no further bleed. So we thought it was the end of it, and then he was observed for another 4 days and then was discharged in a stable condition on day 10. He was followed in OPD on day 21 where his baseline labs, LFTs and ultrasound were done which were normal. On same evening he presented in ER with a large episode of hematemesis and melena. Hemoglobin dropped and serum bilirubin was raised to 46. He was deeply jaundiced. Following aggressive resuscitation, a CT abdomen was obtained. Here you can see that there is extravasation of contrast into the pseudoaneurysm, and in the angiography image, the mushroom shape leaking of the contrast in the vicinity of right hepatic artery is noticed. Angioembolization was done with 2 coils to control the flow to aneurysm, and it was controlled. And following that, his melena and jaundice were resolved, and he was discharged after a week in a stable condition. On day 19 of this procedure, he bled again and had a large melanotic stool with sudden drop in hemoglobin. CT angiogram was performed again, which showed recurrence of aneurysm with extravasation. A repeat angioembolization was done with deployment of a 3rd coil. He became stable again, but only for 3 days when he had a rebleed. This time, again after resuscitation, an emergency laparotomy was performed and right hepatic artery was ligated. Concomitant cholecystectomy was also needed to be done since gallbladder was inflamed and full of clots. Subsequent recovery was uneventful and he was discharged 10 days later. He was doing fine in his last follow-up, which was 6 months back. Case 2 is an 8-year-old boy with history of run-over injury by a phonic art. He presented with severe abdominal pain and grade 3 shock. Abdomen was grossly distended with bruising over chest and right upper quadrant. Following aggressive resuscitation, CT scan was done, which shows extensive parenchymal injury to right lobe of the liver in segments 7 and 8. And again, in this coronal view, a large hemoperitoneum is noticed. And in this sagittal view, we can see that there is extensive damage to the segment 6 and 7. This patient was also given trial of non-operative management and he responded well. He was admitted to PEDS ICU where he remained stable. His serial evaluations of liver enzymes and hemoglobin showed progressive improvement. He started tolerating oral diet on day 5 and he discharged home on 15th day of admission in a stable condition. Follow-up scan after 3 weeks showed good healing in liver with no residual hemoperitoneum. Our third case is an 11-year-old boy who suffered a serious bicycle handlebar injury to his abdomen 5 days ago. He was referred from rural district hospital for further management. On examination, he was sick looking with high-grade fever and sepsis, and his abdomen was distended and showed marked tenderness in the right upper quadrant. The CT scan revealed grade 4 liver injury extending into the porta hepatis with gross ascites. You can see the liver is being split into 2 parts. This child underwent subhepatic and pelvic peritoneal drain placement, which drained pseudosanguinous fluid and pus followed by frank bile. He also had acute metabolic liver injury, which was managed by a pediatric intensive care team. His sepsis improved, but his subhepatic drain outputs remained high. Following that, he underwent ERCP, which was done to assess the site of ductal injury, which showed extravasation from common bile duct, and syncrotomy with biliary stent placement was done. Leak subsided over next few days, and he was discharged on day 15 of admission. A repeat CT after 8 weeks showed good healing in the liver, and subsequently the biliary stent was removed. My last case is a 9-year-old boy victim of hit-and-run accident. On arrival, the patient was drowsy with unstable vitals. ATLS protocols were initiated. His abdomen was distended and tender in the right hypochondrium with multiple abrasions over his back and limbs. His vitals improved and after aggressive resuscitation and a CT abdomen with contrast was done, with showing complete loss of vasculature to the right lobe of the liver. Moreover, there is free leak of contrast in the axial image, and this is also noticed in this coronal image. This child became unstable during the CT and he was immediately taken to the operating room where he died before opening up the abdomen. As Dr. Salan said, only God can save these cases. So the conclusion is that high-grade liver injuries pose significant challenge to management owing to massive internal bleeding and associated ductal injuries. Trauma centers that manage solid organ injuries, including liver, should have access to specialized interventional radiologists and endoscopists who are skilled in performing angioembolization and biliary stenting procedures in children. Thank you. Any questions?
Do we have time for a question?
We have got one paper presentation by Dr. Bushra Kiran Naeem, Consultant General Surgeon with special interest in upper and lower GI surgical oncology. Please.
Assalamualaikum. My name is Dr. Bushra. Today I would like to present an article which is my dissertation-based article, Visceral Injuries in Patients with Blunt and Penetrating Abdominal Trauma, presenting to a tertiary care facility, Karachi, Pakistan. Okay. This is the outline of my presentation. Abdominal injuries are responsible for 10% of the mortalities due to trauma. Delays in early diagnosis and misdiagnosis are the two major reasons for the morbidity and mortality associated with abdominal trauma. So as we all know, trauma is the damage caused by an exchange with environmental energy which is beyond the body's resilience. Civilian trauma is a major cause of death worldwide, and technological advances and diagnostic measures have led many trauma surgeons to opt for conservative management. So trauma, based on the mechanism of abdominal trauma, we have divided, as we all know, as a blunt and penetrating abdominal trauma. Penetrating involve the breaches in the peritoneal cavity with stab and gunshot wounds, and the blunt abdominal trauma are due to the falls due to impact or countercoup wounds within the peritoneal cavity. The most affected organs are the solids, and the hollow visceral injuries are difficult to diagnose initially, and many trauma victims are referred to the tertiary care hospitals like JPMC and Civil daily on daily basis, secondary to the car, bicycle, firearms, stab and fall injuries. The aim of my study was to determine the frequency of visceral injuries and compare these frequency of visceral injuries in patients with blunt and penetrating trauma. So methodology, this was a cross-sectional observational study which was conducted in the Department of Surgery, Jinnah Postgraduate Medical Center, where I did my residency from May 2016 to May 2018, and a total number of 140 participants were included in our study. So the inclusion criteria was that the patients over 12 years of age with blunt and penetrating abdominal trauma were included, and polytrauma patients along with the neurological, thoracic, ortho were excluded from our study. So after taking approval from the hospital ethics committee, we take informed consent, oral and written from our patients, and basic demographic data like age, gender and trauma type and duration of the trauma was noted. After initial treatment, as per ATLS protocols, depending upon the patient's condition, we send them to radiological department, and the abdominal visceral injuries were noted in detail. So the patients who were stable, we conducted chest X-ray, abdominal X-ray, FAST and CT scan, depending upon the availability at the time in that emergency department. So we performed exploratory laparotomy in the blunt abdominal trauma depending upon the signs of peritonitis like tenderness, hemodynamically instability, and the FAST positive. So we explored those patients, and we find out the abdominal visceral injuries. The data regarding the abdominal visceral injuries was noted, and the injuries were also graded according to the American grading system, as we all know, for liver, spleen, and intestines. So after statistical analysis, we calculated the mean and standard deviation for the quantitative variables, and percentage data was computed for the qualitative variables. And the post-stratification chi-square test was applied, and the significant p-value of 0.05 was decided. So in the results, total number of 120, in the total patients, 128 per males, that is about 88%, and 16 were only females. So which showed that majority of our patients presenting to the emergency were males with a ratio of 9:1. So the age distribution showed that majority of the patients were less than 30 years of age, about 75, which concluded 53%, and 46 patients were greater than 30 years of age. So the age range with the most frequent was 15 to 70 years of age, indicating that the abdominal trauma is more prevalent in the younger age groups. So the type of trauma were the blunt and penetrating. 72 patients were presented as a penetrating trauma and 68% with the blunt penetrating trauma. And here males were predominant in both the cases. So the duration of trauma was if the patient presented within less than 3 hours, that were a total of 94 patients, as our hospital were the center of the city. So most of the patients presented early, and 46 patients presented late after 3 years. So mean duration of trauma was 3.6, and the majority of the patients were presented in less than 3 hours of duration. The hospital length of majority of our patients were 10 days, which is longer in the blunt abdominal trauma patients. So the mechanism in the blunt abdominal trauma, we find that 58% of the patients had road traffic accidents, and 32% fall from height, and 10% assaults. And penetrating trauma, majority of our patients were gunshots, and stab wounds were 15%. So this is the percentage of the visceral injuries, in which you can see that liver is the most common after intestine. That is 67% of the patients were presented with intestinal, with the blunt and penetrating 20 and 47% respectively, and liver 24 in blunt and 13 in penetrating trauma. So this is the distribution of the blunt and penetrating injuries in the various visceral organs, in which you can see that yellow, the orange one is the blunt trauma, and the lighter orange and the dark orange is the penetrating. You can see the intestine is the most common here in the penetrating, and liver is the most common in the blunt trauma. Spleen in the midline, and rest of the viscera, pancreas, diaphragm are the rare ones. So this is the comparison of the liver injuries with the baseline characteristics. You can see that the liver has a significant p-value of 0.02% in our study. They are associated with blunt trauma, and intestinal injuries were significantly associated with penetrating trauma. Like this is also has a significant p-value. So rest of the visceras, they were affected, but not a significant one. The age and gender distribution has no significant association with the visceral injuries. This is for the pancreas and the stomach. So this is the comparison of the grade. You can see the grade 4 liver injuries are more common, and in the blunt trauma, we can see that spleen grade 3 and 4 were most common. And here we can see that in the liver injury, penetrating have equal distribution. The grade 4 liver injuries have already been, and this is the splenic distribution, and the pancreas were the rare injuries. So this is the distribution of management. Majority of the patients were managed surgically, 66% in blunt trauma, 97% in the penetrating trauma. So in conclusion, we can say that currently local data exists which show the frequency of visceral injuries in blunt and penetrating trauma in a tertiary care hospital in Karachi. We found that penetrating trauma was more common than blunt trauma, and intestines were the most commonly affected, which is non-related to the literature available. For blunt injuries, liver is the most commonly affected, which is equivalent to the literature which we usually see, followed by the spleen, and liver is the largest organ. That's why it's more liable to injury. We hope the outcomes of our study will provide practical, usable data to help policymakers and lawmakers make informed decisions in the interest of the public safety. I'd like to acknowledge my professors during my residency. Thank you.
Thank you so much, Dr. Bushra. I think the panelists had some questions for the audience. Dr. Waqas,
sorry, if there is any other question that the audience wants to ask to the speaker who are still here. Yes, please. Any comment or question?
Waqas has left, I guess. We are extremely apologetic for the delays we had.
Okay, no worries. So my question was with him, probably for the first case and the third case. First case, why they did not consider angioembolization when patient second time bled, and why in the, so basic. That is important. And I congratulate you on very good presentation. That is good, actually, start of registry that you have started. Good work done. Thank you.
Thank you so much. Thank you so much for your encouragement. I think we'll conclude our session here. Thank you so much for being patient and listening to the presentations. Thank you to all my panelists who joined us on stage and for your valuable time and comments. Thank you, everyone. Thank you.
Thank you for your time and patience. Now I'd like to tell you that lunch has already started and it is in the marquee, right? And we'll be reconvening in around half an hour for
आपके more than 400 होंगे, so you will be scoring 1. All right, तो चूँकि मेरे पास IL6 level 600 plus थे, तो इसलिए इनका जो न्यूट्रिक स्कोर है वो 7 है, which is very high, and इससे worst clinical outcomes हो सकते हैं. NR score 6 है, which means that the patient is at high risk. While as if we look into nutrition assessment part, हमें protein और energy requirement calculate करनी थी, तो 1880 was the energy requirement, which does not require activity factor, and protein requirement was 63 grams per kg body weight. All right, so these are the references, and if any questions you can ask. Is that all right?
Thank you. Thank you. Thank you so much, Dr. Nidha. And this was a very interactive session. Do you have another presentation as well? Yes, the second one, please.
अब सब आंखें खोल के पढ़ें, क्योंकि फिर मैं सवाल देने वाली हूँ. 20 सेकंड लगा दीजिए diagnosis के.
Ms. Nidha will also be covering diagnosis as well.
Yeah.
So we'll be moving towards that now.
Should it start? Start kar do? All right. So another topic that I'll be covering today is nutrition diagnosis for a trauma patient. It is somewhat different from the medical diagnosis that we oftenly read into medical records. So my objective is to distinguish between medical and nutrition diagnosis, to identify the domain in which that nutrition diagnosis will fall, to interpret and write down the PES statement that has been established by the Academy of Nutrition and Dietetics USA, and to outline the guiding principles for writing a PES statement, and then you will be supposed to write a PES statement as well. So if we look into what is basically a nutrition diagnosis, so it differs with the medical diagnosis in a manner that nutrition diagnosis is a problem that is something that specifically a nutrition professional or a dietitian can solve herself or himself. Oftenly, the people who are even working in nutrition profession are unable to identify that what is the difference between medical diagnosis and nutrition diagnosis. So for example, if we say that some patient is having excessive carbohydrate intake, you can reduce it as a dietitian by counseling, by giving effective nutrition management plans. But if we say that the problem is diabetes, uncontrolled blood sugar levels can be due to many reasons. Might be because of a dose adjustment, might be because of stress-related issues that require psychological interventions, might be because of some inflammation or infection-related issues that require infectious control team to intervene. So the difference between nutrition diagnosis is that any problem that a dietitian can solve as a person, as an individual, and on the basis of that diagnosis, a nutrition intervention is made. All right? So a medical diagnosis basically describes a disease or pathology of that organ. However, a nutrition diagnosis describes a problem that basically focuses the intake or clinical focus on the nutrition domain. All right? For example, if there is a swallowing difficulty, like that we commonly label as dysphagia, it might be because of some aging, but because of a swallowing difficulty, that person is unable to consume anything orally. So this might be a problem, but this is not a nutrition problem. This is a medical problem. The nutrition problem might be reduced oral intake because of or related to the etiology would be the swallowing difficulty. All right? So what is the purpose of nutrition diagnosis? Because many times all of you have been practicing in the clinical field. हम लिखते हैं nutrition consult में, this patient does not require any nutrition intervention. It is because we are not, the team or the healthcare people are not aware that many nutrition related problems or healthcare problems do not require nutrition intervention. अब भाई जिस भी मरीज को बुखार होगा वो कम ही खाएगा ना, आपको भी बुखार हो जाए आप कम खाने लगेंगे, लेकिन हर बुखार वाले मरीज को न्यूट्रिशन सपोर्ट रिक्वायर्ड है ये ज़रूरी नहीं है. तो इसके लिए हमें एक न्यूट्रिशन डायग्नोसिस बनाना ज़रूरी है कि वेदर द प्रॉब्लम इज़ रिलेटेड टू न्यूट्रिशन एंड वी कैन इंटरवीन इन दैट प्रॉब्लम और नॉट. ओके, सो इसका एग्जाम्पल मैंने दिया है कि इनकन्सिस्टेंट कार्बोहाइड्रेट इनटेक इज़ डिफरेंट फ्रॉम अ मेडिकल डायग्नोसिस दैट इज़ डायबिटीज़. अब इसमें जो आपके राइटिंग स्टाइल है वो ये है कि आप सबसे पहले प्रॉब्लम लिखें, फिर उसकी ईटियोलॉजी लिखें, यानी जो न्यूट्रिशन प्रॉब्लम है वो आपके ख्याल में किस रीज़न की वजह से हो रही है, और फिर उसके रिलेटेड साइंस एंड सिम्टम्स मेंशन कर दें. ठीक है, इट इज़ रिटन इन दैट फॉर्मेट, जो कि अकेडमी ऑफ न्यूट्रिशन डायटेटिक्स का एक स्पेसिफिक मेथडोलॉजी है, जिसमें आप सबसे पहले न्यूट्रिशन प्रॉब्लम लिखते हैं, फिर रिलेटेड टू में आप ईटियोलॉजी लिखते हैं, जो आप समझते हैं कि ये जो प्रॉब्लम है ये इस रीज़न की वजह से इवॉल्व हुई है, और फिर आप उसकी कोई एविडेंस देते हैं कि आपको क्या लगता है कि क्यों ऐसा इस ईटियोलॉजी की वजह से हो रहा होगा. अब इसका एक बहुत ही कॉमन एग्जांपल ये है कि आप सब लोगों ने हाइपर कोलेस्ट्रोलीमिया के मरीज़ कभी ना कभी अपने प्रैक्टिस में देखे होंगे. तो अब अगर आप किसी हाइपर कोलेस्ट्रोलीमिया के मरीज़ को देखते हैं और आपको पता चलता है कि उनकी फ़ैट इंटेक बहुत ज़्यादा है, तो उनका पीएस स्टेटमेंट कुछ ऐसा होगा कि एक्सेसिव फ़ैट इंटेक और एक्सेसिव सेचुरेटेड फ़ैट इंटेक रिलेटेड टू, यानी कि इसलिए क्योंकि उनकी लाइफस्टाइल पुअर है, पुअर डाइटरी हैबिट्स हैं, पुअर डाइटरी चॉइसेस हैं, रिलेटेड टू पुअर डाइटरी चॉइसेस एज एविडेंस्ड बाय LDL लेवल्स, VLDL लेवल्स, टोटल कोलेस्ट्रॉल लेवल्स, BMI, whatever the different standards or criterias that are available for your health records in your clinical setup. All right. So this is kind of a simple method to write or document a nutrition diagnosis that we have been working as dietitians to bring it in Pakistan. All over the world तो इस पे काफ़ी काम हो चुका है and people are working on it, but पाकिस्तान में अभी इसकी practice ज़रा इतनी consistent नहीं है. ठीक है, so examples इसके कुछ यूँ हैं: excessive fat intake related to frequent consumption of fast foods as evidenced by 10 meals per week, या फिर energy intake है, disordered eating pattern है, swallowing difficulty है. Likewise, it varies from the case to case. You must need to identify and think critically कि basically इस patient को nutrition problem क्या है जो आप as a whole soul person deal कर सकते हैं. ठीक है, so these are likewise guidelines जो मैं discuss कर चुकी हूँ. प्रॉब्लम में यही बात है कि वो कौन सी ऐसी प्रॉब्लम है, न्यूट्रिशन प्रॉब्लम, जो आप खुद रिजॉल्व कर सकते हैं एज एन इंडिविजुअल और ग्रुप और टीम. ठीक है, ईटियोलॉजी, इसके रूट कॉज क्या है, उस प्रॉब्लम के अकर होने का, साइंस एंड सिम्टम्स क्या हैं कि जो उस प्रॉब्लम को मेजर या इवैल्यूएट करने में आपको हेल्पफुल होंगे. ठीक है, सो नाउ दिस इज़ अ केस स्टडी. ये वही साहब हैं जो पहले आपके पास ट्रॉमा सेंटर में आ गए थे, फिर डिस्चार्ज हो गए. अब ये वापस 6 महीने बाद आए हैं फॉलोअप पे और इनकी स्प्लिनीन रिमूव हुई थी. अब 6 मंथ्स बाद यहाँ आए हैं तो पता चला है कि इनकी 25 पाउंड्स वेट लॉस हुआ है और ही हैज़ बीन डायग्नोज्ड एज क्रॉनिक पैनक्रियाटाइटिस बाय द जनरल मेडिसिन टीम. तो अब इनको जो कंप्लेन है इस वक्त करंटली वो ये है कि इनको पोस्ट प्रांडियल पेन होता है और स्टिटोरिया होता है आफ्टर एवरी मील. ठीक है, तो ऐसे जो भी आपके केस हो, इसमें आप एज अ डाइटिशियन एक न्यूट्रिशन डायग्नोसिस बनाना आपको आना चाहिए. तो अब आप एक छोटी सी एफर्ट करें, गलत भी कर लें कोई मसला नहीं है, कि ऐसे केस के लिए आप क्या न्यूट्रिशन डायग्नोसिस बनाएंगे. एक ऐसी प्रॉब्लम जो एज अ डाइटिशियन आप सॉल्व कर सकती हैं, उसका रूट कॉज क्या है और उसके साइंस एंड सिम्टम्स क्या हैं. ये केस आपके पास यहाँ भी प्रेजेंट हो रहा है और जो आपको हैंड आउट दिया गया है उसमें भी लिखा हुआ है. थोड़ा क्रिटिकली सोचें. ऐसा एक मरीज़ आ गया आपके ओपीडी सेटअप में. ओपीडी होता है ट्रॉमा सेंटर में? नहीं, न्यूट्रिशन का नहीं होता. अब कराना, अब आ गया आप लोगों को. सो अब आगे ऐसा मरीज़ है जिसको आपकी जनरल मेडिसिन की जो टीम है उसने कह दिया है कि भाई इसको क्रॉनिक पैनक्रियाटाइटिस है. अब आप कैसे मालूम करेंगे एज अ न्यूट्रिशन प्रॉब्लम उसको क्या प्रॉब्लम है. कैसे उसको डायग्नोसिस कैसे लिखेंगे उसका? अगर हम पाकिस्तान को तरक्की कराना चाहते हैं तो सीखना ही पड़ेगा. यार आप लोग तो एफर्ट भी नहीं कर रहे, मतलब ऐसा तो नहीं करें ना, कोशिश तो कर लें कुछ, तो बताएं प्लीज़. कुछ करीब हैं आप, बट थोड़ा सा इसमें टर्म्स का थोड़ा डिफरेंस होना चाहिए कि हाँ आप ये सही कह रही हैं कि ओरल इंटेक्स ऐसी बात है पेशेंट का कम है, तो इसको हम कुछ इस तरीके से मेंशन कर सकते हैं. ऑल्टर्ड जीआई फंक्शन, क्योंकि ऐसी बात है वो जैसे ही खाना खाते हैं उनको स्टिटोरिया शुरू हो जाता है, ठीक है, पोस्ट प्रांडियल पेन होने लगता है. रिलेटेड टू कॉम्प्रोमाइज पेनक्रियाटिक फंक्शन, क्यों भाई ये क्यों हो रहा है, जो जीआई फंक्शन क्यों ऑल्टर हो रहा है इनका? इसलिए क्योंकि जो पेनक्रियाज हैं वो प्रॉपर्ली काम नहीं कर रहे, पेनक्रियाटाइटिस है, ठीक है. एज एविडेंस्ड बाय, यानी आप साइन एंड सिम्टम क्या बताएंगे कि भाई साइन एंड सिम्टम क्या है कि इनको स्टिटोरिया हो रहा है और पोस्ट प्रांडियल पेन हो रहा है और वेट लॉस हो रहा है अप टू 25 पाउंड्स इन द लास्ट 6 मंथ्स, जिसकी वजह से आपने ये शो किया है कि ओके इनके ऑल्टर्ड जीआई फंक्शन की वजह से इनकी जो भी न्यूट्रिशनल स्टेटस है वो ख़राब हो रहा है, पुअर न्यूट्रिशनल स्टेटस है, जो भी इनकी इनटेक है वो अगर ले भी रहे हैं तो वो बॉडी एब्जॉर्ब नहीं कर पा रही, विच इज़ लीडिंग टू वेट लॉस एंड डिक्लाइन इन न्यूट्रिशनल स्टेटस, ठीक है. सो दीज आर द रेफरेंसेस दैट आई हैव यूज्ड. ये जो अकेडमी ऑफ न्यूट्रिशन एंड डायटेटिक्स है यूएसए में, दे एक्चुअली प्रेजेंटेड, तो 2014 में उन्होंने किया, फिर 2018 में, और अब 2022 की इनकी लेटेस्ट गाइडलाइंस मौजूद हैं अगर आप जाके रीचेक करना चाहें, ठीक है. सो थैंक यू फ्रॉम माय साइड. इफ़ देयर इज़ एनी क्वेश्चन आप प्लीज़ पूछ लें, इफ़ देयर इज़ एनी क्वेश्चन.
Thank you, Ms. Nidha Azhar. We'll be moving towards questions at the end of the session. And now I'd like to call on stage Senior Lieutenant Ms. Aisha Nasser from PNS Shifa. She's a registered dietitian and she's here to talk on, present a talk on nutritional intervention and monitoring and evaluation of trauma patients. The timer, please.
Assalamu alaikum everyone. I'm Aisha Nasser. I'm sub-lieutenant in PNS Shifa Hospital, Karachi, and I'm a registered dietitian. So today the topic of my presentation is nutritional intervention, monitoring and evaluation of the trauma patients. Okay, this is the roadmap of presentation, and I will not go into the details that what is the pathophysiology of the trauma. Let's come towards the nutrition intervention. Ms. Nida ने already assessment and screening and diagnosis को बहुत अच्छा और detail में present कर दिया है. So our objectives for nutritional intervention is to assess and monitor the extent of injury and resulting problems and start the nutrition care plan as soon as possible, and determine the GI function which we use in the assessment process and provide the nutrients in the most effective mode, and use the gut wherever is possible. If gut is not available, then we move towards the parenteral nutrition. So decrease the nitrogen losses by increasing the protein intake of the patient, meet elevated energy requirements, and our target is to spare the proteins and lean body mass, and determine and monitor the folate requirements and balance. Promote healing and rapid recovery, and promote rehabilitation and improve the quality of life. Our goal of nutrition therapy is to ensure that the optimal nutritional support is planned and provided as prescribed to meet the energy requirements and protein requirements, as well to prevent or detect any possible complications and to correct the micronutrient deficiencies. Ms. Nida ने discuss किया कि most hospitals have updated themselves. We are now using the ASPEN guidelines. 2016 में ASPEN ने American Society of Parental and Enteral Nutrition ने अपनी guidelines update की थी, and then 2021 and 2022 में उन्होंने मज़ीद उसे update किया था कि आपने कौन सी equations use करनी है for the caloric requirement. So 20 to 35 kilocalories per kg per day by using the thumb rule we are using in our ICUs and in our critical care units, and protein is 1.2 to 2 gram per kg per day depending upon the patient requirements. Standard nutrition therapy in the traumatic brain injury, these are the patients with traumatic brain injury are highly in the hypercatabolism and with increased risk of the muscle wasting and tissue atrophy, weight loss, etc. And early nutritional intervention reduces the secretion of catabolic hormones and preserves the body mass. As soon as volume resuscitation is complete and patient is hemodynamically stable, you have to start the nutrition therapy in 24 to 48 hours. Early nutrition therapy may facilitate the recovery of patients in the rehabilitation settings. And different studies have also reported that the patients who had not started with the early nutrition therapy, their chances of the mortality are increased as compared to those in which we have started the nutrition therapy in the 24 to 48 hours. So nutritional intervention, the burnt patients, we have to give them the small and frequent high caloric and high protein meals. Consistency of the meal depends upon the patient tolerance and conditions. Obviously, हम बिल्कुल start में patient को full strength में calories नहीं दे सकते to prevent the refeeding syndrome. Oral nutrition supplement, we can add the oral nutrition supplements to increase the calories if the patient's oral intake is less than 75% of the total caloric requirement, and if there is a greater than 20% burn of the total body surface area should require the immediate enteral support. Start by enteral nutrition if enteral route is not available. So practicing guidelines initiate the enteral nutrition as soon as possible within the 24 to 48 hours of injury in the hemodynamically stable patients. And immune modulating formulas may be used that contains glutamine and arginine that are conditionally essential amino acids in the cases of stress. In severely hypocatabolic patients such as extensive burns and the polytrauma, ratio of the kilocalories nitrogen should be 120:1 or even 100:1 has been accepted. It means we have to give the high proteins और हम 2 gram per kg per day पे भी proteins में जा सकते हैं. So the treatment of trauma patients in the ICU is challenging because of the multiple surgeries, abdominal infections and nutritional metabolic problems. Early nutritional is associated with the less wound infection, lower the mortality and shorter the hospital stay as evidenced by the different studies. So यूजली हम पेशेंट का कौन सा वेट यूज़ करते हैं जब आप पेशेंट्स की कैलोरी रिक्वायरमेंट कैलकुलेट करते हैं, तो कौन सा पेशेंट का वेट है जो आप लोग मॉनिटर करते हैं? एक्चुअल बॉडी वेट लेते हैं या फिर कोई और बॉडी वेट कैलकुलेट करते हैं? एनीवन?
Anybody from the audience would like to answer?
Okay. According to the SPEN guidelines, actual body weight को भी use करने के different guidelines हैं. We usually calculate the ideal body weight of the patients because actual patient का जो weight है वो कम भी हो सकता है, ज़्यादा भी हो सकता है. So we usually calculate the ideal body weight according to the height of the patient. जब patient bedridden है तो हम उसका damage span use करते हैं. आप उसकी जो length है वो measure करते हैं अगर आपको height उसकी पता नहीं है patient की तो. Otherwise use ideal body weight or adjusted body weight. Adjusted body weight जो है वो ideal body weight और actual body weight के in between का point है, क्योंकि for example if a patient is 100 kg और उसका ideal body weight 60 kgs में होना चाहिए, तो आप 60 kgs को maintain करना possible नहीं है ideal conditions. तो आप इसके दरमियान में एक weight लेते हैं जिसको आप कहते हैं adjusted body weight. So we are using the adjusted body weight of the patient. Use actual body weight if weight is less than ideal body weight and dosing और इसका फॉर्मूला है dosing body weight का आपके सामने के ideal body weight आप लेते हैं, actual body weight में से माइनस करते हैं ideal body weight को, multiply with the 0.25, it's a constant factor and then plus the ideal body weight. तो ये आपके पास एक adjusted body weight आप इसको कहते हैं. ये weight का आता है जिसकी बेस पे आप उसकी current caloric requirement calculate करते हैं. Then energy goals is to meet the 25 to 35 kilocalories per kg dosing body weight per day. If BMI is greater than 35, then आपने 35 calories पे नहीं जाना. You have to use the less calories as compared to those patients who have less BMI. So protein goals is to 1.2 to 2 gram per kg dosing body weight, which we have calculated, and fluid needs is usually 1 ml per kilocalories baseline. और इसके अलावा जो fluid requirements हैं वो depend करती हैं according to the conditions. If the patient is renal failure or pleural effusion and fluid accumulation in body, so वहाँ पे आपको fluid requirements patient की देखनी पड़ती हैं. Carbohydrates usually provide up to 50 to 60% of the total calories or 79% of the non-protein calories. So it provides 4 kilocalories per gram of the glucose. Usually, if we are using TPN, the limit is 3.5 to 5 gram per kg per 24 hour. And lipid emulsion provides 25 to 30% of the total energy requirement. So it should not be more than 1 gram per kg per 24 hour. When is the time to start nutrition? कब हम न्यूट्रिशन स्टार्ट करते हैं पेशेंट में?
That's a question posed at you all.
Dietitians are here. How many dietitians are here in the session? Okay. Okay, as we have discussed earlier, we have to start the nutrition therapy in 24 to 48 hours of the injury if the patient is hemodynamically stable. But usually क्या होता है कि nutrition is the most neglected part in the hospitals. हम क्या करते हैं कि पहले उसके सारी चीज़ों में तो लगे होते हैं, उसकी हर चीज़ में, उसकी assessment में, और लेकिन nutrition team को जो है वो call बहुत लेट जाती है. Usually जब patient जो है वो आपको नज़र आता है कि बस अब 7 days 8 days हो गए हैं patient को, और अब इसको हम nutrition team के हवाले कर देते हैं कि आप इसको रिहेबिलिटेशन की तरफ लेके जाएं. एनर्जी अगर आप उसकी स्टार्ट में ही न्यूट्रिशन असेसमेंट करते हैं और वहीं उसी टाइम आप उसकी न्यूट्रिशन इंटरवेंशन स्टार्ट कर देते हैं तो उसके मोर्टेलिटी के चांसेस कम होते हैं एज़ कम्पेयर टू दोज पेशेंट्स जिनकी आप 10 days 15 days के बाद न्यूट्रिशन थेरेपी स्टार्ट करते हैं. टाइम टू स्टार्ट न्यूट्रिशन इज ऑल्सो डिपेंड ऑन द प्री इलनेस न्यूट्रिशनल स्टेटस. अगर पेशेंट को अदर डिजीज़ है, डायबिटीज़ है, ऑलरेडी वो किसी डायलिसिस पे है पेशेंट, and type and severity of the critical illness and organ failures, and the route of feeding and use of the special diets obviously. Traditional nutritional assessment tools are not validated, as Nada have discussed that we use the Nutrix score and RRS 2002. ASPEN in 2016 have had recommended to use these scores because they are validated tools for the critical care patient. Before initiation of the feeding, assessment should include evaluation of the weight loss and the previous nutrient intake before the admission. Level of the disease severity and other comorbid conditions and function of the gastrointestinal tract. Enteral nutrition is obviously the preferred route, and enteral nutrition should be started in 24 to 48 hours. And our advanced goal is to meet the calorie requirement in next 72 hours. Dosing of the enteral feed, initially we use 10 to 20% of the targeted calories. आपने हमेशा से जितनी calories calculate कर ली. For example, if a patient have caloric requirement of 2500, so don't start with the 2500 kilocalories. Because there is a chance of free-feeding syndrome if the patient had been NPO since 7 days. तो आपके पास इस तरह के पेशेंट्स बहुत सारे होते हैं जहाँ पे आपने फीड स्टार्ट नहीं की होती है, पेशेंट स्टेबल नहीं है, तो उसको 7 to 8 days गुजर चुके हैं या 3 to 5 days गुजर चुके हैं. So वहाँ पे आप full strength calories नहीं start करते. We start with the 10 to 20% of the calories. 0.25 to 0.5 kilocalories per ml is usually recommended. Then gradually increase the feed to 70% in first 2 weeks, 0.75 to 1 kilocalories per ml, and then depending upon the patient tolerance, full strength feed when patient is able to tolerate 1 to 2 kilocalories per ml. If unable to meet the energy requirements, 100% of the total calories after 7 to 10 days by the enteral route, consider initiating supplemental parenteral nutrition. Here we recalculate the Nutrix score of the patients after 7 days of initiation of the feed. If the Nutrix score is still high or on the higher side, then we have to start the aggressive nutritional therapy. So initiating supplemental parenteral nutrition before the 7 to 10 days period is not recommended at all. Selection of enteral formula. This is very important. There are different formulas available in the market. Which formula is used for which type of patient is very important. We have standard formulas which have for people who can digest and absorb nutrients. Their GI tract is not compromised, or they contain intact proteins or protein isolates. The osmolarity of the formula is obviously more important. We use elemental formulas, specialized formulas, and modular formulas, and pre-digested formulas as well for the patients who have compromised GI tract. So when to use parenteral nutrition? If enteral nutrition is not available and patient को 7 days हो गए हैं, आप उसमें enteral nutrition नहीं start कर सकते हैं, nutric score is still on the higher side, then you have to start the parenteral nutrition. And same guidelines for the enteral, like enteral nutrition, कि आपने पहले बहुत कम से calories से start करना है, and then you have to increase the calories. Monitoring and evaluation. In monitoring of the patient, monitoring should be done on the daily basis. Electrolyte should be strictly monitored, and monitoring of the refeeding syndrome is especially phosphorus, magnesium and potassium. Refeeding syndrome में हम ये 3 nutrients measure करते हैं. Regular weighing and measurements of the intravenous fluid, feeds and urinary output is necessary. Nitrogen balance, we have just started in our ICU by calculating the nitrogen balance, in which we calculate the 24-hour urine collection, और उसके बाद फिर हम उसका nitrogen balance देखते हैं, और if it's positive, यहाँ पे मैंने example add किया है, we are running out of time, so मैं जल्दी इसको cover करूँगी. उसमें आप ये करते हैं कि आप 24 आवर का यूरिन कलेक्शन करते हैं, और उसके बाद आपके पास जो बैलेंस आता है पेशेंट का, अगर इफ़ इट्स पॉजिटिव तो इट मीन्स कि आप उसको प्रोटीन रिक्वायरमेंट ठीक से दे रहे हैं. अगर नेगेटिव है तो देन यू हैव टू इंक्रीज द प्रोटीन्स. ओके, केस स्टडी डिस्कस कर लेते हैं शॉर्टली. It's almost same as Nida has discussed, but I didn't use the interleukin levels, so Nutric score is 5. इसमें मैंने 48 kg पेशेंट का वेट था, सो आई यूज़ द आइडियल बॉडी वेट 68 kg. कैलोरी रिक्वायरमेंट 30 to 35% एंड प्रोटीन रिक्वायरमेंट अगर 1.5 से मल्टीप्लाई करें तो 102 ग्राम्स. इनिशिएशन ऑफ फीड से 25% कैलोरी से अगर आप स्टार्ट करते हैं तो 510 to 590 कैलोरीज, जिसमें आप इसको बोलस फीडिंग अगर 100 किलो कैलोरीज पर आवर दें तो आप फर्स्ट 25% कैलोरी रिक्वायरमेंट उसकी मीट कर सकते हैं. And monitor for the tolerance and then recalculate the Nutri score after 7 days. अगर still higher side पे है, then you have to supplement the parenteral nutrition, or you have to increase the calories up to 40% per day. Thank you so much.
Thank you, Dr. Aisha. I am so sorry we had to keep on ringing the bell, but thank you so much for your effort. Now I'd like to open the floor to any questions, because we've divided this session into 3 categories, because it's all about physical rehabilitation and wellness. So our first 3 talks were on nursing and nutrition. Now that these 3 talks are over, do you have any questions so far? Anyone? Yes, sir. Can we have the mic, please, for Dr. Akhtar from Ziauddin Medical College? Yes.
Thank you. My question was from the first speaker. She taught about the platinum period awareness. So the question is that either trauma center is working on the awareness in the population, because the platinum period is not associated with doctors or the nurses. It is a layman thing, like on road traffic accident when there are accidents. So हमें पता ही नहीं होता, layman को बिल्कुल पता नहीं होता क्या करना है, the way they should carry. So what awareness campaign trauma center is doing, or how the nursing department is facilitating this thing?
Ms. Sana, the question is for you. Can we please hand over the mic to Ms. Sana?
Okay, मैं दूसरा भी कर लेता हूँ question, फिर आप साथ में कर दें. The second question was, you talked about the role of nurse post-operatively for the rehabilitation and for the क्या कहते हैं उसको, empathy. The thing we have seen in the OPDs, in the IPDs, in the OTs, वो थोड़ा रोल उनका उस तरीके से आता नहीं है, डांटने वाला रोल होता है towards the attendance, रश की वजह से. No doubt, I am a doctor, so मैं समझ सकता हूँ कि कैसे उन चीज़ों को देखा जाता है. But the thing is कि ये awareness वाली चीज़ें patients के साथ, attendants के साथ साथ nurses के लिए भी तो कुछ sessions होने चाहिए. Like जो old age nurses होते हैं, I have seen them to be very rigorous with the attendants. Thank you.
ओके, पहले मैं आपके पहले सवाल का जवाब देती हूँ. ईआर में हम ट्रियाज पे मैनेजमेंट करवा रहे होते हैं. जब जो हम ACLS और BLS की ट्रेनिंग की बात करते हैं तो हमारे पास पेशेंट उसी तरह के आते हैं. इनिशियल असेसमेंट हमारा वहीं पे होता है, उसके बाद ही डिस्पोजिशन होते हैं पेशेंट. और जो मैं बात करी, जो मैंने यहाँ पे डिस्कस किया कि हमारे पास अवेयरनेस सेशन बहुत कम है, अवेयरनेस बहुत कम है. जो मैं अभी अगर स्टेट्स भी अगर शेयर करी थी, हमारे पास ट्रेंड इतना ज़्यादा क्यों है? क्योंकि हमारे पास आरटीए मोस्टली अगर हम देखें तो बाइक रिलेटेड है, ठीक है। ये सब हम बहुत कंट्रोल कर सकते हैं। ये कम्युनिटी लेवल पे हमें काम करने की ज़रूरत है, जिसमें हमें गवर्नमेंट का बहुत इनपुट चाहिए। तो डेफिनेटली कल भी हमने इसी के ऊपर बात की थी कि हमें बहुत सारे लोगों को इन्वॉल्व करके एक साथ चलना होगा, तो ही हम एक मास लेवल पे चेंज ला सकते हैं। सिर्फ अगर हम चाहें कि नर्सिंग जैनेटरी उसको चेंज कर सके, नॉट पॉसिबल। क्योंकि जब हम हॉस्पिटल में या कम्युनिटी में डील करते हैं, वी डील एज अ टीम, राइट। और दूसरा क्वेश्चन?
I think our panelists would also like to comment on this question. And before we proceed with their remarks, I'd like to reintroduce again Ms. Khairunisa with all her designations and with great honor. She is the Principal, College of Nursing at Dr. Ruth K.M. Phow Civil Hospital. She is the former Deputy Director Nursing Sindh, former Controller Sindh Nurses Examination Board, former Focal Person Nurses Sindh Health Departmental, and she is in the COVID-19 pandemic and former member of the Pakistan Nursing Council, and she will be commenting on this question. Yes, ma'am.
अस्सलाम वालेकुम ऑल ऑफ़ यू। मैं थोड़ा सा एलेबोरेट करूँगी इस पॉइंट को जो आपने कहा। हमारे पास जो नर्सिंग का रेशो चल रहा है ना, ये जितने भी हैंडलिंग के प्रॉब्लम्स हैं या बिहेव के प्रॉब्लम्स हैं, इसका एक्चुअल रीज़न ये है कि हम रेशो मेंटेन नहीं कर रहे। हमारे पास, क्योंकि मैं डिप्टी डायरेक्टर एक्टिंग डायरेक्टर नर्सिंग रही और मैंने काफ़ी समरीज़ मूव की नेशनल लेवल पे, प्रोविंशियल लेवल पे, जो इसको मैं अभी भी फॉलो अप कर रही हूँ और हर प्लेटफॉर्म पे ये वॉइस रेस करती हूँ। जब तक हम रेशो मेंटेन नहीं करेंगे, उस टाइम तक स्टैंडर्ड्स मेंटेन नहीं होंगे, क्वालिटी ऑफ केयर नहीं मिलेगी। जो एक्चुअल में नर्सिस का वर्क है, रियली वो नहीं कर रहे, और वो नहीं कर रहे, क्यों नहीं कर रहे, उसके मेजर रीज़न है। देखिए, अगर पॉपुलेशन रेशो लगाते हैं तो हमारे पास 2.5 लाख नर्सिस की शॉर्टेज है इन सिंध, और अगर हम नर्स डॉक्टर रेशो लगाते हैं तो हमारे पास 65,000 नर्सिस की शॉर्टेज है, और वी कांट मीट। अगर हम बेड पेशेंट रेशो लगाते हैं तो जो मेरी स्टैटिस्टिक्स के हिसाब से बनता था, हमारे टर्शरी केयर और जितने भी हॉस्पिटल हैं, BHU हैं, प्राइमरी हेल्थ केयर हैं, उस जो एग्जिस्टिंग बेड रेशो है उसमें भी हमारे पास तकरीबन 20,000 नर्सिस की शॉर्टेज है। तो यहाँ जब इतनी शॉर्टेज है तो हम कैसे मेंटेन करेंगे प्राइमरी हेल्थ केयर, सेकेंडरी हेल्थ केयर? जैसा कि सना ने बात की कि उस लेवल पे हमें मैनेज करना है। बहुत सारे हम टर्शरी का बर्डन ख़त्म कर सकते हैं अगर हम वहाँ पर पब्लिक हेल्थ नर्सिस का रोल लेकर आते हैं। इनिशियल असेसमेंट, जिस तरह मैं कह रही थी कि ट्रॉमा नर्सिस होने चाहिए हमारे पास। अब हम इस टाइम, क्योंकि हमारा जो पाकिस्तान नर्सिंग काउंसिल का एक्ट है वो रिवाइज हो गया, अमेंड हुआ है 2022 में, और पाकिस्तान नर्सिंग एंड मिडवाइफरी काउंसिल बनी है, साथ नर्स प्रैक्टिशनर का रोल आ गया है। तो अब जो हमें गवर्नमेंट लेवल पे, यानी जो स्टेट की जिम्मेदारी है, वो रेशो मेंटेन करें। हमारे पास 20,000 डॉक्टर्स हैं, एटलीस्ट 20,000 नर्सिस कर दें तो हम रेशो मेंटेन करेंगे। सेकेंडली, डिस्ट्रिक्ट नर्सिंग ऑफिसर की पोस्टें ही नहीं है। डिस्ट्रिक्ट हेल्थ ऑफिसर है तो डिस्ट्रिक्ट नर्सिंग ऑफिसर क्यों नहीं है? आप डिस्ट्रिक्ट लेवल पे नर्सिस को, क्वालिफाइड नर्सिस हमारे पास अवेलेबल हैं। हमारे पास BS नर्सिस 25 से तकरीबन 5,000 नर्सिस क्वालिफाइड होकर निकलेंगे। इससे पहले डिप्लोमा प्रोग्राम था, उसके भी क्वालिफाइड नर्सिस हमारे पास मौजूद हैं, जिन्होंने पोस्ट RN किया, मास्टर्स किया, PhD किया। तो हमारे पास स्पेशलाइज्ड नर्सिस आ रही हैं। जिस तरह न्यूट्रिशनिस्ट की बात की, तो अब हमारी नर्स स्पेशलिस्ट होगी जो कि मास्टर और PhD क्वालिफिकेशन के साथ होगी। इस तरह ट्रॉमा केयर नर्सिंग की मैंने बात की कि हम ट्रॉमा सेंटर से ही स्टार्ट करते हैं, तो ये ट्रॉमा मैनेजमेंट में बहुत इंपॉर्टेंट रोल होगा उन स्पेशलाइज्ड नर्सिस का, जो कि उनकी स्टडीज़ अवेलेबल हैं इंटरनेशनली, वो लोग ग्लोबली काम कर रहे हैं, रिकग्नाइज़ किया गया है। लेकिन इल्मिया ये है कि पूरे पाकिस्तान में ये जॉब्स ही नहीं है। तो सबसे पहले तो पोस्टें क्रिएट करने की ज़रूरत है, करिकुला बनाने की ज़रूरत है। तो हम हाई लेवल पे इसको, स्टैंडर्ड्स को मीट करने के लिए तमाम चीज़ों पे वर्क कर रहे हैं। और बिहेवियर का इशू यही आता है, जब एक नर्स 50 पेशेंट देखेगी तो वो तो उससे दुआ सलाम भी नहीं करती, डायरेक्ट मतलब जो ऑथ हैं, जो एथिक्स हैं, वो उसको वाकई फॉलो नहीं कर रही। और क्यों नहीं कर रही? बर्डन ऑफ वर्क जो है उसके पास बहुत ज़्यादा है। तो इंशाल्लाह इन फ्यूचर हम इस पे वर्क कर रहे हैं और कर लेंगे इंशाल्लाह.
I think we are short on time, but I'd like to add a few more things to what Ms. Khairnisa said. If you attended the talk yesterday, the plenary talk by Dr. John Swinnon, he mentioned he is a vascular surgeon, a war surgeon for Doctors Without Borders. And he mentioned that in the ER and A&E, when the number of casualties increase, then the level of care falls because there are not as many people present who can actually take care of them. That includes paramedics, that includes nurses, doctors on duty, etc. So we need to, if we're talking about trauma, we need to introduce those kinds of services and access points and then populate them with specialized people. And the thing is that we are placing way too much burden on our nurses, not understanding that they have specializations which we are not further educating them on, and that they're just one person doing a lot of work which perhaps they shouldn't be doing. Like in the trauma center in itself, there are early warning signs. We have an expectation that early warning signs bhi dekhne hain, ye bhi dekhna hai, wo bhi dekhna hai. But at the same time, they're doing so much more, right? So it's about how much can a single nurse do. And then expecting ke khush akhlaq bhi ho, to I think it's a little too much. Thank you. So now moving on towards the second or the middle of our session. Again, physical rehabilitation is very, very important when it comes to surgical management. I think if you look at it from a certain aspect of society or from a certain branch of medicine, it's almost as important as the surgery itself, because post-operative care and rehabilitation, reintroducing the patient back into society in a way that they can reintegrate into it, deals with their overall well-being and how well or what they can make out of the surgery itself. For that, I'm honored to have Professor Dr. Nabila Sumro, and she is the director of IPMR, Institute of Physical Medicine and Rehabilitation. Dr. Sumro, we thought you would not be able to make it, but I'm so pleased you're here. So can we have you on stage? Nabila's topic is Impact of Rehabilitation on Post-Traumatic Patients.
Bismillah ar-Rahman ar-Rahim. My apologies, we had a similar event at our institute, so I just quickly wrapped it up and
Glad you're
came
here.
I think Dr. Zahra has said that rehabilitation and trauma go hand in hand. If you don't rehabilitate traumatic patients, there's no role. The treatment is just not complete. So we'll, ये मेरे हाथ में control है? Okay, thank you. So we'll be quick. This is the first civilian institute in Pakistan, multidisciplinary, which caters to all rehabilitation, like all disabilities. Trauma resulting in disability, rehab is the only answer. हम अपने इंस्टीट्यूट पे कौन से बहुत सारी चीज़ें ट्रॉमा के बहुत ट्रॉमेटिक पेशेंट्स रिपोर्ट होते हैं, कौन से हैं जो हमारे यहाँ बहुत कॉमनली आते हैं? Amputees, traumatic brain injury, spinal cord, people with peripheral nerve injuries, penetrating blunt injuries, burn, musculoskeletal, chest injuries, and you go on. Most commonly, amputees or traumatic brain injury and spinal cord top of the list में है. Spinal cord के बारे में मेरे colleague बात करेंगे, and I'll be highlighting कि how can we make the difference in patient's life if we are involved. The first and core component of rehab that all rehab professionals should be under one roof when a trauma patient is referred or they walk in. So, around the patient, we as a rehab physicians, any surgeon who's dealing a trauma, could be neurosurgeon, could be an orthopedic surgeon. So me, with my allied health team, physiotherapist, occupational therapist, neuropsychologist, prosthetist, orthotist, language swallowing and audio. So my whole team, we work together as a rehab team. We as a rehab physician, we diagnose, we make a plan, and then we implement it through the team. So amputees के लिए क्यों ज़रूरी है? अगर हम amputees as an example लेते हैं कि rehab का क्या role है? Amputee आया, surgeon ने amputate किया, और फिर then he goes home. What about कि उसकी psychological support before amputation? Mentally preparing him that this is not end of the life, so आपको prosthesis दी जाएगी, या prosthesis के बाद आपकी क्या life होगी और आप क्या क्या कर सकते हैं. That's very important. Amputees, चाहे वो किसी hospital से discharge हो या किसी trauma के through they are thrown out of their jobs, they are given certain amount of money and they are asked to leave. Once the trauma is over, limb is amputated, we concentrate on positioning. Positioning ठीक नहीं होगी तो contractures और complications होंगी, और बाद में अगर हम artificial limb या prosthesis देना भी चाहेंगे तो नहीं दे पाएंगे. Do's and don'ts, ये बहुत ज़रूरी है for any surgeon to know. I don't know हमारे audience में surgeons हैं या नहीं हैं. I didn't get chance to interact, but they must know कि after surgical amputation, what are they, which positions are they supposed to avoid, ताकि वो बहुत खुश हो जाते हैं कि जी wound heal हो गया, सब ठीक ठाक है, और end में हमें मरीज मिलता है with contractures, with multiple complications. जिस मरीज को हम easily artificial limb दे के आराम से चला सकते थे. Strengthening of the stump and the contralateral limb. This I am talking about immediately when the limb is amputated and the wound is healed. So we work on the position to avoid complications. We strengthen the stump and the contralateral limb. Skin care is very important before fitting the artificial limb. Shape of the stump is very important. ये 4-5 steps हैं कि अगर rehab physician और surgeon साथ काम न करें, can result in disasters. We train them in activities of daily living, that जब तक आपकी limb न लगे, in order to gain confidence, हमारा ADL floor जो है, our therapists teach them and give them assistive devices so that they can, how can they do their own activities without being dependent? We control their pain through physical modalities, through different strategies, apart from painkillers. Stronger the painkiller, they'll be more like, they're more, मैं कहूँगी कि इतने वो active नहीं होते हैं, या depression अलग होती है, उनको जितने stronger centrally acting painkillers दें, and they are not as alert. So different pain strategies rehab team उनको offer करती है so that they can be pain free. They allow us to put the limb and do their training. क्या complications हम avoid करते हैं अगर we take them through this good journey of rehab? We avoid their short stumps, जो हम surgeons के साथ मिलके decide कर सकते हैं. Short stump से बहुत बेहतर है कि वो through joint disarticulation करें, ताकि हमें बड़ा सा lever मिले in order so that they can walk with the artificial limb. So next time my request is कि हमारा जब भी session रखा जाए, it should be interactive with surgeons. I don't know how many are present in our contractures. Surgeons can easily prevent contractures by edema, कि किस position में नहीं रखना है, improper skin grafts, phantom limb pain. Phantom limb pain is the pain experience in an absent limb, which is not there, but patient feels pain in that limb, and that's devastating. So we treat that, and also dermatological issues, how to keep the stump clean and all. So this is a role of a rehab team for any amputees. Sorry. ठीक है? उसके बाद आती है कि prosthesis की stage. Prosthesis are many kind, body powered है, myoelectric है, hybrid है, bionic है. ये सारे design होते हैं और manufacture होते हैं हमारे institute पे. We give them. गिविंग प्रोस्थेसिस, प्री प्रोस्थेसिस से अगर आप नहीं शुरू करेंगे तो प्रोस्थेसिस फिटिंग और गेट ट्रेनिंग में हमें बहुत प्रॉब्लम होता है, ठीक है. दोज वर अपर लिम्ब, दीज आर लोअर लिम्ब. और इसी तरह से हमें गेट ट्रेनिंग करनी पड़ती है और फिर डिसाइड करना पड़ता है कि उसके बाद वो किस जॉब या जगह पे जा सकता है. सो दिस वाज एम्प्यूटी. आई क्विकली हाईलाइट कि ट्रोमैटिक ब्रेन इंजरी. सेकंड जो हम ज़्यादा देखते हैं ब्रेन इंजरी. ब्रेन इंजरी में मेडिकली स्टेबल करके मरीज़ घर पे, लेकिन इतने इश्यूज होते हैं मरीज़ के साथ कि वो घर पे एक वेजिटेबल की तरह होता है. जस्ट सेविंग लाइफ is not, you know, if you leave them like a vegetable. तो rehabilitation settings क्या होती हैं कि न्यूरोसर्जरी वार्ड से डिस्चार्ज हो और हमारे पास आए, so that we can take over at that stage. Then we call them as an outpatient और फिर हम उनको कम्युनिटी के में किस तरह reintegrate करेंगे. So this is a flow chart. Time is less. I'm watching. I only have 2 minutes more. So I'll quickly scroll through the slides so that I can tell you कि as soon as the patient is discharged, उसके बाद उसकी journey, apart from medically, जब वो medically और surgically stable हो जाता है, then our team takes over. What happens? जो specific programs बहुत important हैं, जो totally ignore हो रहे हैं. Post traumatic amnesia, उसकी assessment और उसकी treatment. Post traumatic agitation, किस तरह पेशेंट को सेफ रखा जाए, एनवायरनमेंट कैसा हो, किस तरह उसको हैंडल किया जाए डे 1 से. कॉग्निटिव रिहैबिलिटेशन बहुत इंपॉर्टेंट है. उसके बाद ही लूज मेमोरी अफेक्ट हो जाती है, एग्जीक्यूटिव फंक्शंस अफेक्ट हो जाते हैं, नेमिंग अफेक्ट हो जाती है, कॉम्प्रिहेंशन अफेक्ट हो जाती है, तो दैट गोज इग्नोर्ड. तो visual special abilities, he is not able to recognize कि what is over, what is under, what is right, what is left. Attention, memory, चाहे वो recent हो या past हो, speech affect हो जाती है, orientation to time, place, all cognitive functions are affected. So हमारी cognitive behavioral therapy के through we take them through these stages so that we get maximum out of him. स्पेसिसिटी मैनेज ही नहीं होती है, इतने बुरे कॉन्ट्रैक्चर्स में आते हैं, हाइजीन के इश्यूज के साथ आते हैं. वी नीड टू टेक केयर ऑफ दिस फ्रॉम डे 1. कास्टिंग, स्प्लिंटिंग एंड स्ट्रेचेस का प्रोग्राम टुगेदर विल अवॉइड कॉन्ट्रैक्चर्स एंड देन गिव देम अ बेटर क्वालिटी ऑफ लाइफ देयर. अनफॉर्चुनेटली वार्ड्स में चाहे हमारे फिजिशियंस हों, चाहे बिकॉज इट्स नॉट देयर फॉल्ट, दे हैव नॉट बीन एक्सपोज्ड and they don't have a habit of working with a rehab physician team. तो वो जिस तरह हम अभी बात कर रहे थे कि ट्रॉमा नर्स हो, रिहैब नर्स हो, सब बहुत इजी उनकी लाइफ हो सकती है. बैलेंस एंड वेस्टिबुलर असेसमेंट, बिकॉज जर्की मूवमेंट से उनका वेस्टिबुलर सिस्टम डिस्टर्ब हो जाता है और सेंट्रल इंजरीज से उनका बैलेंस. सो वी हैव टू वर्क थ्रू with them through the whole program of gait training, balance and coordination. Dysphagia, comprehension, language issues, swallowing issues are again major problems. जिसपे हमारा पूरा floor, we have about more than 25 language swallowing and audiologists who work. इसलिए अब बहुत रोल है assistive technology का इनकी लाइफ में कि जो हम function gain नहीं कर सकते उनको किस तरह augment करें with assistive technologies. Quite few of them are available and manufactured at our institute, and few can be easily bought from the market. So environmental control equipment, जिस तरह मैं कहती हूँ कि virtual reality driving simulation है, इस तरह virtual reality के बहुत सारे सॉफ्टवेयर में प्रोग्राम्स आते हैं जिसके थ्रू आप उनको ट्रेन कर सकते हैं. सबसे बड़ी बात जो इग्नोर जाती है, डिस्चार्ज प्लानिंग के बाद केयर गिवर को क्या बताना है, फैमिली की सपोर्ट उसको कैसे बाहर लेके आएगी, कौन लाएगा, कौन हमारे पास उसको लॉन्ग टर्म एक रिहैब के प्रोसेस के थ्रू हम करेंगे. एंड इट्स ओनली पॉसिबल व्हेन द टीम कोऑपरेट्स विद द फैमिली और केयर गिवर. केयर गिवर और फैमिली फ्रस्ट्रेट होके इसी मरीज को एक कोने में डंप कर देते हैं, ओनली फीडिंग देम और maximum giving them bath because they don't know and they can be fruitful members of the society. So I thank you all for your attention and apologize for taking 50 seconds more. Thank you so much.
Thank you. It was a pleasure, absolute pleasure. Very enlightening. And now, continuing on that same note, we have Dr. Atif Ahmed Khan. He is the head of physical medicine and rehabilitation at Combined Military Hospital in Malir. He has over 40 plus publications on the same specialization, and he is very passionate about this field, and he is here to discuss a case study of his, which is the critical role of physical medicine and rehabilitation in spinal cord injury. Dr. Atif. Dr. Atif has requested 15 minutes on the clock, so we will indulge him with that for sure. Thank you.
मेरा काम ज़्यादा आसान कर दिया. मैम नबीला has already pointed out, highlighted the role of physical medicine rehabilitation overall in the cases of trauma. So I'll just jump to my presentation. So 250,000 to 500,000 patients per year with a $100 billion financial burden on the society, and a single patient medical treatment cost over $1 million over his lifespan. You can imagine $1 million is a huge amount of money to be spent on a single patient. So this is the impact. This is the financial impact of the condition that we are about to talk on the society, and it also has an impact on the person because of his disability that he encountered and because of the complication he encountered. He developed depression, anxiety, which is 4 times more common in these population as compared to the normal people. And because of depression, anxiety, that patient goes into social isolation, which eventually lead to divorces. Divorces are 2 times more common in these patients, the spinal cord injury patient, as compared to the general population. And eventually it can go to suicidal tendency, which is 10 times more common in such people. So any guess what we are talking about? We are talking about spinal cord injury. And this is our today's topic that I'll discuss, the critical role of spinal cord injury in the physical medicine rehabilitation in the traumatic spinal cord injury patients. So I was thinking कि मैं इसको किस तरीके से आप लोगों को communicate कर सकूं कि ये कितना important है physical medicine rehabilitation. So I came up with an idea to narrate a story of a few of my patients. This will help you understand how critical it is and how it's the role of physical medicine rehabilitation. So I've got 3 patients. All of 3 of those patients have almost similar nature of injuries, but with different outcome. The first is the patient who was not rehabilitated at all, who did not, and the second one is the one who did receive some rehabilitation, but then we lost him to follow-up. And the third one was one who received the rehabilitation, stayed with us, followed with us, and is still following with us, and you will see the results later on in the slides. So the first patient was a 32-year-old wrestler, an army wrestler who competed at various national and international forums and won several medals for the country. One day he was having a local fight in his village. He was a resident of Kasur, like a local jo kushti वगैरह होती है. During that bout of fight, he had an injury to his spinal cord. He was treated conservatively at a local hospital and was discharged by giving initial treatment and remained there for a few days. But he was not referred to any rehab services, or he was not advised anything, and he then went home. He has no idea, no clue about his condition. He later on, 4 months later, he reported in one of the military hospital from where he was referred to us in the Armed Forces Institute of Rehabilitation Medicine, which is the pioneer institute in the physical medicine rehabilitation field in Pakistan. It's in Rawalpindi. There he was assessed and was found to have a spinal cord injury T5 Asia A level. And it was a spinal cord injury without radiological evidence. The patient was dependent in grooming, toileting, all activities of daily living. He had no clue about his disease. And he came to us with the complications like this. He had developed pressure ulcers in its various sites like greater trochanter, sacrum, the medial malleoli. This was his condition when he reported to us. He also developed contractures at the knee and the hip joint, which was very of grave severity. So it was an uphill task. This is the routine that we faces normally. So we gave him, he was rehabilitated with us for almost 8 to 10 weeks, and at the time of discharge, this was the condition. His wounds were already healed from a grade 4 pressure ulcer to almost a healed pressure ulcer. His contracture was much better than before. And this was the patient who didn't report it to us in the first time. The next is the patient who was a 24-year-old soldier who was a resident of Sawabi. He was in an operational area and a bunker fell on him and was evacuated to CMH Rawalpindi, where he was operated upon and was labeled as a spinal cord injury T10 ACIA patient. Then from there he was referred to Armed Forces Institute of Rehabilitation Medicine for complete thorough rehab. He was paraplegic at that time. He was dependent on all activities of daily living. He was incontinent for bowel and bladder. He was unable to transfer, and he was depressed. So we had a multidisciplinary team meeting at AFIRM, and according to that, as per the results of those meetings, the patient and family was educated. We have given him physical therapy, occupational therapy, psychologist review was done, vocational rehab was done for that patient, and bowel bladder management was done. He was trained in transfers, mobility, mobility from wheelchair, and he was also trained in grooming. Bladder was managed with clean intermittent catheterization. He was trained with this. And a time bowel program was also, he was taught with the time bowel program. And he was discharged after complete rehab. But we advise him to follow with us, stay with us, keep on coming to us every 4 to 6 weeks. But somehow he couldn't manage to come to us, and we lost him to follow-up. He then again reported to us like around 6 months later. Although we had trained him in all of these things, but with the passage of time, जो वक्त गुजरता जाता है, जो आपने इनको procedures समझाए होते हैं patients को, that need to be revised. जैसे आप कोई चीज़ पढ़ते हैं, even हाफिज़ कुरान भी जो होते हैं, वो भी अपने कुरान को जो होते हैं revise करते रहते हैं. Revise. The more you revise, the more you remember. So जो इनका follow-up हमने रखा होता है, वो इसलिए रखा होता है कि ये हमारे पास आएँ और हम बार-बार इनको वही चीज़ सिखाते जाएँ, तो एक तो वो चीज़ उनके mind में embed हो जाती है, और सेकेंडली ये होता है कि वो उसको सही तरीके से फॉलो कर सकते हैं. लेकिन चूँकि ये पेशेंट, वी लॉस्ट दिस पेशेंट, सो विद द पैसेज ऑफ टाइम उसने शॉर्टकट्स लिए होंगे. कुछ शॉर्टकट्स जो हमने उसको बताया, आपने किस तरह से ट्रांसफर्स करने हैं, किस तरह से मोबिलिटी करनी है, बेड में किस तरीके से टर्निंग करनी है, उसने उसके शॉर्टकट्स डिस्कवर किए होंगे और वो फॉलो किए होंगे. तो जब वो हमारे पास आया तो ही अगेन दिस पेशेंट ऑल्सो डेवलप द अल्सर्स इन दीज साइट्स. Because we have trained him in clean intermittent catheterization, लेकिन उसके भी उसने कुछ शॉर्टकट डेवलप किए होंगे, प्रोसीजर ठीक नहीं कर रहा होगा क्योंकि हमारे पास फॉलोअप नहीं कर रहा था. तो he also developed penile ulcer for which we consulted the urologist. So he also remained with us for a few weeks, for 8 weeks or so, and he was rehabilitated. Again, the pressure ulcer is a uphill task to treat pressure ulcer. The most difficult thing to treat in the rehab is to treat their, and spinal cord injury patient is to treat their pressure ulcers. सो वो हमने फिर इनके ठीक किए, फिर इनके जो है वो कंप्लीट थेरेपी हुई. आप देख सकते हैं जो इनके हील के बाकी अल्सर सारे जो ग्रेड 4 प्रेशर अल्सर्स थे, दे गॉट रिकवर्ड. ही वाज देन डिस्चार्ज. दिस इज द थर्ड केस. इट्स अ वेरी इंटरेस्टिंग केस. ही वाज अ 25-year-old मेल. हिज फादर वाज चौकीदार एट द लोकल बैंक, and he was the only son, and he had 5 sisters to look after, and his parents had spent all his money to get him educated. He was a bachelor, he has done his BBA, and later on joined the same bank in which his father was a chowkidar over there, the watchman over there. So he was earning, he was doing his job, but one day he went with his friends to a swimming pool and dived in the shallow water and sustained an injury to his spinal cord. He was a spinal cord injury C5 Asia B. So the point to be noted is that our first 2 patients were of a thoracic level of injury, and this patient was even more severe than the previous 2 and he has a cervical level of injury with all completely paralysis of all 4 limbs. So he was a much uphill task to be catered for, but because he followed with us, so the outcome was much better than the previous one. This was his MRI reports, you can see it. So we had a multidisciplinary team meeting, which already Ma'am Nabila has told us that how we do it. So he was dependent on all activities of daily living, feeding, grooming, dressing, toileting. He was totally bedridden, incontinent for bowel and bladder, bedbound completely. So after that multidisciplinary team meeting, we had plan to follow it up. His film score was 48 out of 118. So the rehab plan was formulated. So we have to look after his pressure areas most importantly, क्योंकि pressure area, pressure ulcer once developed जो होते हैं, इनका फिर बहुत ज़्यादा impact होता है on the outcome. Hospital stay हमारा बढ़ जाता है. जब pressure ulcer develop होता है, once it is developed, तो हम पहले pressure ulcers को treat करते हैं, then उसके बाद patient की rehab शुरू होती है. और pressure ulcer अकेले treat होने में जो होता है, वो तकरीबन 8 to 12 weeks ले लेता है. Sometimes इससे भी ज़्यादा time लग जाता है. तो हमारा main emphasis होता है जो patient हमारे साथ initially आ जाता है कि हम उसके bed sores या pressure ulcers ना बनने दें. So for that we use the frequent turning in the bed every 2 hours. We have provided them with tilt table. Daily inspection of the pressure area was done, and the pressure relieving mattresses and the air mattresses were also given to that patient. Our nutritionist, she has put a lot of work into it by providing her the balanced diet which is required to prevent the pressure ulcers from building and prevent her muscle wasting, his muscle wasting. Thromboembolic complications is more important to prevent. For that, pneumatic compression and range of motion exercises were given so that we do not develop any thromboembolic complication which will hinder our rehab. Bladder management was done. He was bladder management हमने इनकी तब की है. Initially जो था वो passive थी, लेकिन later on जब उसकी upper limb की power आना शुरू हो गई, then we have started training him with clean intermittent catheterization, और वो फिर उससे हमने शुरू करवाई as he was able to do it. The pictures were taken with the consent of the patient. So, and bowel management, one of the most important thing is the bowel management. ये हमारे जो होते हैं patient, they are just like आप कह सकते हैं कि infants या बच्चों की तरह होता है. जिस तरह हम अपने बच्चों को pamper करते हैं and we train them in their potty train करते हैं, इसी तरीके से हमने इनको भी train करना होता है ताकि इनकी time bowel program होता है वो हमने develop करना होता है. उस time bowel program में क्या होता है कि हम इनके मुख्तलिफ ये जो हमने स्टेप्स यूज़ किए हैं, मुख्तलिफ स्टेप्स यूज़ करते हैं और इन स्टेप्स के साथ जो है वो उनको इस तरीके से ट्रेन करते हैं कि एवरी मॉर्निंग दे पास द स्टूल वंस अ डे एवरी मॉर्निंग बिटवीन 6 to 9 AM. यानी at AFIRM we had around 18 to 20 patients at one time, and all of our patients, they usually pass their stool between 6 AM to 9 AM despite all of them being incontinent for bowel. बॉल इनका इनकॉन्टिनेंट होता है, लेकिन हमने उसका प्रोग्राम इस तरीके से किया होता है कि रोज़ाना सुबह दे वंस गो टू टॉयलेट एंड दे एवैक्यूएट कम्प्लीटली. उसके लिए हम क्या करते हैं, 3 to 1 रिजीम होता है, वो हम फॉलो करते हैं. उसमें हम 3 times a day स्टूल सॉफ्टनर देते हैं. रात में 10 बजे के करीब हम उनको जो है वो सेनाकॉट की 2 टैबलेट्स देते हैं. वो फिर गट मोटिलिटी डेवलप करते हैं. इट टेक्स 8 hours अराउंड के उसकी जो है वो गट मोटिलिटी आती है. तो 10 बजे हम देते हैं तो सुबह 6 बजे के करीब उनकी गट मोटिलिटी आना शुरू हो जाती है. जब गट मोटिलिटी आती है तो हम उस वक्त उनको एक सपोजिटरी लगा देते हैं. सपोजिटरी देते हैं. सपोजिटरी देने के विदिन हाफ एन आवर वी सेंड देम टू वॉशरूम. उनका असिस्टेंट उनको वॉशरूम में लेके जाता है या हमारा स्टाफ वॉशरूम में लेके जाता है, एंड देयर दे डू द डिजिटल स्टिमुलेशन. वो डिजिटल रेक्टल स्टिमुलेशन करते हैं और उस डिजिटल रेक्टल स्टिमुलेशन के साथ जो होता है फिर उनका स्टूल पेरिस्टाल्टिक वेव के साथ आके इवैक्यूएट हो जाता है. स्टिल दे आर बाउल इनकॉन्टिनेंट बट दे आर टाइम्ड. सो ज़्यादा हो गया, इसमें मेरा ज़्यादा टाइम लग गया. फिजिकल थेरेपी फिर हम प्रोवाइड करते हैं. वी हैव टू प्रोटेक्ट हिज ऑर्थोस्टैटिक हाइपोटेंशन फॉर विच वी गिव देम टिल्ट टेबल. रेंज ऑफ मोशन एक्सरसाइजेज आर डन, and wherever contracture or spasticity develop, we give them other modalities like ultrasound, etc. We train them in transfer technique. वीडियो है, टाइम नहीं है, वीडियो can't play this video. इनको हम ट्रांसफ़र सिखाते हैं, हाउ टू ट्रांसफ़र फ्रॉम व्हील चेयर टू बेड. गेट ट्रेनिंग कराते हैं इनकी पैरेलल बार में. इसी पेशेंट की हमने गेट ट्रेनिंग कराई. ऑक्यूपेशनल थेरेपी, इनकी अपर लिम की वीकनेस थी तो उसको डेवलप करने के लिए ऑक्यूपेशनल थेरेपी, फाइन मोटर एक्टिविटीज़ में इसको ट्रेन किया ताकि ये फिर अपनी जॉब कंटिन्यू कर सके एज अ बैंकर, चूँकि ये बैंकर था. थोड़े से साइकोलॉजिकल इश्यूज़ थे. यंग मैन था, यंग लड़का था, उसके बहुत सारे सेक्सुअल इश्यूज़ भी थे, तो उसके साइकोलॉजिस्ट से भी रिव्यू करा है, एंड वी ऑल्सो एड्रेस हिज सेक्सुअल इश्यूज़ ऑल्सो. So at the progress after 3 months, he improved from spinal cord injury Asia B to Asia D. His film score improved from 48 to 111 out of 126. He became independent in ADLs, and he became continent in bowel and bladder, and he walked out of our hospital by himself.
Can you please play this video?
तो जब तक वीडियो चलती है मैं आपको ये बताता चलूँ कि this was my main aim to tell you that how much is the physical medicine rehabilitation important for spinal cord injury and other traumatic condition that we encountered in our daily lives. So whenever you people or the surgeons or whoever, spinal surgeon, neurosurgeon, they encounter a spinal cord injury patient, they must consult with the rehab team also and send the patient to some good rehab setup where the patient can be rehabilitated and can be, so that he could be a useful member of the society. This is the video of the same patient, the spinal cord injury C5 Asia A patient. He eventually walked out walking. So this was all what I was, this was all about those cases. Now the newer technologies that are available, I'll just go through the slides because my time is already over. This is the advanced wheelchair pressure mapping system. This is available at the Armed Forces Institute of Rehabilitation Medicine. इसमें हम क्या करते हैं, pressure areas देते हैं. तो जो pressure areas होते हैं उसके हिसाब से जो होता है custom made CAT cam machine से जो है वो हम sitting equipment बनाते हैं इनका wheelchair का, ताकि ऐसे patient को जिनको prolonged sitting करनी पड़ती है तो फिर उनके pressure ulcers वगैरह ना develop हों. ये जो है वो anti-gravity treadmill है. This is also used in these patients. Advanced wheelchair mobility options. This is not that much advanced, this available usually. Battery powered scooters are available. Also video I will not play. Body weight separated treadmill walking we also use in these patients. Implanted electrical stimulation devices, because these patients, most of these patients are young patients, so they have all the right to live a normal life. So for them, implanted electrical stimulation devices are also available. Voice activated computerized control units are specially available. It's not available in Pakistan, but internationally it is available and it can be later on, inshallah, in future. We are planning to bring it to Pakistan also for the higher cervical level of injury who have no power in their upper limbs. Implantable electrical stimulation devices are also used in these patients. This is the power exoskeleton mobility aid. This is initially, it was made for the American Army to use to carry heavy weight and go long distances, but now they have introduced this into medical field and they are using it in their paraplegic and tetraplegic patients for use, to improve their mobility and ambulation. It's very high-end and top-of-the-line equipment that is available so far. Assisted fertilization technique is also available because these patients have all the right to become parents and they like to live a normal life. This is the digital bridging AI. This is the latest of all. It is introduced, I think, last week, 24th or 23rd of May. The first patient who was provided 24th or 23rd of May 2023, as of day before yesterday or something, the first patient who was providing with this digital bridging AI technology, in which they have they have put the chips in the brain and the spinal cord distal to the site of injury, and through the thought process using artificial intelligence, this patient is about to walk, and he can walk. You can find it on the internet also. So the take-home message is the spinal cord disease is no longer an injury not to be treated, it must be treated. And I have already told you that anyone who encounters spinal cord injury, and the doctors and the neurosurgeon, the spinal surgeon, they must refer those patients to a proper rehabilitation setup. Currently we have 2 in Pakistan, one in the Rawalpindi, that is dedicated setup, Armed Forces Institute of Rehabilitation Medicine. The second one, the Madam Nabila Center, that is Central Institute of Physical Medicine Rehabilitation. So I will end with successful rehabilitation is the one where an individual is admitted as a patient and discharged as a taxpayer. Thank you.
Absolutely brilliant. Thrilling and thrilled that Dr. Atif and Professor Nabila could be here. Now, continuing on this talk on physical and occupational rehabilitation, we have some very, very important guests over here who will also be a part, inshallah, of the Shaheed Mohtarma Benazir Bhutto's collaborators. We have members of the Disabled Welfare Association Pakistan who are actually putting into play all of what Dr. Atif and Ma'am Nabila spoke about. And they will be presenting their topic on independent living, the role or the future of independent living for the traumatically disabled and how they are living through their disabilities themselves. So can we have on stage Dr. Zaib Taj and Ms. Fatma Jafri, and they'll be presenting over here because it will be easier for them. A big round of applause. Can we start the timer, please? For 10 minutes.
Good evening to you, and this is Fatma Jafri from Disabled Welfare Association. We are an organization of persons with disabilities with more than 70% executive members are persons with disabilities. It's different from other non-profits, and because its focus is with the person who are having the same experience of disability in their own lives. So it's the same motto of a person with disabilities, for a person with disabilities, and by a person with disabilities. So DWA is an OPD, and it has been functional more than 25 years, since 1998. It got registered in 2003. It got legally registered through 1961 ordinance. So let's begin with my presentation here. And the topic is already mentioned here, and independent living, how independent living is related with trauma survivors. All the disabilities which are caused by a trauma is already mentioned by Ms. Nabila, and thanks to her, she has mentioned all the disabilities, including brain injuries, including spinal cord injuries, and including gene myopathy. All these are mentioned by Ms. Nabila Sumlo and then Sir Atif. How can we relate independent living with trauma survival? This is the main part. Independent living is a philosophy. It was introduced in 1972 by Ed Robert in 1972 when he was only a student, and he got an admission in university with his friends. Later on, this movement globally gained popularity, and all the countries all over the world, they have opened independent living centers. And the idea of the independent living center is that it has 3 stages. Why it is so famous and why it is so popularized? Because of its diversity and dimension, its futuristic approach. It will work in few more decades. It will continue, it will be functional, it will be physically, practically applicable, and it will work globally. It will remain a global trend for more than 3, 4, 5 decades because it has 3 stages. It improves the personal mobility, and it prepares the person to be productive in the society. Then it works on inclusion in the society, and on 3rd level, it works on policy and lawmaking. It makes the country and the society accessible for persons with disabilities. It works on accessibility. And so considering all the 3 stages of IL, we can say that this IL is a futuristic approach, and that's why we have been successful with that. Mr. Javed Rais Yes, Mr. Javed Rais is a pioneer of IL in Karachi, and he has been trained in IL philosophy from Japan, and he has also been the part of the exchange program in America, and he introduced this project in Karachi. We started and established our independent living center in 2016, and it was in a very small setup. Later on, with the diversity of the work, we progressed and we extended our work, and we have been doing Disabled Welfare Association has been doing all the initiatives which has been state level. Whatever the countries are doing for persons with disabilities as an OPD or as a DWA has taken at least a small level, but DWA has taken initiatives in every dynamic dimension, in every diversity or every segment of the society. DWA has taken the initiatives. All the state level initiatives DWA has been taking in small scale. So now coming to that IL, how IL is related with the trauma survivors. Now coming to my topic, why IL and trauma survival are related. IL caters the needs of the person with disabilities who are home confined. Unfortunately, in Pakistan, there is a great number of majority of the person with disabilities who are more home confined. The statistics shows that the families of persons with disabilities are not financially stable. They are leading struggling life. They are financially not very well off. So that's why they have their own challenges there, and this makes persons with disabilities live in home confinement. And we used to conduct baseline, and we identify persons with disabilities, and we make them the part of the IL program. And when they become the part of the IL program, we can imagine, you cannot even imagine their, you cannot even imagine their level of disappointment. They are in sheer disappointment. They have no hopes in life. They feel they're in dead end, and life shows no meaning to them. The same is the situation for this is where trauma survivors and IL center, IL people and trauma survivor relate with each other. Trauma survivor is when he feel that he is in a labyrinth, no way of hope, no sigh of relief, and life seems a dead end. And he seems that death is a better option for me instead of living. Even there are evidences of some suicidal attempt. So the level of despair of trauma survivors and the level of despair of person with disabilities in home confinement of years, of 10 years of home confinement, 7 years of home confinement, and 15 years of home confinement is somewhat similar. So that's why we can easily relate that our work would be equally helpful. IL therapy or IL rehab services are equally helpful for trauma services as it is helpful for home confined person with disabilities. That's the way where we can relate with the trauma survivors. Yes, IL rehab services are holistic. Why they are holistic? Because they focus on individual care. We see personal goal, we see the needs, and we also see what are their abilities and what can they do in their lives. And our multidisciplinary team, we consider doctors, we consider therapists, we consider psychologists, and we have social support system. Then physical rehabilitation, we have our physiotherapy setups. We also recommend them to IMPR, where have a connection with them, and we send our person with disabilities to IMPR for visits. And then lifestyle adaptation. Lifestyle adaptation is very important and very necessary for person with disabilities, because they need some changes in their lifestyle, like for exercise, sleep, nutrition. Life is changed after the trauma. So with the change, they need to cope. And then community integration, they must feel a part of the community. They should be, they should socialize, they should feel that they're important, they're equally important like others. And then education, self-management, they should know that after the trauma, they must know how they can manage their life, how can they cope in their lives. Because self-management is very important thing, because when trauma survivors, then when they face failure frequently in their lives, when they used to do things successfully, now they are unable to do things, this gives them a lot of despair. So self-management here gives them a great help, and they learn to cope with the new challenges of their life. And it's long-term and well-being. Yes, we believe in the long-term well-being of our person with disability. So this is how our IL rehab services are holistic and more fruitful for trauma survivors. Now, coming to that DWIL center, as I've told you that our project has started in 2016, and we have been running this IL center since that time. And this IL center is a home-like place. If you come and visit here, you can see a group of persons with disabilities who are happy in family-like environment. Some are busy in conversation, some are busy in studies, some are busy doing work in computers, some are busy in some entrepreneur activities. A lot of activities are going on at the same time in the center. So you all feel the happy faces, you get the message of hope. So this is very important, and this is the strength of IL center, of this IL center, because whenever a new person, a trauma survivor, or any new person who is home confined and who is in despair, who joins this, who see so many persons with disabilities enjoying their life, leading comfortable life, coping with life, with happiness, with soul satisfaction. So they become comfortable. So they develop the hope that they can also be the part of that like them, and we can also enjoy life, and we can also live like others. So they can feel that, yes, there is some hope for them. So this is the message DWIL Center delivered to all.
Thank you, Ms. Fatma. We're done. We're done. I'm so sorry. But thank you for being here, because it's not easy speaking in front of a crowd. And I know that you're such a good speaker when you're conducting workshops, but sometimes it can be a mouthful. And Ms. Fatma and Dr. Zaib were supposed to carry out this session together, but unfortunately, Dr. Zaib wasn't feeling too well, and she had to head out. Basically, the concept of independent living, it's a whole philosophy in itself, what follows after physical medicine and rehabilitation. I mean, it's all fun and games when we're talking about it from a perspective of somebody who has not been through it themselves, right? All of these people who carried out their talks before Ms. Fatma, right? We are all hale and hearty. So that's a completely different perspective. But somebody who's living through this, and when they've sought treatment from you, from IPMR, from CMH Malir, and then there are actually people who are reintegrated into society, going through that is a completely different ballgame. It's life, and that is very, very, it's brave. It has its ups and downs, and that's what we hope to reintegrate. They don't ask to be treated differently. They don't ask for special treatment. They just want to be treated equally, and that's why it's called independent living. So this is why they're here, and I'm so glad they could make it. Thank you. Now, this part of our session on occupational and functional rehabilitation is over. Now we're going to be moving towards mental health. I'd like to invite Dr. Ali Khan, psychiatrist at the United Nations. organization of internally displaced people to come on stage and deliver his talk on the legacy of trauma and challenge to emotional and behavioral health. Dr. Ali Khan.
Thank you. Good evening, everyone. First of all, मैं रिक्वेस्ट करूंगा आपसे कि मिस ज़ेब के लिए प्लीज़. It's not an easy job to talk about mental health in front of such a renowned surgeons and such a renowned psychologist, because surgeons, they don't give us recognition. Dr. Sabir se mazrat ke sath.
Dr. Shahjahan is also the Dean of Dental at Dow, तो उनसे भी आप मालूम करें.
सबसे. And especially who are specialists in talking, especially the psychologists. So it's not an easy job, but ठीक है, I'll try. And in such a small time, talking about mental health, especially the legacy. Can I get a mic? Legacy, विरसा. हम सारे के सारे इतने लकी नहीं हैं कि हम लेगेसी में, विरसे में सब कुछ अच्छा रिसीव करें. समटाइम्स अच्छा मिलता है, समटाइम्स बुरा मिलता है. बहुत लकी होते हैं जिनको अच्छा मिले. एंड इन दिस एज 2023, we all believe that we are product of our ancestors. But I want to highlight here, not only physically, हमको जो रिसीव हुआ वो फिजिकल के साथ साथ कुछ मेंटल इश्यूज भी रिसीव हुए. नॉट ओनली बैड बट गुड एज वेल. सो आज मैं कोशिश करूंगा इतने छोटे से टाइम में कुछ बात कर सकूं रिगार्डिंग द लेगेसी. Legacy, it could be individual, it could be, community based and all that. कोई भी नहीं चाहता कि वो अपने पास्ट में रहे, but some people, some of like कभी-कभी होता है, रहना पड़ जाता है. ये ठीक है, हमने सबने बात की है, लेकिन मैं थोड़ा सा कोशिश ये करूँगा कि थोड़ा सा हम सोल्यूशन पे जाएं. सोल्यूशन क्या हो सकता है? Let's start from hospitalization. Itself, this word is horrible. Agreed or no? आप hospitalized होंगे 2 दिन बाद, and not only for that patient and the people surrounding him, family, उसकी wife, life partner, माँ बाप, बच्चा है तो उसके माँ बाप, बड़े हैं तो उसके बच्चे. So it's kind of like a package. पूरी फैमिली डिस्टर्ब होती है, पूरी फैमिली एक फियर से, एक एंजाइटी से गुजर रही होती है. तो थोड़ा सा अब जब हॉस्पिटलाइज हुआ है, सो दिस इज द टर्निंग पॉइंट. आई गेस दिस इज माय ओपिनियन. आप लोग हो सकता है डिसएग्री करो. अगर हम इस पीरियड में थोड़ा सा पेशेंट, नॉट ओनली द पेशेंट, बिकॉज व्हेन आई केम हियर Professor Somro was talking about to describe and define about the disease and outcomes. Here I would like to add, it's not only the patient, we supposed to and we should explain about the disease to the patient, not only to the patient, but as well to his family, because they are also concerned कि फ्यूचर में क्या होने वाला है, क्या नहीं होने वाला. अब सपोज सम ऑफ यू वर टॉकिंग अबाउट एम्पुटेशन. ऐसा सिर्फ पेशेंट की पाँव नहीं कट रहा, किसी का हाथ भी कट रहा है, किसी का दिल भी कट रहा है. पेशेंट का पाँव कट गया, उसकी इनकम को लेके फ्यूचर में उसके घर वालों का हाथ भी कट गया है, जो उसका पार्टनर है उसका दिल भी कट गया है. सो इट्स नॉट एन ईजी कि आपके जिस्म का I'm gonna cut it off and throw it off. Please consider this. So pre-op and post-op period. Post-op में most ऐसा नहीं है कि हम बोलते हैं कि पाकिस्तानी पेशेंट. Believe me, पूरी दुनिया में सारे पेशेंट्स एक जैसे हैं. US में, इंग्लैंड में, इटली में, चाइना में, एक जगह जो मेरे एक्सपोजर है, जो मैंने बोला है, सारे पेशेंट्स वो ये चाहते हैं कि हम सर्जरी ओटी से निकलें और पेन रिलीफ हो, पेन ख़त्म हो जाना चाहिए। तो एक काउंसलिंग यहाँ भी ज़रूरी है। सो मुझसे ज़्यादा मेरा टाइम तेज़ भाग रहा है। काउंसलिंग प्री ऑप, ये एक ऐसा पीरियड होगा जहाँ पे हम पेशेंट की और पेशेंट के केयर गिवर्स की जो फैमिली है वो उसके एंजाइटी को और उसके फियर्स को दूर कर सकते हैं, उसको बता सकते हैं कि बहुत ज़्यादा होप्स अगर नहीं भी दिलाना सकते तो कम से कम उसको तसल्ली ज़रूर दे सकते हैं। ज़रूरी नहीं है कि उसको हम उस हालत में छोड़ें कि वो ज़िंदगी सहता रहे, गुजारता रहे। हमें पेशेंट को ऐसा करना है कि वो ज़िंदगी जिए। प्लीज़, ये मैं थोड़ा सा बोल्ड करना चाह रहा हूँ कि ज़िंदगी जिए, पेशेंट भी ज़िंदगी जीने का पूरा हक रखता है। ये थोड़े स्टैट्स हैं, आप लोग पहले ही बोर हो रहे हैं मेरी शक्ल देख के। अगर हम प्री ऑप और पोस्ट ऑप कुछ काउंसलिंग्स वगैरह करें तो ये रिजल्ट्स हैं। मेरा ख्याल है नेक्स्ट स्लाइड पे जाते हैं। एक चीज़, मैं यहाँ ये नहीं आया हूँ, मैं यहाँ ये कहने नहीं आया कि मैं ये एक्सपेक्ट करूँ कि कोई सर्जन या कोई और पोस्ट ऑप में या प्री ऑप में, हमारे यहाँ तो खैर कंसेंट भी हम अपने पैरामेडिक्स को कहते हैं या आरएमओ को कहते हैं कि वो कंसेंट ले ले। चलो इसी पे करते हैं। So what I want to say is I want to emphasize on teamwork. यहाँ मैं कुछ ऐसी बातें करूँगा कि शायद आप लोगों के लिए नहीं हो, बट मेरा एक्सपोजर थोड़ा सा बाहर का है, सो मैं उससे फ़ायदा उठाना चाहता हूँ कि ना सिर्फ ये कि सर्जन अकेला पेशेंट को पोस्ट ऑप काउंसलिंग करे, इट्स नॉट हिज और हर जॉब। हमें एक टीम चाहिए और उस टीम में, ये भी एक बोरिंग सी स्लाइड है, और उस टीम में मुझे 2 लोग चाहिए पाकिस्तान में इन एवरी टर्शरी केयर हॉस्पिटल। यहाँ थोड़ा सा रोक रहा हूँ। एक साइकोलॉजिस्ट, सर्जरी के लिए आया हुआ है कोई पेशेंट सर्जरी करवाने, उसकी जो मैनेजमेंट है, मैनेजमेंट की जो टीम है, उसमें मैं ये चाहता हूँ एज अ मेंबर ऑफ यूनाइटेड नेशन, हम ये एक्सपेक्ट करते हैं कि उसमें एक साइकोलॉजिस्ट हो और एक रिलीजियस स्कॉलर भी हो सकता है कि ये बात मेरी समझ ना आई हो आप लोगों को। लेट मी एक्सप्लेन समथिंग। मेरा बिलीव ये है कि पेशेंट, बहुत सारे पेशेंट्स ऐसे भी होते हैं स्पेशली इन पाकिस्तान कि जो रिलीजियस बिलीव्स जिनके बहुत स्ट्रांग होते हैं, तो हम रिलीजियस स्कॉलर का भी सहारा ले सकते हैं, इसमें कोई हर्ज नहीं है। साइकोलॉजिस्ट का भी हमको ऑन बोर्ड लेना पड़ेगा। ऑल्दो कि मैं चूँकि साइकियाट्रिस्ट हूँ तो मेरा बिलीव ज़्यादातर केमिकल्स पे होता है, न्यूरोट्रांसमीटर्स पे होता है, हम उस पर एम्फेसाइज करते हैं। लेकिन आज इस मौके से फ़ायदा उठाते हुए मैं ज़रूर कहूँगा कि साइकोलॉजिस्ट, देयर शुड बी वन साइकोलॉजिस्ट इन a management team of any patient who is coming for surgery. ये deliberately डाली है, खुद नहीं डल गई है, it's not a mistake. एक वॉल रिपेयर हो रही है, एक आदमी का काम नहीं है। हमें पेशेंट को मैनेज करना है, पेशेंट को वापस लाना है, तो सिर्फ सर्जन will not be good enough. एक साइकोलॉजिस्ट, एक रिलीजियस स्कॉलर और उसके फैमिली मेम्बर्स, वो ज़रूरी हैं कि उनको ऑन बोर्ड लिया जाए ताकि पेशेंट सर्जरी के बाद एक अच्छी लाइफ जी सके, ज़िंदगी गुजारे नहीं, ज़िंदगी जिए। अभी तक मैंने तो कोई ऑब्जर्व नहीं किया कि किसी ने कोई सवाल किया हो, लेकिन प्लीज़ यू आर मोस्ट वेलकम इफ़ यू गाइज हैव एनी क्वेश्चन।
Yes, you have a question at the back.
यस मैम। ज़रा आसान सा सवाल कीजिएगा प्लीज़।
अस्सलाम वालेकुम, माय नेम इज़ अलीज़ा माइकल, आई एम अ स्टूडेंट ऑफ बीएसएन। सर मेरा आपसे ये सवाल नहीं है, एक क्वेश्चन है कि हम इतना क्यों लैक कर रहे हैं कि हमारे पास डाइटिशियन नहीं है। मतलब एजुकेशन वाइज वी आर वेरी गुड, वी हैव यूनिवर्सिटीज़, बट क्यों हमारी ग्रुप्स नहीं है हमारे पास? क्यों नर्सेज हैं तो वो डॉक्टर के साथ कम्युनिकेशन नहीं कर पा रही, डॉक्टर्स हैं तो वो आगे कम्युनिकेट नहीं कर पा रहे। देयर इज़ अ लैक ऑफ कम्युनिकेशन इन एवरी सेटअप। लाइक अगर हम हेल्थ केयर से बात करें तो मिडवाइफ्स हैं, वो नर्सेज से बात करना पसंद नहीं करी। अजीब एक लैक ऑफ कम्युनिकेशन चल रहा है और इस बीच में कुछ नहीं हो रहा, बस पेशेंट जो है वो अपनी हेल्थ लूज कर रहा है। वी आर गेटिंग पेड वेरी वेल, एवरीवन इज गेटिंग पेड वेरी वेल, बट द अटेंशन एंड द केयर द पेशेंट शुड गेट वो नहीं मिल रही। बाकी सब सही चल रहा है।
थैंक यू सो मच मैम। आपने मुझे कंफ्यूज भी कर दिया। आपने कहा सवाल नहीं है, क्वेश्चन है। मेरा ख्याल था कि सवाल और क्वेश्चन एक ही होता है।
नहीं, मेरा मतलब कोई एकेडमिक सवाल नहीं था ये।
आई मस्ट अप्रिशिएट यू। देखें, आपने थोड़ा बहुत जवाब दिया है, ऐसा नहीं है। मेरा फर्म बिलीव है इस बारे में, मेरा एक्सपोजर भी है, एक्सपीरियंस्ड भी है कि हम पाकिस्तानी, हम किसी से कम नहीं हैं, स्पेशली इन मेडिकल प्रोफेशन। आप अमेरिका चले जाओ, यूके चले जाओ, बंच है, बंडल्स हैं वहाँ पे। पॉइंट कम्युनिकेशन का है, पॉइंट कंपटीशन का है। इट्स नॉट ओनली अबाउट कम्युनिकेशन, थोड़ा सा कंपटीशन है सर्जन्स में, फिजिशियंस में, डॉक्टर्स में, नॉन डॉक्टर्स में। थोड़ा सा हेल्दी कंपटीशन नहीं है। साइकियाट्रिस्ट, साइकोलॉजिस्ट को रिकग्निशन नहीं देने के लिए तैयार, इसी तरह साइकोलॉजिस्ट हमें नहीं मानते। तो टीम वर्क, टीम वर्क, टीम वर्क। आप अकेले जो कर सकते हो ठीक है कर लोगे, बट यू विल गोना टेक टाइम, और इतना अच्छा शायद परफॉर्म नहीं कर पाओगे। अगर आपको टीम मिली हुई हो जिसमें सब आप ही की तरह ज़हीन हो, डेडिकेटेड हो और काम करना चाहते हो, ठीक है। कुछ भी ऐसा नहीं है हमारे प्रोफेशन में लेके जो पॉसिबल ना हो। अगर मैं अपने पेशेंट को पूरा टाइम दूं और मेरी टीम भी उसी तरह डेडिकेटेड हो के प्रोफेशनलिज्म के साथ उसको अप्रोच करे, तो रिजल्ट्स बहुत अच्छे होंगे इंशाल्लाह।
Thank you. I hope that answers your question. Because we're running really short on time, I would quickly like to invite on stage Ms. Bushra.
I have a comment to make.
बिल्कुल बिल्कुल जी, Dr. Shahjahan.
Assalamualaikum. Can you all hear me?
बिल्कुल, we can.
My name is Professor Shahjahan Katwa. I'm the co-chair for the scientific session. Khan Saab, for your information, perhaps this is the first time in Pakistan that a totally different scientific session concept has been introduced. That's why you are here, sir. Usually we do not see behavioral therapists, psychiatrists, psychologists, nutritionists, and the nursing people at any major medical or dental scientific forum. So that also answers your question. That's exactly what the future, is the direction is. That's how things should be incorporated. आपका ये ख्याल कि क्यों नहीं होते, आज आपको मौका दिया गया है. You are here, you are sharing what you want to say, and that's how things will proceed. So we are totally shifting. There's a paradigm shift in how things should be. So we have promoted compartmentalization. जिस तरह से हम ये जब scientific sessions conceive कर रहे थे, we wanted to promote rehabilitation and function, which includes and wellness at the same time. Emotional, mental, spiritual, everything is interconnected. Future में बहुत मुमकिन है कि इस तरह की और conferences हों, आपको, आप जैसे और colleagues को involved किया जाएगा so that we can bridge the gaps. The basic objective, if you look at the traumatology logo, it all revolves around the patient. We are aiming towards the patient care. So future lies in doing the same thing in the same circular way. Thank you.
Thank you. Thank you so much, Dr. Shahjahan. I think that was a very important point to make.
Thank you so much, sirs. Thank you so much. I really appreciate it. Thank you so
Now, I'll quickly invite on stage Ms. Bushra Munawwar. She is a trauma psychologist at the United Nations. Her topic is on emotional stuckness, understanding trauma and its impact on mental health. Ms. Bushra, I would just request you to kindly, just make it quick if you can. Thank you.
Hello, Assalamu alaikum. Very good evening to all of you. And like Zara said, I'll be very brief because this is the end of the session. So most of the चीज़ें काफ़ी हद तक clear out हो चुकी होंगी. If I'll start with that, मैं बहुत कोई hard and core definition की तरफ नहीं जाऊँगी trauma की. Basically, any event, any circumstances जो एक person के लिए इतने harsh enough थे कि उसकी memory में imprint हो गए. और वो इम्प्रिंटिंग या वो मेमोरी अगर उसकी मेंटल एंड इमोशनल वेलबींग को चैलेंज किए चली जा रही है और उसकी डेली लाइफ फंक्शनिंग में हिंड्रेंस क्रिएट कर रही है तो उसको हम ट्रॉमा डिफाइन करेंगे या ट्रॉमा की कैटेगरी में इंट्रोड्यूस करेंगे. अगर चैलेंजेस की बात हो तो ट्रॉमा की बहुत सारी वेरिएशंस हैं, टाइप्स हैं, रीजंस हैं. लेकिन अगर हम स्पेसिफिकली बात करें पेन से रिलेटेड, फिजिकल पेन, तो वो भी इटसेल्फ बहुत बड़ा चैलेंज होता है या ट्रॉमा होता है. जैसे यहाँ पे स्पाइनल कॉर्ड इंजरीज़ को डिस्कस किया गया, कोई भी ट्रॉमेटिक इंजरी जो है वो इटसेल्फ बहुत बड़ी चैलेंज हो सकती है. अच्छा, होता क्या है कि हमारी बॉडी जो है वो स्कोर रखती है. उसके लिए फिज़िकल पेन जितना चैलेंजिंग है उतना ही मेंटली भी उसको वो चैलेंज करेगा, उतना ही उसकी इमोशंस भी चैलेंज होंगे. ऐसा नहीं है कि फ़िज़िकल पेन जो है वो डिफरेंट होगी या उसका जो माइंड है वो डिफरेंटली वर्क करेगा. तो बॉडी जो है वो इक्वली स्कोर देती है सबको, आपकी इमोशनैलिटी को भी, आपकी मेंटल वेलबींग को भी. और बहुत सारी स्टडीज़ ने इस चीज़ को प्रूव किया है कि हाईली कोरिलेट करती है इसके साथ. अगर हम बात करें कि किन किन एरियाज़ ऑफ लाइफ को चैलेंज करता है एक फ़िज़िकल इंजरी या इमोशनल पेन या मेंटल पेन, तो डेवलपमेंटल सबसे पहले आपकी ग्रोथ हिंडर होगी. अब ये करियर वाइज ग्रोथ हो या इमोशनल ग्रोथ हो, सभी इफ़ेक्ट होंगे इससे. फिर सेकेंडली डेफिनेटली फ़िज़िकल ग्रोथ इफ़ेक्ट होगी. रिलेशनशिप्स, जैसे यहाँ पे डिस्कस हुआ था कि डिवोर्सेस के रेशो बहुत ज़्यादा हाई अप हो जाते हैं, फैमिली बॉन्डिंग बहुत वीक हो जाती है. वही पर्सन जो आपका इतना लव्ड वन था, अब वो आपके ऊपर बर्डनाइज, आप उसको बर्डनाइज फील करने लगते हो, तो रिलेशनशिप्स बर्डनाइज हो जाते हैं. देन ऑक्यूपेशनल, इकोनॉमिकल स्ट्रगल्स हमारी कंट्री में ऑलरेडी बहुत ज़्यादा है. फिर एक ऐसा पर्सन जो क्रॉनिक इलनेस के साथ आ रहा है, उसके ऊपर ऑक्यूपेशनल बर्डन इटसेल्फ ऐड ऑन हो जाएगा. फिर मेडिकल एक्सपेंसेस, ये एक और मज़ीद ऐड ऑन चीज़ है. एंड देन स्पिरिचुअल, पर्सन अपनी बिलीफ सिस्टम को बहुत ज़्यादा चैलेंज करने लगता है, बहुत क्वेश्चन करने लगता है. अपना जो उसका फेथ सिस्टम है उसको कहीं दफ़ा बहुत ज़्यादा क्वेश्चन करने लगता है. जब ये सारे एरियाज़ इफ़ेक्ट होंगे तो डेफिनेटली जो ट्रॉमा है वो कैसे, कौन से सिम्टम्स शो करेगा. डेफिनेटली वो एंशियसनेस बहुत ज़्यादा शो करेगा, फियर बहुत होगा, PTSD बहुत ज़्यादा डेवलप होने के चांसेस हैं, सब्सटेंस यूज़ या अब्यूज़ बहुत ज़्यादा हो जाएगा, सोशल आइसोलेशन बहुत ज़्यादा हो जाएगा, ब्रोकन रिलेशनशिप्स होंगी, ब्रोकन फैमिलीज़ सामने आएंगी, ये सारी चीज़ें होंगी. यहाँ मैं थोड़ा सा फोकस करूंगी कि जब भी हम बायोलॉजिकल अप्रोच की बात करते हैं, मेडिकल अप्रोच की बात करते हैं, तो हम इक्लेक्टिक अप्रोच को लेके चलते हैं. अब यहाँ पे जैसे अभी क्वेश्चन भी अराइज हुआ था और डॉक्टर शाहजहां ने भी कहा, तो हमारी प्रायोरिटी का यहाँ पे जो गैप आ रहा है, बेसिकली कम्युनिकेशन के साथ साथ प्रायोरिटी का गैप आ रहा है. हम मेडिकल फैसिलिटीज़ प्रोवाइड बहुत ज़्यादा करते हैं प्रायोरिटी बेसिस पे, बायोलॉजिकल मॉडल पे बहुत ज़्यादा काम करते हैं, और सोशल सपोर्ट भी बहुत ज़्यादा प्रोवाइड की जा रही होती है फैमिली की तरफ से, रिलेटिव्स की तरफ से, कॉलीग्स की तरफ से, फ्रेंड्स की तरफ से. लेकिन इस एरिया को कहीं ना कहीं इग्नोर किया जा रहा होता है, या इसको प्रायोरिटी पे नहीं रखा जा रहा होता, या इसको सेकेंडरी कंसिडर ज़्यादा किया जाता है। तो अगर हमने एक इफ़ेक्टिव मैनेजमेंट ट्रीटमेंट प्लान्स करने हैं तो ये एरिया सबको पता है, लेकिन थोड़ा सा निगलेक्टेड है, या इसकी अप्रोच सेकेंडरी लेवल पे चली जाती है। तो मेरा एम्फेसिस यहाँ पे आने का मकसद यही था कि इसको प्राइमरी कंसिडर किया जाए, बेसिक कंसिडर किया जाए, ठीक है। क्योंकि अगर इसको है तो नेचर ने बॉडी के अंदर हीलिंग कैपेसिटी रखी है। जो हम इन तीनों की इंटीग्रेशन के साथ चलेंगे तो इफ़ेक्टिवनेस ज़्यादा इन्हांस होगी। और इफ़ेक्टिव मैनेजमेंट के लिए मैंने अपनी प्रैक्टिस में या अपनी जितना भी एक्सपीरियंस उसमें ये देखा है कि अगर हम साइकोलॉजिकल असेसमेंट को एट द टाइम ऑफ एडमिशन, जहाँ पे हम कॉन्सेंट लेना स्टार्ट करते हैं, हिस्ट्री टेकिंग करते हैं, अगर वहीं से हम साइकोलॉजिकल असेसमेंट की इम्प्लीमेंटेशन स्टार्ट कर दें तो चीज़ें बहुत ज़्यादा बहुत बेहतर हो सकती हैं और एक बहुत इफ़ेक्टिव अप्रोच हमारे पास आ सकती है। सेकेंडली, एजुकेशन, पेशेंट को डे 1 से एजुकेट किया जाए अबाउट द नेचर ऑफ द इलनेस। जैसे डॉक्टर अली खान ने भी कहा कि सिर्फ पेशेंट को नहीं, उसकी फैमिली मेम्बर्स को भी एजुकेट करें, और इवन उसको ये भी बताएं कि एट द टाइम ऑफ रिकवरी भी उसको पेन की साइकिल से गो थ्रू करना पड़ेगा। इट्स नॉट लाइक कि हमारे मोस्टली पेशेंट्स ये एक्सपेक्ट करते हैं कि बिफोर द प्रोसीजर मेडिकल एड मिलने से पहले तो पेन समझ आता है, आफ्टर दैट क्यों हो रहा है पेन, वो क्यों नहीं मैनेज हो रहा। तो ये भी उनको कहीं ना कहीं बताने की ज़रूरत होती है कि हीलिंग के प्रोसेस में भी पेन उतना ही इंटेंसिटी होगी और उसी साइकिल से गुजरना पड़ेगा उनको। तो ये एजुकेशन अगर दे दी जाए तो एक्सपेक्टेशन का लेवल जो है थोड़ा रियलिस्टिक हो जाता है। देन कोपिंग स्किल्स ट्रेनिंग, ये क्योंकि ट्रॉमा की इंटेंसिटी वेरी करती है पर्सन टू पर्सन, इसलिए उसकी जो कोपिंग स्किल्स हैं वो भी इंडिविजुअल फैक्टर्स पे फोकस किया जाए। पर्सन की देखा जाए कि उसकी स्ट्रेंथ क्या है, उसकी पर्सनैलिटी की ट्रेड्स क्या हैं, ठीक है। फॉर एग्जांपल, अगर एक पर्सन का फेथ सिस्टम बहुत ज़्यादा स्ट्रॉन्ग है तो उसके फेथ को ही हाईलाइट करके उसके अंदर कोपिंग स्किल्स बिल्टअप की जाए, ठीक है। तो रेजिलियंस, ऑप्टिमिज्म, होप बिल्टअप करनी है तो उसकी इंडिविजुअल कोपिंग स्ट्रैटेजीज पे फोकस करें तो ज़्यादा अच्छे रिजल्ट्स आएंगे। अच्छा, ज़्यादातर जो हमने अपनी प्रैक्टिस में देखा है, अगर ग्रुप काउंसलिंग्स करवाई जाएँ पेशेंट्स की तो वो ज़्यादा अच्छी, इंडिविजुअल सेशंस तो होते हैं लेकिन ग्रुप काउंसलिंग ज़्यादा इफेक्टिव होती हैं, उसमें मोटिवेशन का लेवल ज़्यादा हाई होता है। सेम माइंडेड लोग जब अपनी पेन को शेयर करेंगे, अपनी एक्सपीरियंसेस को शेयर करेंगे तो ज़्यादा अच्छे रिजल्ट्स आएंगे। इसी तरह सपोर्ट ग्रुप्स हो सकते हैं। हमारे यहाँ थोड़ी सी इसकी कम प्रैक्टिस है। मोस्टली मैंने जो सपोर्ट ग्रुप्स देखे हैं वो सोशल मीडिया पे देखे हैं। लोगों के जो हैं वो सेम एक्सपीरियंसेस अपनी डिस्कस करते हैं, लेकिन कम्युनिटी बेसिस पे भी अगर स्पोर्ट्स ग्रुप बनना शुरू हो जाएं तो बहुत इफ़ेक्टिव रिजल्ट्स आ सकते हैं। देन ग्रुप एक्टिविटीज़ को ज़्यादा हाईलाइट किया जाए तो ज़्यादा पॉजिटिव रिजल्ट्स आ सकते हैं। थैंक यू सो मच। आई लीव दिस माय प्रेजेंटेशन विद दिस नोट कि trauma is a fact of life. It does not, however, have to be a life sentence. Thank you.
Any questions? No? Okay, so final panel, you have a question, please. Then we'll be moving towards the final remarks by the panel, and Ms. Sarah Hussam will be carrying on the end of the session moderation.
Bismillah Rahman Rahim. Assalamu alaikum. My name is Hussain Ali and I'm VP at Disable Welfare Association. I'm feeling very nervous in between of all doctors because my background is from engineering and but today मैंने बहुत सीखा आप लोगों से। आज मेरा एक थोड़ा सा सिली सा या इनोसेंट सा क्वेश्चन है मे बी, बट मैं ये जानना चाहता हूँ कि व्हाट इज़ द डिफरेंस बिटवीन नर्सेज एंड पर्सनल केयर अटेंडेंट्स?
नर्सेज एंड पर्सनल केयर अटेंडेंट, कोई है मेडिकल की फील्ड से रिलेटेड ज़्यादा अच्छा आंसर कर सकते?
इसको मैं आपको आंसर करती हूँ। देखिए, नर्सेज और पर्सनल केयर अटेंडेंट में बिल्कुल डिफरेंस है। नर्सेज जो है ये क्वालिफाइड होती हैं, जिस तरह यहाँ आपने साइकेट्रिस्ट देखा है, रिहैब देखा, न्यूट्रिशनिस्ट देखा, तो नर्सिंग जो है ये 4 ईयर डिग्री प्रोग्राम है, आफ्टर एफएससी होता है और इसमें तमाम कोर्स कवर करते हैं। उसके बाद आफ्टर बीएसएन ये नर्स स्पेशलिस्ट की तरफ जा रहे हैं, जिस तरह के एमएस नर्सिंग है, और अब हम जो फील्ड को वो करा रहे हैं कि फील्ड स्पेशलिस्ट होगा, न्यूट्रिशनिस्ट होगा, यानी उसकी उसमें स्पेशलिटी होगी, या 1 ईयर डिप्लोमा प्रोग्राम करेगा मास्टर्स, या जिस तरह गैप आ रहा है नर्सिंग केयर में और नर्सिस को पैरामेडिकल समझा जाता है, ये एक प्रोफेशन है। अटेंडेंट जो है ये छोटे कोर्सेज होते हैं, जैसे एड नर्स है आपका, टेक्नीशियन है आपका, ये 1 ईयर डिप्लोमा प्रोग्राम्स होते हैं जो उसके अंडर में काम करते हैं। तो नर्सेज जो है वो तो एक वास्ट रोल है, उनकी स्पेशलिटी डिस्क्राइब हो चुकी हैं, पीएचडी लेवल तक जा रहे हैं। तो यहाँ पर उनका रोल अलग है, इंडोर भी है आउटडोर भी है। अब जिस तरह हम बात कर रहे हैं कि डिस्ट्रिक्ट लेवल पे डिस्ट्रिक्ट नर्सिंग ऑफिसर हो, पब्लिक हेल्थ नर्स हो, प्राइमरी हेल्थ केयर नर्स हो, बहुत सारे गैप हैं अभी हमारे जो स्टैंडर्ड्स हैं उसमें। हमारे पास मेडिकल मॉडल जो है वो यूज़ हो रहा है, हेल्थ केयर मॉडल यूज़ नहीं कर रहे। जिस तरह अभी जो साइकेट्रिस्ट थे और जो साइकोलॉजिस्ट हैं वो सारे यही बात करते हैं, जिस तरह फार्मासिस्ट ने बात किया कि जिसका जो काम है बेसिकली वो इंट्रोड्यूस नहीं हो रहा फील्ड में, जिसकी वजह से गैप आ रहा है। तो अगर हम एक हेल्थ केयर मॉडल करेंगे तो वो डिस्क्राइब होगा हर एक का रोल, इस तरह नर्सिस ने क्या करना है। तो जो नर्स स्पेशलिस्ट है, जैसे ट्रॉमा केयर नर्स है, तो वो क्या करेगी, इनिशियल असिसमेंट अगर आप अराउंड द वर्ल्ड देखें तो वहाँ पेशेंट रिसीव नर्सिस करती हैं। बाकायदा जो इनिशियल असिसमेंट होता है, एबीसी मेंटेन करना होती है, मैनेजमेंट करनी होती है, उसके बाद किस डॉक्टर को केस रेफ़र करना होता है वो सारा नर्सिस करती हैं। हमारे पास शॉर्टेज ऑफ नर्सिस बहुत ज़्यादा है, डॉक्टर्स हमारे पास ज़्यादा तादाद में हैं, उनकी पोस्टें गवर्नमेंट ने क्रिएट की हैं, लेकिन ऑल दो डॉक्टर्स भी शॉर्टेज है। जो स्टैंडर्ड होना चाहिए WHO के हिसाब से पॉपुलेशन रेशो पे, वो रेशो अभी तक डॉक्टर्स का भी मेंटेन नहीं है, और नर्सिस तो बिल्कुल मेंटेन नहीं है। 1 डॉक्टर 4 नर्सिस होनी चाहिए, हमारे पास इस टाइम 5 डॉक्टर 1 नर्स है। तो हम स्टैंडर्ड मीट नहीं कर रहे, जो काम एक्चुअल में नर्सिस का है वो नर्सिस परफॉर्म नहीं कर रही, क्योंकि उनको अपॉइंट नहीं किया गया, पोस्टें क्रिएट नहीं की गई। जो अटेंडेंट हैं उनसे काम लिया जा रहा है, तो हम सिर्फ काम कर रहे हैं, क्वालिटी ऑफ वर्क पे अभी तक नहीं आ रहे। जब तक हम स्टैंडर्ड मीट नहीं करेंगे, हेल्थ केयर मॉडल जो है इंट्रोड्यूस नहीं करेंगे, इम्प्लीमेंट नहीं करेंगे, उस टाइम तक चेंज नहीं आ सकता। तो ये एक बहुत बड़ा गैप है, लेकिन अटेंडेंट और नर्स में बहुत फ़र्क है। नर्स जो है हॉलिस्टिक केयर देगी आपको, जिसमें साइकोलॉजिस्ट भी है, वो न्यूट्रिशनिस्ट भी है, उसके सारे रोल आ रहे हैं, लेकिन शॉर्टेज की वजह से वो इम्प्लीमेंटेशन में नहीं है।
थैंक यू मैम।
Thank you. All right, and now thank you for being here, for being a part of this session. The session officially comes to an end, and so does Traumacon 2023. This was the last session of the day and the last session of this conference. It has been an absolute pleasure. Does anybody have any other questions, sir? Any remarks that you'd like to make? No?
डॉक्टर नबीला,
Madam,
डॉक्टर नबीला, आपने हमें एक रिक्वेस्ट की है कि नेक्स्ट टाइम आपका सेशन जो है वो सर्जन के साथ होगा, सो वी विल अरेंज फॉर दैट।
यस यस
इंशाल्लाह। एंड डॉक्टर आरिफ, आपकी जो टॉक थी इतनी इनलाइटनिंग थी, आपके एक्सपीरियंसेस, हमारा जो है विजन क्लियर हुआ, हमारा आई ओपनर था कि व्हाट वी कैन डू फॉर देम। ज़ेब, यू आर के इंस्पिरेशन फॉर अस, and all the other speakers, there are 3 sessions merged together, all have got their own importance, और हमारा समझे ये मेडिकल केयर से इंटररिलेटेड है, इंटीग्रेटेड है। सो विद दिस वी एंड दिस सेशन, एंड देर हो गई है, चाय ले लेते हैं।
Yes, thank you, Dr. Afsha Bano, for your remarks. And now I would like to invite on stage my co-chair and chairperson, Ms. Khairunisa and Dr. Afsha Bano, so that they can present their awards to the speakers, please. Ma'am.
हेलो, यहाँ पर जो हम बात कर रहे थे मल्टी डिसिप्लिनरी की, तो ट्रॉमा सेंटर को कॉन्ग्रेचुलेट किया, उन्होंने सबको इकट्ठा कर दिया है अल्हम्दुलिल्लाह। तो ये बहुत बड़ी बिग अचीवमेंट है। इनिशियल स्टेज हमारी स्टार्ट हो गई है और इंशाल्लाह हम बहुत आगे जाएंगे, और इसी तरह की कॉन्फ्रेंसेस होंगी। तो इनिशियल स्टेज तो स्टार्ट है अल्हम्दुलिल्लाह। थैंक यू।
Thank you. Our first award, I would like to invite Ms. Sana Amir Ali on stage to receive her award from Ms. Dr. Afsha Bano and Ms. Khairunisa, please. Principles of Managing Trauma Patients, Significant Role of Nurses, Ms. Sana Amir Ali, Head of Department Nursing, SMBBIT. Big round of applause. Now I'd like to invite on stage Ms. Nidha Azhar from Ziauddin University, Nutritional Assessment and Diagnosis of Trauma Patients. Ms. Nidha, thank you so much for coming and for putting our audience. She really put our audience to test. Thank you. Now, I would like to invite on stage Sub-Lieutenant Aisha Nasir Saiba. Aisha Nasir Saiba, please. We've also worked before at PNS Shifa, so it was a pleasure seeing you. Nutritional interventions and monitoring and evaluation of trauma patients, Ms. Aisha Nasir. A big round of applause. Then, of course, Professor Dr. Nabila Somro, thank you so much for coming. Director, IPMR, Sindh Institute of Physical Medicine Rehabilitation. Dr. Somro, thank you so much for taking out the time. And on post-traumatic patients. Big round of applause. Then, wonderful talk. Dr. Atif Ahmed Khan, 3 amazing cases. The last one when he was walking really took my breath away. Head of Physical Medicine and Rehabilitation at Combined Military Hospital, Malir. The critical role of PM&R in spinal cord injury. Severely injured patient and he went home walking. What a case. Dr. Atif. And finally, last but not the least, from the Physical and Occupational Rehabilitation session, section, we have Dr. Zeeb Taj and Ms. Fatma Jafri from the Disabled Welfare Association, Pakistan. Their award for the topic, The Future of Independent Living for the Traumatically Disabled. Ma'ams, can you please नीचे आकर अगर आप award दे दीजिए? Thank you so much, Ms. Fatma. Big round of applause for Ms. Fatma. Very brave. And now we have Dr. Ali Khan, psychiatrist at the United Nations. His topic, The Legacy of Trauma, a Challenge to Emotional and Behavioral Health. Dr. Ali Khan, if you could come and receive your award. Thank you, Dr. Ali. And then we have Ms. Bushra Musawwir, trauma psychologist at the United Nations, Emotional Stuckness, Understanding Trauma and its Impact on Mental Health. Ms. Bushra, thank you so much for coming and being part of our conference. Ms. Bushra, everybody. And now I'd like to invite on stage Chairperson, Scientific Committee of the Pak Traumacon, Professor Dr. Shahid Noor, to present the award to our chair and co-chair, Dr. Shahid Noor. To both the ladies, yes, Dr. Afsha Bano and Ms. Khairun Nisa. Ms. Khairun Nisa and Dr. Afsha Bano, our chairperson for the session. Thank you so much, ladies, and thank you so much, Dr. Shahid Noor. Thank you. Thank you all for being a part of this session. Now, members of the SMBBIT, I request you to gather at Hall A for closing ceremony. And to the rest of you, I hope you enjoyed your time at this conference. Thank you so much for coming, and see you next time at Pak Traumacon 2024. Hall A. I've told them Hall A, everybody, you have to make it to Hall A for a closing ceremony. Quick, quick, all of you.